चल रही है क्या? ये वाला हो मोटो का, ये वाला पॉइंट चाहिए। क्या लेने लगा मैं तीसरा वो तो लगा है जो तीन चलो नहीं होगा। हेलो हेलो महादेव सिस्टम। हाँ हाँ लेके आओ बनाना, बनाना लेके आओ। हाँ अभी नहीं किया आज ना है क्या? क्या होगा?
और ये कभी पकड़ रहा है ना, एक चालू रखिए।
तो हम बताओ सब पता है नहीं हुआ। हाँ
नहीं चालू कर, वो लोग करे तो हमको पता नहीं।
उस दिन चालू कर दिया था यार कृष्णा को पता है। कौन है यार? कौन बंद 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 यार रेड जली तबे चली। अरे रेड जली तबे चली। हाँ टिप को खाली टिप पे छोड़ दो। सुनने चालू करा साउंड के लिए अच्छा कर जाए सिस्टम को पीछे साउंड ऐसा उस दिन बोल रहा ये ऑप्शन नहीं बना रहा। अच्छा कुछ भी नहीं चालू करा साउंड के लिए जैसे पीटीटी वगैरह करता है तो आवाज कैसे मान लीजिए वीडियो आवाज उसके लिए आप चालू
Can I
पॉइंट
presentation?
ओके कौन सा है कौन सा
वैसे ऊपर भी
Next, I would like to name them Sir Reggie White or Philadelphia Eagles. Next, Sir Tony Dossett, and later on when obstetrics. So, shared out and awareness about the sleep health. Sir Aaron Taylor, he also developed early middle age obstetrics. Next, Sir Ja Marcus Fussell, he also developed retirement age. So, among all these studies, only they found out early middle age retired NFL high sleep apnea is compared to and were similar. Obstetric sleep apnea has some similar community, whereas the clinical assessment, it is quite similar. So, definitions to national football players, though it is very studies, one of study by Hanan et al. It found out that about 120 NSL players half played linemen and again linemen a person with after 1 to 30 retirement moves and OSA as well as hypertension. Study by Albiq et al. They found out retired NFL players sleep disordered breathing present in 0.3%, whereas defensive linemen were more likely to have sleep disordered breathing around 60. So again, among these studies also, there are number of limitations such as the persons who are responding to participate of yes, must be responding before or sample size also there out. So that's why correlated to the general population. And one more study by Rice et al. They found out among 157 relevant players. Whereas the previous study were done for the retired NFL players. In these studies, the 137 players from 12 different teams, 100% story. FNI 0.9% and moderate SCV 4.4%. Again, in this study, limitation is SCV is negligible percentage and can be studied the different rates and ethnicity. Change. Finally, in comparison, though their material and methods are different, so this generally see OSS fat, peripheral artery, and the in the fat sleep apnea, mild mild sleep apnea is 22%, whereas moderate 35%, whereas when we then we found out that around 20% no sleep, percent mild sleep apnea, and 20 moderate sleep apnea, and study on the same population. First of all, fat study was done. Then after 3 months, PhD was done, and this was a different. So I would like to about obstetrics. So, yes, thank you.
Fine.
Good morning, sir. Sorry, sir. Sir, sorry, sir. First of all, it is not original study, but I would just compare PH central added. Some of the data, all the data, the number of physical parameters we include, and then showing them that much data not collected in case of that, and it is a study. So there can be missing data from that, but again, sorry, because I don't know the detail of the.
I think Dr.
Right, Mr. Doctor, other.
Next, review this. Technology.
Is very common. Some sorts of very my
Starting
maybe for published paper, saw that article. So on station, the patient are sleeping, later sleeping, for police. It was a small mistake. So would same round filing, developing relations. When I evaluate his sleep schedule was on weekdays, wake up time working people. 20. Sometimes was accessing your experience. So there was no survey complete. Learning was here before of medium sound. Length of time was 10 years. Was not arousal. Worsening patterns were person needs to find position. Previous slide, please. He has here. He used to go 3 times. He complaining about gain about 25 kg. Price study was not done. That was not taken. I evaluated. I am using stop and question. What X factor of OSA? Observe happening. He had my gosh, more than 10 seconds was more than was made. First line in number of years in of OSA. So it was line in this. Next. ISS is so drowsy. He was drowsy by he went in motor vehicle accidents. He used to counter by using cups of issues. RLS evaluation, there was no urge to move at on bedtime at bed. So RLS also. That's not there.
कि इस लैपटॉप उधर क्यों नहीं है?
सेटअप किया
Past medical, no significant medical history except speaking, alcohol, and nicotine, and caffeine. I reviewed all the systems, certain diagnosis, hard one, and veterinary system, where I checked doctor. Yes.
Slide देखिए.
Examination was done. Examination. So was great. Some palace was morning. Yoga was vegan and also non-fat. Yes. That examination, there is no significant. Scientific exam was normal. Sleep disorders and disorder. Stroke very. Primary see it's a good one. Most of the time, this is a study published in the medical they are very consistent. They found because of seed fragmenting. Is the type of mass. Small events. Small events.
राहुल कहाँ है?
Symposium.
बैठने इसका हो जाएगी?
Small events reduce from 12
शिफ्ट करना है इसको।
also reduce from
अच्छा, देखते हैं next week। तो आगे देखो। दे रहा है। ये नहीं कर पाएगा। डाल देते हैं।
पहले हमको नींद नहीं नींद आती थी तो थकाने वाला और के बैठ जाते थे मुस्कान हो जाती गला में कुछ सूख जाता था उसके बाद फिर मुझे पता चला छोटा है हम आए आपसे सबने जांच की तो जांच के बाद एक मशीन हमको सजेस्ट की कुछ करने के बाद हमको इतना कि ये भी बहुत अच्छी आती है गाड़ी चलाते थे सब छोटा तो गाड़ी में ड्राइव बहुत अच्छी तरीके से देखिए बहुत होगा पहला मेरा मेरा नहीं
समझ में आ स्पीकर लेना सब स्टॉप पर कैसे सेटिंग करेंगे
presentation,
इसमें
which will see that you'll be
सेटिंग
करना
है सेटिंग्स
सेटिंग तो लेना
what will the next speaker now.
चलो
What talk about two speakers.
ऑडियो कर रही है
It's from surgery.
सर को सर तो कौन सा
ये देखिए ये सेक्टर
जो ना अच्छा ये
Yes. Slide. Hello. Start करते हैं.
हेलो
Slide.
वो है ना एंटर वहाँ पे
First of all, share and like side by side. CMEs, with the chance to use most generally one work like this is on the yes or no? No. Is it? Why? Why? Okay. I don't chance.
स्टेज प्लेस सर
Super. Now, consistency should be visible. Others. Only one. Only one.
गिविंग ठीक है
That's fine. Next one over so yes. Anyone?
अच्छा
Now, what is the practice come into our mind? This is only one small part. The screen is only one small part. A scheduled work time. But since what we the screen came into our office, our officials, our employees, us to 7 workers. Yes or no? Is going to 7? इसको बोला
लगा दे रहे
put off. Because we have to now, 60 minutes,
चार्जर
and what is the reason? Because the blue light is medium. And the more important part over here.
आपने नहीं कहा
This is what I have told the madam has said all men. And say what essay to
जी सर हाँ
उसके बाद there was an exam that has been introduced by Britishers in India. That brings us to then lunch. Yes. क्या बोलते हैं ना? Squarely. Right. That is all. Take the things right now. For her life. The solution is it is for her life. इससे मतलब है बहुत सारा हिंदी में सीखना है
चार्जर
Focus how you are focused. Five. Standing at ISSEMCON. Now, what is of or why this longer seat is needed for our athletes all for our solutions. Studies. With good sleep, there is increase of muscles. Okay, why? One is I spent once because in daytime we undergo cellular damage. Sleep is a balance in cellular. Other is skill learning is going to sharpen the skills and also helps a person understand and make the skills get better. Next one is skill learning. Memories. Also about functional training or teaching, person can memorize. Next, स्पोर्ट्स में क्या होता है सिस्टम रियल टाइम decisions. So it is function. Also helps in both of us. Don't have more difference on maximum sports in the game. Next, what is going to result? Going to result. Okay, then. So this is the importance of sleep. Is of sports and with this.
स्कूल का भर दीजिए मैं सेटिंग कर देता हूँ उसको पुडिंग लगा दीजिए
He was before. I'll just forget.
Yeah, basically it's a combination of different topics.
कॉफी कर दीजिए तो बंद करना इसको
I fixed your dog. Putting the details over there, as Madam has said, it's just a part of a small relaxation. Okay. What? Is everyone that programs all this and what is the time duration that is required got a regeneration of the neuroplasticity. Okay, okay. So, molecule in a particular level of the cell needs time to regenerate. C is the issue. Talking about 20 years. I'm talking about 8 to 10 hours. This is the time duration that we require in our body to regenerate neuroplasticity. Okay. That's why we see the power level training is required. It may be required also. Right?
It answers this question.
Yes.
How does the power nap?
Yeah.
How about
Banaras, muscular relaxation. And the psychological relaxation is vaccines. What happens, the question what I said over here is that concern. There is a great advances. The duration of sleep is yes or no? Oh. And the other part of it, when a person wakes up during night time for duration or any other temporal points, what happens? See, I mean, have the last slide, the second last slide of my presentation. It has been studied by major researchers that that's advances. That's not duration difference. That's the that's the is something involved. How simulating is okay. Then maybe about 50. It's about 4 to 6. The other news about us that when the person wakes up from the middle of the night.
Look presented.
Suppose sample we are talking plus we will add selenium, process and what happens over here if you have those yachts and balls, then if you wake up in the county, you have more episodes for waking up in the night. The daytime, when you wake up, you will not first there is what we can say, the other neuromas, like sleep, like vigorous.
Okay, thank you. I think we'll call it the please. You can carry on your discussion. You carry on the discussion during
Yes,
the
yes.
I think
My pleasure.
we have over some time.
There is,
I think Dr. Amita.
it's not for.
Yeah, I request the chairperson to kindly give his concluding remark.
Think in this conference on sports and exercise medicine, sleep is an important component for general health as well as for sporting performance. That's knowledge that is well known and really beyond debate. And an exposition on the importance of sleep medicine was needed and that's been provided by the state. I think sports medicine specialists or sports medicine practitioners would agree that they must work closely with sleep medicine for the betterment of their athletes, the sports persons and their performance.
Yeah, thank you, sir. And thank you to all our esteemed speakers for the valuable presentation. Your expertise and insights have greatly enriched today's session, and we are grateful for the knowledge you have shared with us. And I would like to thank the chairperson for guiding this session. Your insights and support have enriched today's discussion, and we appreciate your contribution, sir. Now, as a token of gratitude, I invite our chairperson to kindly present a memento to our esteemed speakers. Professor Amit Khan, sir. Professor Anamika Singh, kindly come to the dais. Dr. Minali Mirdha, AIIMS Varinda, kindly come to the dais. And I would like to pay my respect to the chairperson by presenting him a memento. Now we are proceeding to our next session. The topic of the session is Yoga for Lifestyle Management and Stress-Free Living among Gen Z students, balancing these scales. It's a symposium and our speakers are Dr. Anumeha Bhagat from GMC Chandigarh, Professor Seema Singh from ERA Medical College, Lucknow, Professor Jyoti Dwivedi from HIMS, Dehradun. And I would like to invite Dr. Satish Dipankar from AIIMS. He's additional professor, AIIMS Mangalagiri, to kindly chair the session. Yeah. Yes. Yeah, so along with Dr. Anumeha Bhagat, Professor Seema Singh, and Professor Jyoti Dwivedi, we have Dr. Archana also with us in this symposium. So I would like to invite all the esteemed speakers to deliver their talk on this topic. Thank you so much.
So, very good morning to all the audience present in the crowd. And before I start my presentation, I would like to thank the organizers also for giving us this platform to share our experiences on how stress and physical inactivity and other parameters can affect the lifestyle of an individual. And then, I begin my presentation by first talking about ओके कर दे इसको शेयर एप्लीकेशन वो नहीं रहा ना नहीं There are some technical glitches. They'll take 1 minute and then I'll continue with the presentation. Yes, sir. Okay, so back कहाँ से जाएंगे? ठीक है. So I will be talking about be giving some scientific evidence of tackling stress and lifestyle disorders among the Gen Z students with yoga. And then after the scientific evidence, Dr. Jyoti Dwivedi will take you through a 61-point relaxation technique. So we will try to blend the science with the experiential experience of practicing yoga for a healthy lifestyle. And then Dr. Seema will again give a very interesting demonstration of the chair yoga and the Chandra Namaskar through a pre-recorded video. So beginning my presentation today, so let me take you through the outline of my presentation first. I will be talking about what these Gen Z students are and why stress is so prevalent and so rampant in these students. And then we will talk about various other issues which may be created because of stress. That is the issue of metabolic syndrome, the non-alcoholic fatty liver disease, and the physical inactivity, all of these which lead to a host of lifestyle disorders. And then I will take you through a few of my studies in which we will talk about the feasibility of developing a Raj Yoga meditation program for these Gen Z students, and then what are the implications of developing that program. So let us look at generational categorizations. First. So we belong to different generations. We all are aware of that. So people born between 1946 to 1964 are said to be the baby boomers, and currently they are of the age of 59 to 77. So we go on from the baby boomers to the Gen Y, the Gen, and then finally to the Gen Z. So why are we so concerned here in today's symposium about the Gen Z? Because these are the current group of students whom we are handling each day. And although this generation is categorized by being very digital savvy, tech savvy, they have been exposed to YouTube and all the online and digital platforms through their schooling days. So now they are very experts. They are experts at handling the technology. But I feel that they are not so good and so adept at handling their own mental health as well as physical health. And therefore, that leads to creation of a certain age and a stage of stress. So why are we talking about this generation and we are trying to correlate it with the stress? Because let us give me some of a historical background. There was million of years ago, there was the Stone Age. Stone Age was characterized by the stone being important in that generation because it was used for developing flames, for lighting the fire, for making spearheads and arrowheads, for killing animals, for generating food, and then also for sculpting for relaxation techniques. From the Stone Age, we went to the Iron Age, where iron became predominant. Then the age of reason and philosophy developed. And from there, the dropping of the atomic bombs at Hiroshima and Nagasaki came the atomic age. Now, in the post-atomic dust, the thing was that there was a lot of stress and anxiety among the survivors of those of that time, that when the next atomic bomb might be dropped on them. So that led to the creation of this age of stress and anxiety, which is continuing till now, and we are having more and more events which is creating the increase in stress in our times, in the present times as well, which is affecting the Gen Z. Now, along with this, age of stress also developed and began the age of belief in scientific reasoning and thinking. People started thinking that with the dropping of atomic bombs, it was a scientific thing that led to the development of the atomic bomb, and now science could only help in giving a solution to the relief of stress and anxiety in their age. So then from here, I will start talking about the burden of the stress, anxiety, and depression in the global context first. So this figure is representing a systematic, this has been drawn from several systematic reviews and meta-analysis. So the first one by Kochaki et al. Mentioned that the global stress levels in the medical students was 32.5% prevalence. And then came the review of Rotenstein et al. In 43 countries, from which they showed that the global prevalence of depression in almost 143 studies conducted in 43 countries was 27.2%. From there, Kutila et al. In 2016 did a systematic review of medical students in Asia, and then very high level of anxiety in Asian students. And then Sarkar et al. Did a systematic review in 2017 showing that the global levels, that the levels of depression, anxiety, and stress were still higher in the Indian population. So this led to survey on medical students of phase 1, where we noticed that when we use the general health questionnaire for estimating the prevalence of risk of mental disorders, namely mood and anxiety disorders in these students, we found that there was a very high percentage in our students as well. So why are we allowing, we are all very intelligent beings, why are we allowing stress to affect us? Because we know that all of us are aware of this eustress phenomena, that there is a certain increase in performance as the stress levels increase. But beyond that, we may land into chronic stress. So chronic stress will lead to exhaustion. It will lead to entering the individual into a panic zone, and then finally breakdown and burnout. So do we know where this tipping point is from eustress to distress or chronic stress? We are not very sure where a performance will start ebbing, and probably yoga has a meditation component of yoga has a very important role in letting us handle this stress, and I will talk about it in my later slide. So BMG in 2011 gave a definition of health, which is the ability to adapt and self-manage faced with social, physical, and emotional challenges. So as physiologists, we all know very well that whenever there is a stressor, there is a perturbation of the physiological variable, which will come back to its normal. So that is the normal response, change in the variable coming back to normal. But whenever there is extreme of this stressor, which the individual cannot handle, that is termed allostasis. And allostasis, in that the physiological variable varies a lot. It will not come back to its original levels, and probably with meditation we can control. Again, I'll be giving evidence for that. So let us look at the stress response and quickly take you through this. Whenever there is stress, there is activation of the sympathetic system and the activation of the HPA axis. Activation of the sympathetic system is a very immediate response known as the flight or flight response. Also, all physiologists are very aware of it. Increases in BMR, blood pressure, respiratory rate, blood flow to the skeletal muscles will occur. Then with the release of catecholamines, these catecholamines, they cannot pass the blood-brain barrier. However, they affect the locus ceruleus in the brainstem through indirect pathways and can activate the dopamine release in the prefrontal cortex, which will cause changes in the working memory. Then another delayed response is activation of the HPA axis. But these glucocorticoids which are released, they have got these receptors, mineralocorticoid and glucocorticoid receptors in the hippocampus. But whenever there is a high level of cortisol, it binds to these glucocorticoid receptors and thereby helps in terminating the stress response. But then that means when there is a continuous low level of cortisol, it will continuously keep on activating the hippocampal area and cause changes in the long-term memory of that individual. From here, we come into the relationship between the prefrontal cortex, the stress response, and the immune system. So in this diagram, you can, in this flow chart, you can see very well that whenever there is this bed nucleus of stria terminalis is there, and there is a balanced input to the bed nucleus of stria terminalis, there is an inhibitory input from the medial prefrontal cortex, from the cingulate cortex and the prelimbic cortex, and there is an inhibition, there is excitation from the infralimbic cortex. Another thing to note in this flowchart is that the left prefrontal cortex causes the inhibition of the right prefrontal cortex under normal conditions. But so I'll just quickly, these are the different functions of the different areas. So in the normal condition, what happens that when this BNST is getting a normal activation, there is a slightly, the autonomic system is balanced, there is a slight parasympathetic predominance and overall a balanced immune system functioning. But then whenever there is a chronic stress, after chronic stress, we see that what happens is that there is a volume loss, a dendritic atrophy, and decrease in the left to right inhibition. And thereby, there is more inhibition, predominance of inhibition, and that leads to a growth of the dendritic growth in the BNST. Because of this dendritic growth and overactivation of the inhibition of the BNST, what happens that there is increased parasympathetic tone. And then HPA dysfunction. And HPA dysfunction will have several consequences. We all are very aware of that HPA dysfunction will cause reproductive axis dysfunction. It will cause the growth and the thyroid hormone dysfunction, and finally the immune dysfunction. So that is very quickly, I took you through the physiological aspect of how stress is causing all these phenomena. So to summarize, whenever there is chronic stress, it will cause increase in cortisol and other peripheral markers of stress, shift in autonomic tone towards sympathetic hyperactivity, a decrease in the size of the prefrontal cortex, decrease in size of the hippocampus, plus the increase in size of the amygdala. Then stress runs through three stages. There's the Pepto-Bismol stage, the rum and coke stage, and the glass of water stage. In the Pepto-Bismol stage, there will be these physical manifestations of increase in heart rate, respiratory rate, blood sugar levels, blood pressures will vary, changes in the GIT function, emotional disturbances, and muscular problems. But these remain unnoticed, and then the person progresses to the rum and coke stage, which is causing excessive nervousness and behavioral changes. The memory also starts falling in the individuals, and there is a constant worry and anxiety. The person is not able to sleep properly. So from this stage onwards, the things become clinically diagnosed. Clinical diagnosis of hypertension is there, high cholesterol levels, heart diseases, type 2 diabetes, and so many other things which will happen. So now let us take you from here. I will take you through several studies which we did. So in the study on prevalence of metabolic syndrome, now why am I talking of metabolic syndrome here? Because I want to connect that these lifestyle disorders, a precursor of these is the metabolic syndrome. So we found a high prevalence of metabolic syndrome in our studies, 18.3, and these were students between the age of 18 to 25 years. And in 612 students, we did the study. Then we also found that the parental history is positively correlated, and with BMI also the prevalence increasing BMI. So from this study, next we went to do another prevalence study for NAFLD in the same type of population, but different students. So we found that the prevalence of NAFLD, which is a sequelae of the metabolic syndrome, is again high, 12.7% in this group of students. From here, then we again conducted another study in which we tried to look at the physical activity levels of these students, and we found that many students in this generation were sedentary or physically inactive, and the preponderance of male versus, if we check the male versus female data, then we saw that males were highly significantly more active than females, which is very logical also. We know well aware of that, and their sitting time in the average sitting was more in females. So now from all these studies, then what we thought that we wanted to see whether meditation could, it is feasible to conduct a Raj Yoga meditation program. So we did a 1-month intervention project for that, and we did a supervised Raj Yoga meditation program for the students, and we assessed the feasibility using the REAIM framework. Now the REAIM framework is the acronym for the reach, effectiveness, adoption, implementation, and maintenance of any intervention that we do. So we saw that reach was manifest by 90.4% expressing their interest in participation. For this, we took 2 batches of MBBS, and from them we asked their interest in participation. From them we selected 40-40 each, so there was around 47% adoption of our Raj Yoga program. Effectiveness was checked by 3 parameters: the general health questionnaire, the MSSQ, the medical student stressor questionnaire, and also a qualitative analysis, in which we found that the mean GHQ scores of these students were significantly high before the intervention, and after the intervention we found that the scores in these individuals decreased, and there was also a decrease in the interpersonal and the social stress related scores of these individuals. So we saw yet that it is feasible to conduct a supervised Raj Yoga meditation program for this Gen Z group of students, and we also did some qualitative analysis from which there was this outcome that there was a positive effect of meditation. The students were able to practice the meditation and also could identify which is the stressor which is causing the stressor which is leading to their stress, and they also even acknowledged their fickleness of mind. From this qualitative analysis we found out implementation by a daily record of the attendance that we are doing. Maintenance we cannot comment on because it was a short-term 1-month Raj Yoga meditation study. We also did another study in which we used the examination stress as a model for acute stress for these medical students and evaluated the autonomic changes. So from the conclusion of that study was that when the students are not meditating, there is examination stress. Under those conditions, the systolic blood pressure, diastolic, and all cardiovascular and autonomic parameters increased, as is shown here in this flow chart. And when the student practices Raj Yoga meditation during that examination stress period, there is significant decrease in the diastolic blood pressure, no changes in the systolic blood pressure, but some parameters of autonomic HRV also change. However, there is increase in many parameters of HRV and baroreflex sensitivity, which are markers of the improved autonomic tone. So we can easily say that conducting a Raj Yoga meditation program is feasible, and it causes a decrease in the autonomic and the cardiovascular parameters of these individuals who are practicing it. We are not saying that. Other studies are also saying that meditation causes decrease in cortisol. This is a result of the 45 RCTs which were conducted, and it evaluated the effect of all types of meditations on parameters like blood pressure, heart rate, triglycerides, and concluded that in a range of populations, meditation techniques are effective. Then I have more data to have a scientific confirmation of the findings that we had. But let me come to the last part because the time I have already exceeded the time. So we can say that scientifically proven benefits of meditation on diminishing stress are that there's a decrease in the cortisol levels, which is a peripheral marker of stress, shift in the autonomic tone towards parasympathetic predominance, increase in the size of the prefrontal cortex in the hippocampus, as well as decrease in the size of the amygdala. So this is just quite the opposite of what was happening during stress, and now with meditation that has helped. So I've already been summarizing my presentation. So with this conclusion, I call upon Dr. Jyoti to carry forward with her 61-point relaxation technique. Thank you.
अब मैं उनको बुलाऊंगा बच्चों को जोड़ती हूँ।
So I would like to invite Dr. Archana Gyuntial, Professor KGMU, to join us as the second chairperson. Please join us. And over to Professor Jyoti Dwivedi for the second presentation of the symposium. And please join.
Thank you very much. कौन सा आपका ना? इसी में चल रहा था इसी में आ गई है, हाँ, इसी में आ- तब तक मैं- इसमें आगे चलो, आगे चलो, तो सब कुछ तरह का बनाता है विशेष है। आगे चलो। हाँ वो पॉइंटर एक्चुअली ही डिडंट नो ना, तो उसने बीच में बंद कर दिया। आगे चलो। इसी के बाद ठीक है, मैं
Facebook तो बहुत ही लगेगा।
हाँ,
Slides, इसमें दिख ही नहीं रहा।
मैं कर देती Since there was a little disturbance, so let me start my presentation at a very relaxing note, क्योंकि मेरा presentation ही relaxation पे है। चिदानंद रूपा शिवोहम शिवोहम। Respected dignitaries, seniors, faculty members, and all others present in the hall. The human body's highest of all shrines and the inner dweller Atma symbolizes the Supreme. Let's work on this highest and most precious body, most precious shrine, the human body. This picture depicts the hand of a modern day man. Why? All the conditions of a modern day man are precipitated by the enormous mental stress he undergoes. So, whatever is the modern medical diagnosis, the basic disease is stress. Ladies and gentlemen, aging is inevitable. We all have to age, but stress carries us faster towards the end. I am Dr. Jyoti Dwivedi from Himalayan Institute of Medical Sciences. हिमालय से बनारस तक आई हूँ। कार्तिक पूर्णिमा के दिन गंगा से गंगा तक। I'm here to present in front of you something called as sleepless sleep or 61-point relaxation. The advanced form of that is Yog Nidra. The continuous stress of mind and the absence of physical eustress describes Gen Z. Physiologists and physicians now believe that mind influences the body in a profound manner. External stressors directly affect the hypothalamic pituitary axis, leading to disturbance of the endocrine system, the ANS, also the somatic system, resulting in something we called as disease, which is the end organ or the target organ system is affected. A brief bout of anger can ignite the whole neuroendocrine system. Not only a stress produced by anger, even other extremes like depression, loneliness, all these things are negativities, are the causative agents of lifestyle diseases. So, how to address such problems which do not even have a proper diagnosis in modern medical science? Swami Ram of our institute used to say that 70 to 80% diseases are psychosomatic, where the fundamental cause is the stress in mind affecting the body. Looking at the frustrating scenario, it is accepted by physicians all over the world that modern medical science is unable to treat many ailments, and in despair, non-responding patients are often asked to change their lifestyle. A survey conducted recently by Bandolier reports that 82% of heart attacks and 74% of strokes are preventable by having a good lifestyle. And intensive lifestyle changes lead to regression of coronary atherosclerosis after 1 year, which has been stated by the lifestyle heart trial of USA. So what the West calls as good lifestyle, we the proud ancient Indians, we call it the art of yogis. Yoga is an ancient science, and fortunately, extensive global research has been now done on this. A yogic lifestyle is the best lifestyle ever devised by mankind. Yoga karmasu kaushalam. Yog hi karmo mein kushalta hai. It's a way of life. And what is a dictum? Rigved कहता है, let body be the body's cure. Within our personality lies the cure for all the ills suffered by this personality. The enemy is within, the healer is within. So which practices can keep us healthy and disease-free? Let's see. Practices that work on body and mind, yogasanas, various relaxation techniques, that work on breath and mind, various pranayam, that work on mind and eventually the whole physical and energy body meditation. Yoga is just not tying yourself into knots. It's the basic preparation of deeper yogic practices. They are the stretches and held postures alternated with relaxations that allow the mind and body to be fully coordinated. Voluntary breathing exercise are shown to bring the autonomic nervous system under control through vagus nerve activity. Swami Ram has rightly said that breath is the portal for the control of uncontrollable, that is the autonomic nervous system and the mind. The components of breath, the inhalation and exhalation, reflect and stimulate the sympathetic and the parasympathetic nervous systems respectively. The respiration, as we physiologists all know, that it enjoys the duality of being involuntary, which can be made voluntary. Can I grab your attention, ladies and gentlemen? If the mind is disturbed, the breath will be disturbed. And if the breath is made calm, the mind automatically becomes calm. Incorporating breathing techniques makes the relaxation effective. Innumerable relaxation techniques are cited in ancient yogic scriptures, and now the relaxation response is very well known to the Western world. Systemic and progressive relaxation, the Shavasana, is the simplest and the least time-consuming technique among all these, which involves muscles, breath, joints, nervous system, and the mind. Another well-established technique of Hatha Yoga is Shav Yatra, or traveling through your own corpse. Shav Yatra, traveling through your own corpse. Now, the Swami Ram of our institute, he modified this Shav Yatra for the sake of Westerners to understand and to focus on certain points which make the relaxation deeper and deeper. So here, this Shavyatra now becomes 61-point relaxation technique where you pay attention to the specific key points in the body. These are some nodal points, energy points. Calm them down respectively one by one, and the whole body is completely relaxed. I have an audio also, but if this was a workshop, I would have played that audio and all of you would have gone into deeper relaxation very easily. But then it will take at least 10 minutes. So I will just tell you how the 61-point relaxation is done. These are the key points. These are the key points. When you start your 61-point relaxation, you first focus on your breath. You lie down ideally. You can also do it while sitting. You have to focus on your breath. If you're sitting, you have to sit with your trunk and neck straight and close your eyes. You have to remember that you should not fall asleep. It is a sleepless sleep. You should not fall asleep. Mostly people who do the 61-point relaxation start snoring in few seconds. So you have to again and again make yourself aware that you can't sleep. Otherwise, it will not relax you. Otherwise, you'll go into a dreaming state or something like that. And your blood pressure also may increase rather than falling. So to start with, Srinivas. So to start with, you concentrate on a point between your eyebrows. With your eyes closed, imagine a cool blue light which is there in between your eyebrows. And then, as the instructor tells you, or if you are doing a guided meditation, or if you are if you have practice, then you can do it on your own. But take this cool blue light from the center of your eyebrows to this place, the center of the throat. That is point number 2. So there are 61 points like this. Point number 1, center of the eyebrows. Point number 2, center of the throat. Point number 3, tip of the right shoulder. Just keep on imagining this cool blue light transferring from one point to the other, and each portion, each point is getting deeper and deeper relaxation. So point number 4 is the center of the elbow, right elbow. Point number 5, the center of the right wrist. Point number 6, the tip of the thumb. Point number 7, the tip of the index finger. Point number 8, the tip of the middle finger. Point number 9, tip of the ring finger. Point number 10, tip of the little finger. Then you go back. Then you go back to point number, the center of the right wrist, center of the right elbow, center of the tip of the right shoulder, then back to the throat. Similarly, you will repeat these points as written in this picture. If I had more time, I would have taken you into this relaxation. But since the time is less, so we'll proceed. So this is what is 61 points. We've done a massive, not massive, but a small research on 61 points in our department also there. And we've seen a lot of parameters, physiological parameters, which have shown statistically significant results. So since the time is less, I'm not going into the details of this. This is just a biofeedback which is showing when the subject is going through 61 points, the music is more. 61 point relaxation करते करते फिर biofeedback के उसमें दिखाया. No, this music is not part of the relaxation. Yeah, so we worked on premenstrual syndrome. Since I'm also a gynecologist, before I turned into a physiologist, I started working on all those diseases and how does the 61 point affect. So we saw statistically significant results with 61 point, and this was also authenticated by the Association of Physiologists and Pharmacologists of India. So this is relaxation through Yoga Nidra, or the practice of sleepless sleep. I would just sum up by saying that you should take a health capsule every day where you have a combination of holistic diet, simple yogic postures, pranayam, relaxation, 61 point, along with the treatment offered by the modern medicine if required. So do not wait for the miracles. You are the miracle. Let this knowledge not be veiled in the dust of times. अटल बिहारी वाजपेयी ने कहा था, मैं अखिल विश्व का गुरु महान, देता विद्या का अमर दान, मैंने दिखलाया मुक्ति मार्ग, मैंने सिखलाया ब्रह्म ज्ञान, मेरे वेदों का ज्ञान प्रखर, मेरे वेदों की ज्योति अमर. Thank you, BHU. Thank you, Banaras. Thank you, Dr. Barun, Dr. Anumeha, Dr. Seema, everyone. Thank you, all the respected faculty members sitting over here. 61 point, if done properly, will take 10 minutes. 10 minutes. But if you have even less than 10 minutes to do, if you're sitting on a chair, you can do half of this, 31 points. It also gives good results. We've seen that. The best time to do this is all the time, anytime. And as I said that people also fall asleep while doing 61 point. तो जैसे अभी गुड स्लीप हैबिट्स की आदत की बातें की जा रही थी, अगर अच्छी स्लीप नींद के लिए भी पहले 61 पॉइंट करके एंड देन यू कैन गो टू स्लीप. We use normal physiological parameters as well as like blood pressure, temperature, EDG, EMG, all those things which are seen in a biofeedback, HRV, and cortisol, and all other parameters. Yes. You would. I have an audio. If you want, I can give you an audio, because all you require is an audio. You can play the audio and you can do it under guided. Even if you are doing it well, even one practice of 61 point relaxation can bring down your blood pressure, can make your breath smooth, regular, all these things. So you can imagine if you're doing it for 1 month, you will really, if you're having hypertension or something, you can bring down your blood pressure with minimum of medications. I would say, I would not say that it will remove your medications, but your medication can also reduce. Yes. Namaskar, sir. I'm honored that you're sitting in front of my presentation.
Thank you for the opportunity. I'm really confused. I don't get access to your mark. So this will it's often it's all different way about that. Second thing, the from 1 person you go, you would say the 16 point will give you the best experience. That will come down in any case if I say call. But that doesn't make sense. So let's see, is it an overplay? Single point will bring your hypertension. That's 2 points. How different scientifically. And so the question from your how long will it treat the disease? Effective way, different patient quantity. It is reliable, repeatable, eventually biggest one. Okay, breakfast point like
we can get better response to a live distribution. Change the human physiology is strong. But for example, we how do we bring biofeedback into this? It's 61 point. Biofeedback is suddenly getting it is 61 point has eliminated biofeedback then by body or it's a separate zone. Fourth point, I'm seeing the data, careful data, the deep value situation. You have said to believe me that we are not 25 years annually. But careful data and the values. I'm overloaded for questions and make
I knew some good questions are going to come up from sir. So first thing is, sir, 61 point relaxation is much different from Shavasana. In Shavasana is also done in various ways where you do your progressive relaxation one by one by one. But the yogis have learned this Shav Yatra traveling through your own corpse. They say it is as good as mentally scanning each and every part of your body and healing it. Because there may not be many scientific data on this, but since I live in an institute where I also interact with many yogis and many other people who are doing it regularly, someone who is there in dialysis as dialysis in charge in our unit, he says that he had a frozen shoulder and he kept on doing 61 point. While doing 61 points, he used to get stuck there even before the frozen shoulder was diagnosed. And after some time, he said that they diagnosed this shoulder as stiff and then finally it became frozen. And then he kept on doing 61 point and mentally scanning and asking the place to get relaxed, to relax, to relax. So, what Swami Ram has devised, why he has devised this, he says there are certain nodal points in the body. As we said that there are षट chakras. तो ये षट चक्र से अलग है, ये नोडल स्कैन्स हैं, बहुत सारी नाड़ियां हैं शरीर में. Okay, I know that I know I've taken a lot of time. Okay.
Good morning, everyone. So in today's session, I will be talking about the chair pose yoga and Chandra Namaskar. For our Gen Z generation, इसको बस यहाँ से करना है. हाँ यही है. ठीक है नहीं हम कर देंगे. So before doing this, playing this video, I would like to discuss physiology of yoga. So yoga have effect on the cardiovascular health. It helps to improve the blood flow, heart rate, which can lower the risk of heart disease. In respiratory system, breathing exercises can improve the lung function and elevate the symptoms of respiratory condition like asthma. In nervous system, yoga helps to reduce the stress and promote the relaxation by stimulating the parasympathetic nervous system. And in muscles and bone health, yoga helps to maintain the strength, flexibility, and balance while also reducing the risk of injury and disease related to the bones and joints. Physiological response to stress, very beautifully Dr. Anumeha discussed and Jyoti ma'am also discussing this about the stressor. So physical, mental, emotional, environmental stresses have lots of effect. They have acute and chronic response. So this yoga intervention pathway for short term and long term, they activate the fibrolytic, they improve the fibrolytic profile, decrease oxidative stress, increase the endothelial function, and reduce the risk for the atherosclerosis, hypertension, cardiovascular diseases, etc. So in this, I'm going to discuss about the neurotransmitter affected by the yoga. Yoga is widely recognized for its physical and mental benefits, but did you know that it can also have a profound impact on the delicate balance of the neurotransmitters in the brain? These chemical messengers play a crucial role in regulating our mood, cognition, and overall well-being. This comprehensive guide will be explored the key neurotransmitter affected by the practice of the yoga and how they contribute to improve the mental health overall well-being. So yoga affects the neurotransmitter level. It reduces the stress. It has been shown that reduce the level of cortisol, the primary stress hormone, can have a positive impact on the level of the other neurotransmitter. Mindfulness and relaxation, the practice of yoga with its emphasis on the deep breathing, meditation, and present the movement awareness can increase the production of the feel-good neurotransmitter like serotonin and dopamine. Physical activity, physical postures and movement in yoga can trigger the release of endorphin, which are the natural painkiller and mood booster. Now, the feel-good neurotransmitter serotonin is often referred to as the feel-good neurotransmitter as it plays a crucial role in regulating the mood, happiness, and overall well-being. And sleep and appetite. Serotonin also influences the regulation of the sleep appetite and other essentially bodily function, contributing to the sense of balancing and stability. So yoga's impact shown to increase the serotonin level, which can lead to reduce the symptoms of depression and anxiety and improve the mood and enhance the feeling of the calm and contentment. Next is dopamine, which is the reward neurotransmitter, is often neurotransmitter. It play a crucial role in regulating the motivation, goal setting, and feeling of the pleasure and satisfaction. Goal-oriented behavior dopamine help us focus on the achieve our goal as it reinforce the behavior that lead to reward and pleasurable experience. Yoga's impact has been shown to increase the dopamine level, which can lead to improve the mood, enhance the motivation, and greater sense of the accomplishment and well-being. Next is GABA, which is known as the calming neurotransmitter. It helps in anxiety reduction. GABA is an inhibitory neurotransmitter that helps reduce the neural excitability, leading to a calming effect on the brain and body. Stress management, increasing the GABA level. Yoga can help meditate to negative effects of stress, promoting the greater sense of relaxation and well-being. GABA also have a role in sleep regulation. It plays a crucial role in regulating the sleep cycle, making it easier to fall and stay asleep, which is essential for overall health. Next neurotransmitter is endorphin, which have role in pain relief, referred as the body's natural painkiller, as they can help reduce the perception of the pain and discomfort, helps in regulate the appetite, enhance the immune system. Now come to the equipoise, which is the state of balance or equilibrium through the yoga. In today's fast-paced and stressful world, finding the inner balance and calmness can seem like a elusive goal. By incorporating the careful selected asanas, which is known as the postures, and pranayama or breath control techniques into our daily lives, we can cultivate a deep sense of equipoise. In yoga, equipoise can refer to the state of being present and connected by your own goodness and goodness of others. Importance of equipoise. It is crucial for navigating the complexities of modern life, allows us to respond to life's ups and downs with greater clarity, resilience, and emotional intelligence. benefits. By achieving a state of equipoise, we can experience reduced stress and anxiety, improve the decision making, enhanced relationship, and greater sense of overall well-being. So, role of yoga with its focus on the physical, mental, and spiritual integration offers a powerful pathway to cultivating the equipoise and maintaining the balance of our lives. Asana practice. So carefully selected yoga posture or asana can help to calm the mind, reduce physical tension, and promote a sense of grounding central awareness. Pranayama techniques, practice of breathing control, can help to regulate the autonomic nervous system, lower the heart rate and blood pressure, and induce the state of relaxation and focus. Uh, Mindfulness and meditation deepen the experience of inner calm and equipoise, allowing us to immerse ourselves in the present movement. So, transforming benefits of yoga is reduce stress and anxiety, improve the physical health, increase the mindfulness, and enhance the emotional intelligence. So, conclusion is harnessing the power of yoga. By understanding the profound impact of yoga on the delicate balance of neurotransmitter, we can harness the power of this ancient practice to enhance our mental health and overall well-being. So, incorporating yoga into your lifestyle can be transformative and holistic approach to optimizing your brain chemistry and nurturing your mental and the physical health. Now, I would like to play a small video for chair pose yoga asanas.
योगा कर सकते हैं, चेयर पे कर सकते हैं, अच्छे रहेंगे।
This is the neck movement.
ये सांस को भरते हुए, सांस को भरते हुए, सांस को छोड़ते हुए, yes, and stretch. इसके बाद आंखों की क्रिया करेंगे, this stretch, धीरे करो, आसान है, पूरी को सर से पैरालिश, सांस को भरते हुए मुट्ठी को बंद करिए, और करिए, सांस को छोड़ते हुए मुट्ठी को नीचे, yes, let's see a particular silence. इसी दूसरी क्रिया है एक आपको क्रिया के सपोर्ट में नेगोशिएशन में बैठ के रहता है दूसरे तरह से सपोर्ट इसी तरह के
Okay. So there is these poses for upper extremity and lower extremities. And okay. So these stretching exercise for the upper extremity. So fast pause. फास्ट कर दीजिए हाँ कैसे करते हैं हो सकता है वहां for spinal strengthening. फास्ट नहीं कर सकते
गैप करने के बाद जिनको खाने के उनको बैठ इस तरह से साइड चेंज कर such as the
Okay. So next is Chandra Namaskar demonstration. इसको प्लीज एक मिनट इसको कर दीजिए. Just a minute, ma'am. इसको जो चलिए आइए कैसे बंद हो गया है. इससे पहले हाँ ये डेमोन्स्ट्रेशन चंद्र नमस्कार.
नमस्कार नमस्कार का अभ्यास स्टार्ट कर रहे हैं.
There is a few steps related to this Chandra Namaskar. We will start this Chandra Namaskar from.
Ma'am, give your concluding remarks. Yeah.
तो इसको स्टॉप कर दीजिए.
नमस्कार की
So this Chandra Namaskar do under the following steps. First step is Ardha Chandra Asan, then Dev Asan, Trikona Asan, Parsuttan Asan, Anjaneya Asan, Skand Asan, Ardhamal Asan, Mal Asan. After that, we will repeat in the other pose Skand Asan, Anjaneya Asan, and Parsuttan Asan, Trikona Asan, Dev Asan. After that, we will conclude in this the Ardha Chandra Asan. So there is a one cycle, there is a two cycle for the Chandra Namaskar. First, we will complete in right side these asanas. After that, we will complete the another left side. Thank you. Thank you.
questions and queries will be discussed during the Q&A.
Assisting us to give extra revenue we have. So these are the them. Yeah. So just really third hand about this. These are the voice. It's not sitting on the chair. When we take time, but we take time also we can follow those.
Yes, we can do anytime.
You can still sit down, make pain back. Study. We discuss it.
Yeah, thanks to all the speakers and thanks to the chairpersons. Now I shall request our chairperson to kindly present memento to our esteemed speakers. I shall request Dr. Satish Dipankar to kindly present memento to Dr. Anumeha Bhagat. I shall request Dr. Archana Gildia to kindly present memento to Dr. Professor Seema Singh. And Professor Jyoti Dwivedi. So it's an honor for me to present memento to our esteemed chairpersons. So may I request Professor K.K. Deepak sir to kindly present memento to our chairpersons? Sir, please stay with us because we have our next symposium entitled Physiology of Altered Gravity. And we have with us Professor K.K. Deepak, visiting professor, IIT Delhi, ex-head Physiology Department, AIMS New Delhi, and Dr. Arnab Das, RKB, MBRI Howrah, as the presenters. And we have, I would like to invite Professor G.L. Khanna to kindly chair the session. Professor G.L. Khanna is Pro Vice Chancellor, Manav Rachna International Institute of Research and Studies, and Vice President, BRICS Council of Exercise and Sports Science, Executive Body Member, Asian Council of Exercise and Sports Science. Thank you, sir. So over to you, sir, now.
Thank you. So, I think now good morning. I'm very happy to be here in Udupa Hall. In 2002, I received Udupa Memorial Ovation Award in BHU. So happy to come back, number one. Yeah. So, and thank you, IMS and the board for organizing, and I can see so many colleagues here. Yeah. So with this, 20 minutes is too short to give but I'll try to justify this thing. The topic we chose with Arnav, my organizer, in fact, not organizer for this, and he approached me, and I'm so happy that, okay, let's do it and give a twist and do some science. In a conference, we should do science, bring data. Without data or opinion, can get opinion from anywhere. From ashram, you can get opinion. As a scientist on this platform, bring data and give data and discuss data. That's what the science is about. So that's what I would encourage people. So the topic is a little difficult for me to visual interaction during. Okay, now, okay. So the story starts somewhere long back in 1992 in Bangalore. I presented one blood pressure simulation model, and APPI conference, I organized it. So that was the one achievement which we did. That model was later used by NASA. I got an award from there, Devas Bajaj Prize for Innovation. After that, I was fascinated by microgravity and other gravity situation because we're working on autonomic nervous system, and we thought microgravity is actually a big stimulus for changing autonomic profile and can be used as a therapeutic or intervention. So we got that pro-gravity body here designed for changing, for creating a gravitational loading in space. But it can be done on Earth also for sports sciences. Suppose you are lying and I want you feel like standing when you are lying. You can load the 20 kg, 30 kg, 40 kg, and so on and so forth. So it has an Earth application. Then we also filed 2 more patents. I'll not discuss today. Controlled artificial gravity generating bed. This is the number. You can go and read the details of this. Also, a controlled push-up exercise device for astronauts. Using the same principle, if I load myself in microgravity when there's no gravity, I can have a different type of devices, whether I'm lying on bed or doing push-up. If I want to do push-up in space, my body weight is not there, so how can I do push? I have to create that kind of push-up, giving that. So these are the patent which we've been filed, and all this information is already available. And so that's good. This is the model presented in Bangalore, a simple device which can generate blood pressure, a pulsatile blood pressure. You can see the blood pressure. If I have a pointer, I can show, you can get. So the limitation was I could create beats per minute, because that was the frequency. I could create 60 beats per minute because that was the frequency limitation of dog respiratory pump. I used dog respiratory pump to do that. So that's what the good point was that it's okay. If it works, fine, otherwise, no problem. Don't worry, don't disturb. Now, this is the device on the left side. This has been published in IGPP journal, and Dr. Buchanan happened to be there, and we actually edited and made it beautiful. This thing. Look on the right side, the same device NASA picks up, which means NASA is reading IGPP. How does NASA know that it's been published in IGPP project in Bangalore that time? And they make miniaturized version, a small version of the same. They were interested how my blood pressure will oscillate in space. Make device, put LVPP in the same device, and they fly on a low Earth orbit flight, which goes and then see within second how it is behave. They were interested how my wall is behaving. Because gravity is not there. Is my wall endothelial and other the vessel wall is oscillating with the same, and that's what they used. The problem is, I see and go to microgravityuniversity.com, which is a NASA university website, which houses all the projects done by the NASA projects and the protocols, not the results. I cannot access the result of my own equipment. So if you see this, basically this device, how this device has been used, which means India has to generate its own data. You will not get the data. Or if you get, it will be 20, 30, 40 years later. They release it, they're available and they release it. So India should wake up and generate the data, bring the data and other things otherwise. I'll take 2-3 minutes to give this presentation. Amandeep Kaur, my last student when I left AIMS doing MSc, and she could not come today. She was supposed to give this presentation to honor my student. I present her data. 6-degree head down is a microgravity simulation. You all believe? Yeah. But when I started, I did not believe. Why 6 degree? Why not 4 degree? Why not 8 degree? Why not head down Shirshasana as we suggest? I'm standing. If the gravity is not there, why upside down? I didn't believe. This is a simple, funny question I gave to two. And I was a visiting professor at UCSD. I had a strong argument. I presented a hypothesis. If you do a 6 degree from 0, 4, 6, 8, you should get a U-turn. They said, no, you should not get a U-turn. And his article, hot argument went up. I came back, immediately I put up this. And in this study, the beautiful part which I'm going to tell, anybody can do, and you should repeat this study again, y minus 60, and come up fundamental things. What is happening to my vessel wall at minus 60, or what is happening to serotonin? Measure it. Endorphin, measure it. Happening to this. If you don't do that, no. So beautiful part is that this simple protocol anybody can do. Please do. It is not yet published. I will be showing soon. Standing for publication is the last student. Okay, these all things. Look at the protocol. Keep things simple. 5 minutes baseline, 4 degrees, 6 degree, 8 degree. You can go up to, we have done 20 degree also. We have done a 60 degree, minus 60 degree also. But here, this is what the window. A simple, and you record extensive parameters. Give the result. So I will not go because it's 20 minutes. We could get the U-turn. Quickly we published first part by Vishwajit in IJPP. You have an article. We are showing that it is a U-turn at 6 degrees. I'm still perplexed. Why did a U-turn? And which are the parameters not giving U-turn? As this lady has proven, there's one parameter not giving U-turn is the resistance change in different tilts. We measure the resistance first time in the lower limb, because if you do tilt, my blood from the lower limb will go to my head side. The leg should become thin. So when you go to space, puffy face, chicken legs. You get it? If you look at Sunita Williams today, just look at the legs. Go and do it, search. legs are actually chicken legs. Sunita Williams' legs are chicken legs and the whole world is worried. Why? What to do? And this is what we proven right over here, the resistance. And how to do resistance? Simple, measure the resistance and you can find change from 0 to 4 degree and 4 degree, and it keeps on increasing. As long as you keep, it will keep on. First there will be blood flow, and after that muscle wasting. And muscle wasting at 1 to 2% will keep on happening as long as you stay in it. The simple thing, if I don't do exercise, my legs are going to be lean and thick. Happens in aging, happens if you don't do exercise. This is the phenomenon, and we have correctly shown by measuring impedance, electrical impedance. You can do it by volume change or plethysmography and so this is how the data should be, and this is a discussion I'm skipping. And conclusion, we conclude that changes in the posture from supine to HDT stimulate micromobility by increasing parasympathetic dominance, which we got in total power here. We also got by HRV. So this is the finding. And as you go for 8 degree or you stay longer in 6 degree, after some time I'll get my head float, and then there will be sympathetic stimulus. My heart rate will go up. But that happens later. So this is how we can say, but I would encourage you to repeat those studies. Coming to the point of somato-visceral interaction, what is that? It is a somatic interaction, and the visceral through a pathway, it changes. So whether you have, so the mind-body interaction, what you call about, the whole thing is based on somato-visceral modification in yoga also. And here also we thought of, this is the topic we gave it to ourselves to think anew. I didn't find this topic going anywhere, but I thought, okay, let me think and then do this and fit our research into it. So what are the gravity dependent behaviors and physiological activity? Like if I have a gravity, I have 1G, I'm being operated all the time. So my muscle tone, my posture, my blood volume. So if I stay here for more than 1 hour, there'll be pooling. So if I don't do this thing, at my age, if I do for 1 hour, I'll faint. Anybody will faint. 40 minutes is a good time if you stand still, and that's all. So labyrinthine function. It's gravity dependent because the obstacles, they are floating. Intraocular pressure, GIT function, and others I will still not list. So some of the things we have been working on, and this problem we are facing, I wanted to have a mechanistic approach. What is the mechanism by which things are being operated? So this is a one flow chart. So microgravity would influence reflex-based systems like somato-visceral. Somatic means skin or visual or anywhere it's coming, and visceral means viscera are being affected. It could be vascular, it could be GIT, it could be other lung, other thing. But there can be some non-reflex-based. Get my point? The gravity will start pulling my blood in the lower limb is a non-function. It's like in a test tube, if you put it for a long time, if you don't tilt it, there will be sedimentation. You put the blood in a test tube, you get the sedimentation. Okay, so if you take a test tube, you put the blood, there will be sedimentation. But if I move the test tube 360 degree all the time, RBC will be suspended in the center. So this method will create a Earth-based microgravity simulation. This technique is called clinostat, and happily in Bardhaman, Subha Chatterjee's designed method equipment for India. It's a small tabletop, put something and rotate 360 degrees, your RBC or any other cell will be suspended. And I asked him, can you create one for human being? Yeah, yes, I think he says. So I'm here, if you tilt me at some speed, I'm comfortable because after 10 seconds I come back. And it's doable. So India should create a clinostat for human being. Will be given a tribute to Dr. Bose, who designed clinostat for the plant. He put plant here and keeps on moving. The plant was going straight, not going up. This is Indian science. He put the plant here And if you rotate all the time, normally put a plant, it will go up. It's a gravity effect. So Calcutta already did this work in India. So both Chatterjee comes up with a cell function and think big. So think big, I think, and do something. So based on the flex, like as a vessel, vessel function, it will change your vasculature. The stretch reflex itself will change, and muscle tone, another thing, all these parameters. And there could be secondary effects which you can observe, like change in bone function. How come when the gravity loss is not there, in a space, you lose bones? Or while aging, like aging people are sleeping most of the time, like watching TV and not standing like young guy, and therefore they lose bones besides other parameters. So aging and astronaut, they are having same mechanism. So therefore you can use aging as a model for space research and use the countermeasure used in space research for countering the aging effect. For example, yoga in a space astronaut can be yoga for uh, aging also will do the same function. Okay, so then interaction of gravity with the sensors, is it direct or indirect? So I could think like you can think better than me. I think there's only one direct effect is air obstacles, because they are suspended, and they are suspended at the moment you tilt, they will that's how I sense the gravity movement or position, another thing, air obstacles. I think that is the only direct effect of gravity on sensory receptors. And then once it is there, then they will initiate nausea, vomiting, and all other things, ear changes, and most of them are indirect. And that's my classification. Only prepared demo for yesterday, I thought this is what. But this requires a lot of research to prove that way. So you go to indirect, for example, pain receptors. Are they affected? I don't know. Is pain becomes hyperesthesia? One phenomenon, when you come back from space, you cannot stand. I'm not asking why you cannot stand, but I give you one more reason. It becomes as if Earth is twinkling. Because my legs have been suspended in there, there was no ground to touch, and this becomes hypersensitive. I'll take a while, the pain receptors, like the simple touch receptors become pain receptors when not used. And this happens when you return from, or you lie down from, or you do experiment in the morning. You get up in the morning, check your pain sensitivity in the lower leg. I did it for myself. 7 hours non-exposure to the gravity, your legs becomes more sensitive. That's why in the morning you look for the soft chapel. See, they're special provided, soft. So one should do experiment, put a person for 24 hours and look for what happens to my lower limbs. Besides change in posture, change in blood flow shift and other things. Yeah. So I need to be stopped, otherwise it will be difficult. How much time is there, sir? You are the master. No, because I have a lot of things, so you.
But is it possible to apply all the information?
Yes, I think I have some slides. Yes, it is very much applied. If you can use my body gear meant for space while swimming. In a swimming, you are horizontal. Gravity is least operating because that's also a microgravity. And you can apply. You can apply during the sports, which means if you swim with the load, like many people run with the load, 2 kg, 5 kg, you have seen it. I've seen in US, I've just returned from here. Many people put 2 kg and then they walk. They have loaded them with 4 kg or 5 kg. The weight is more. How can you load person while swimming? That's for sport. I'm swimming, now load me. You can use my gravitational loading or put some string or some other device by which you pull, and which means additional set of muscle will be, which means I become the best swimmer if I swim with the load 5 kg, 10 kg, whatever, or 20 kg. Who knows who can do better? And that's why you have to really work hard because you are being pulled. or you're being pushed, whatever. So this is one example, that's a one example. But I request, give me time so that I can finish, otherwise you all will be bored and say, no, I know. So, okay, then I cut off in 5 minutes, 10 minutes. Okay, thank you. So this is my question to you. All these five I have, you can take a picture of this slide, no problem. How will you record on Earth? How will you record in space? Because your recording device may also depend on gravity or may be affected. It's floating. Like if you take your ADI equipment or some other equipment, it will be floating unless you fix it or pen, everything. So I think this is what exercise, which means what equipment can be taken as a load, payload. It's called payload. If you go to your store, they'll say 1 kg. No, it's too much. 1 kg taken from here to here has a cost. The equipment has to be in grams. You can't do. So you have to devise a special equipment for recording in space or while swimming. I am swimming and record my heart rate underwater ECG. Can you do underwater ECG? Or can you do underwater blood pressure if you can't do the water user? So if you don't have, devise one and make one. So quickly, at 2012, we started Space Physiology Lab. It's doing well at AIMS. So we have all these things. And lower, you see anti-shock trouser available in the market, used as LVPP. We were not rich like Sai, who has 1 crore equipment for LVPP. They still have it. Exerciser, you have seen it. So we devised our own and then we devised other. So this is what we have been doing. Experimental setup, lower body negative pressure, lower body positive pressure. And all these devices, like this one is available with the site. So many people have it and you can make one. Dr. Latika Mohan, Dr. M.B. Dikshit, they designed something similar by using a vacuum cleaner. I still have that picture. She's sitting right over here. If you don't get it, you don't have 50 lakhs, make one in 10, 1 lakh or 2 lakhs. You don't require one vacuum cleaner. Okay. So this is what is the last figure. You see the Sunita Williams now? I'm tracking the news and look at the right side. Sunita Williams now. People are saying she is losing weight, but NASA is defending. If I lose weight, I still remain the normal. I don't become abnormal, my heart rate and other things. So this subtle is going on. You follow the news. Is she losing weight? Is she not losing? Supposed to be there for 2 weeks. Now it's almost how many months? And nobody knows when she's going to return. Okay. So anyway, now this is the body gear which has been granted to us. So this is the body gear, which gravitational loading, I can create body weight for 70-80% myself. Okay. The good thing is about is there's a flow created, Velcro magnetic flow, where I stick. This is my ground. And in space, there's no ground in the space. So that's the concept. And these things are already available on net. You can visit my website, kkdeepak.com, and see all these things stuff available, or you go to website. Okay, so using this, we did a lot of validation. Lot. Like 5 papers we already published on this model itself. So another PhD student has joined from NIT Jalandhar and she is looking for how can soleus be enhanced in space? How can I make my soleus strong in space? And that's what yoga people should also come up. How can you make soleus strong by using yoga? That would be the research. Okay, so this is all data. I'm not going into this detail. Thank you so much. So which yoga should be performed? We made a protocol. Why? This also we made a protocol, all this. Okay. And this is how it happens. This is Rakesh Sharma who went first to space. In space, now currently we are looking for. These are some ideas. This is the last slide. People can take pictures. Some of the ideas which I would think the space should go. So one of the thing is Gaganyatri, my roadmap is start recording parameters in a microgravity situation. Or look at what is happening to RBC in microgravity situation right on Earth in your lab. You can do today. You don't have to go anywhere. Emotion physiology and analysis. This is important. Sunita Williams' emotion is very strong. If your flight gets 1 day delayed, you get mad. एक दिन लेट हो जाएगा तो आप, मैं भी परेशान हो जाती, एक दिन, and the space is, the whole 1 year schedule is gone. And so it's very, emotion is very important. Human physiology modeling, digital modeling, Gaganyatri, which is the name of an Indian, therapeutic challenges, scientific experiment for the future, application of musculoskeletal modeling you can do in your lab now, and physical fitness regimes for astronauts. So, and this is my roadmap. I think this is something can be done. It is already published, Space Physiology, Promising Future. Earth application, space research is very important. Most of the research can be used for sports or otherwise. We published a position paper on this, the academic challenges, this is College of MNC, expert opinion on position paper, and to find out the how, what is the academic medicine, the way you are thinking of sport medicine, thinking of academic, the space medicine. And this is 60 years old book I found in B.B. Dixit library, 60 साल पुरानी, as old as me. And there are 3,000 abstracts. Imagine 3,000 abstracts in 1960, released by NASA, which means it was already 20 years old. So this is my team. We were in ISRO 2020. We went inside where the Gaganyatri is going to go. I went inside to see this module, which is actually supposed to go, will go in future. These are counterpart at UCSD and this thing. And these are the exercises. Thank you so much for. Thank you. I'm sorry. Thank you. Maybe 15 minutes. Point of it.
Very good morning to all of you. It's an honor to talk about the microgravity in front of Deepak sir, who has already explained many things. And it's an honor to present a work or topic on this at BHU and Varanasi Kashi. And the organizers requested me to be a little fast. So without wasting time, I'll just start talking about the short-term microgravity exposure. And you have already gone through that what is microgravity. It's nothing but a feeling of weightlessness where the gravity is not working that much on a long axis. And basically in astronauts, there faces a lot of issues starting from radiation to many things. And I will keep the presentation in a how it can be implemented in sports, as Khanna sir, Dr. Khanna sir has already asked. So I'll try to cover that, but a kind of a glimpse. So there are International Space Station. I think all of you can see in that picture that International Space Station, one of the major goals is to research on biological processes as well. And how can we use those microgravity effect, the physiological changes in disease population to cure some diseases or to improve the health on Earth. So that is the end, to protect the astronauts as well, the countermeasures. So there are a lot of research studies that use the space-based platform, but the major problem is, as Sarah has correctly mentioned, on human, when you are thinking about the Gaganyaan and human missions, particularly India, ISRO is thinking, And we don't have enough data on physiological responses, particularly it's highly protected by the NASA. Very few, 1 or 2 studies generally comes up. And the major problem is the small sample size to send someone in the International Space Station and getting a response, high expense, and that to a time constraints. And there are some privacy and protection policy from the Canadian Space Agency as well as the NASA as well. And obviously, they have a lot of studies are going on. As you can see, the Sunita Williams is undergoing cardiorespiratory exercise testing on a bicycle ergometer at International Space Station. That workshop was conducted on 12th, on the very first day, that CPET workshop. The similar kind of thing is also going on at space. And the recent picture where you can see, but how it is related with sport. So this is the two interesting data. So on April 2016, 2007, she ran the first marathon by any person in space, in International Space Station. And the most interesting is in September 2012, she ran the first person to do a triathlon, doing a swimming. How he did the swimming? So she elicited the swimming response by just doing some resistance exercise to simulate that thing. And biking, obviously, you saw the bike, the bicycle ergometer, and they have a running treadmill there as well. So the astronauts need to do regular exercise to prevent the bone loss and muscle loss. And most of you are familiar with the 4 phases, the wing commanders, and they are the initially selected and undergoing training for the Gaganyaan mission, which ISRO is planning. Most probably in 2016, it got postponed a bit. So obviously that indicates that India, we should do some work on space physiology particularly, and what kind of responses or changes are happening. And the bigger goal is how we can bring from the sports science department. So the goal can be the how to implement that responses to improve athletes' health and performance to further. So the some basic things, what kind of changes happens in an astronaut's body, you can see based on their stay, the neck, bone mineral density decreases. And when they post-flight, from pre-flight to post-flight, you can see there are around 10% to 11% decrease. And after 1 year also, when they stayed on Earth, still their recovery is not completed. So bone mineral density as well as the fiber type distribution also changes, their metabolic property changes, as well as you can see the gastrocnemius soleus muscle in 7 days decreased to 10 to 12%, whereas 16 to 28 weeks, it went to 20% to around that much decrease happened. Along with that, if you see the anatomy, the skeletal muscle, the fibers become very thin, lipid droplets increases, muscle atrophy occurs. So, but in the topic, we are going to focus on the cardiovascular system mainly and the cognitive, as is mentioned in the title. So this is the timeline of NASA spaceflight mission. These many missions have been taken up till today, starting from 1960 to 2024, but hardly we have 3-4 papers, and that too not from the NASA. So that is the bigger problem we are facing right now. And these are the many papers. You can see that autonomic function of the astronauts one by one, and at International Space Station or in space flight, not on any other model basically. So I am quickly skip. So what spaceflight basically does on autonomic function? So in spaceflight, there is a decrease in plasma volume, as well as in International Space Station when they are staying for a short term or long term, means less than 1 month or more than 1 month. So there will be a decrease in exercise. The muscle activity decreases, as well as vestibular disturbances, as Sarah has already correctly pointed out, and circadian rhythm disturbances also occurs because it's always illuminating and high noise is there at International Space Station, and some non-physiological stressors means they have to attend lot of conferences sometimes, some news things. So some other, when they will return, correctly pointed out, what Sunita Williams most probably is facing now. So all those create basically the sympathetic activity mode, and that decreases the vagal activity. So, but every time we cannot go to International Space Station and do a research and to see the responses. So we have on-Earth models. One of such is the 6-degree head-down tilt. So as you can see, this is from the Canadian Space Agency as NASA's model. So what they are training astronauts, 10-degree head-up tilt, dry immersion is there, water immersion to do the extravehicular activity at International Space Station. On animal model, there are some studies where the limb suspension or immobilization and parabolic flight. On Earth, we can do when particularly a flight slightly decreases, so we feel a weightlessness, or when we are traveling in a merry-go-round in a park, so we feel the same weightlessness, or in a lift also, that kind of, but it's not enough to do some kind of a research during that time. So effect of 6-degree head down tilt, I'm focusing more on that. So which we can easily implement or use in our on Earth, in our system. And the acute effects and immediate effects, there are a lot of papers. The immediate effect response, Sarah has already pointed out, is the same paper that 4 degree, 6 degree, and 8 degree head down tail Sarah has mentioned, and 6 degree has the optimum one, how it is doing. And there are long term. So different agencies, what is the protocol of 6 degree head down tail bed rest? They need to stay for 60 days and every day for 30 minutes on a 6 degree head down tail. And that is a standardized protocol followed by Japanese Space Agency, Canadian Space Agency, as well as NASA. And they are monitoring what kind of cardiorespiratory changes are happening, autonomic changes are happening in the body, as well as some endocrine responses as well. And when we searched the cognitive function particularly, I found very less paper, and one of such key paper is published in 2022, where they did a supine position, after that a 120 minutes head down tilt, and they measured what kind of changes are happening, and they did some testing during that situation only, as you can see, and they measured the cerebral oxygenation as well. And what they found? They found that the reaction time in 3 different tasks like switching, inhibition, and naming, the response time or reaction time decreases significantly, as well as, so why it has decreased, the reaction time? So they measured the oxygenation and they found that cerebral oxygenation increases, means when somebody is in a 6 degree head down tail, blood circulation is getting altered, it is shifting towards cerebral circulation, load is more. Obviously, it needs to be implemented that which kind of subjects, those who have a lower permeability or some vascular disease, obviously it will not suit them. But they did on the healthy individuals, and they found that the improvement in cognitive behavior may be due to increased circulation in the brain. And how we can increase circulation in the brain? That is another question. So this concept can be utilized in sports. That is what our lab is currently working. So if we can simulate this one, so sports like archery or where the higher cognitive attention or focus will be required, or chess, can we use this model as a pre-exercise or pre-competition intervention instead of just sitting on a chair at the competition venue? They will undergo maybe for 15 or 20 minutes or half an hour. So if we know that can be implemented, if we know that 30 minutes is basically doing this particular thing. So this is not only, so I'll enter into the exercise. So this is the one beautiful study where you can see the 4 different models. One is the normal cycle ergometer. The second one, top right corner, is the 6 degree head down tilt, which basically simulates the microgravity. Another one is the head up tilt that basically simulates the Mars microgravity, and another one is the lunar gravity. Basically, it's so, and what they did exercise on a bicycle ergometer using a ramp protocol, and they continuously monitored cardiorespiratory parameters. Just simply put it a carbohydrate gas analyzer. They measured VO2, they measured heart rate, VCO2, minute ventilation, all those parameters throughout. And what they found, if you see this particular figure, the heart on Earth after exercise, the heart rate was more. But in microgravity, moon gravity, and Mars gravity, after exercise, the heart rate was quite less. Can you utilize or implement those or leverage this particular output? And to obviously, a lot of research needs to be done. So, and why this concept came? So lower body. So earlier also, long back, anti-gravity was the concept designed by the NASA and to prepare astronauts. But that got used. We are using regularly for the recovery management. Can't we use the microgravity as well to improve performance or the particularly sometimes sports or the boost the recovery as well? So I'll quickly go through that. So to train faster and the technology, I'm not going deeper into that. And there are a lot of papers on anti-gravity treadmill. So can we utilize the Earth-based simulated microgravity induced alteration in physiological functions to optimize sports performance and recovery responses? Currently, we are focusing on this only. And what we did, we took certain subjects, around 28 males and 20 females we have already finished. And we did a simple set down tilt simulation just to know that are they able to tolerate that 30 minutes head down tilt? So, and it was just a pilot one so that we can design some other exercise intervention incorporating this as well. And we continuously monitored their heart rate variability, cardiorespiratory responses, and we found that RMSSD, that is the root mean square differences, and SDNN was significantly increased after 30 minutes of head down tilt. No such significant differences was seen in the frequency domain parameters, which corroborate with the findings from the Deepak sir and other. And another one result important, that is the cognitive part. So what we did before 6-degree head down tilt and after 6-degree head down tilt, we did there some cognitive assessment like attention, short-term working memory, as well as truth test, congruent time and incongruent time. And you can see in congruent and incongruent, there was a significant reduction in reaction time, which indicates this may be due to the circulatory alterations. And can we use this information or to extrapolate the study on sports population to make the subjects prepare or to improve their performance or the readiness particularly? Can we? So we can leverage the information, I think, to maximize the health benefits on Earth. So the information is the head down tilt, the microgravity response, but that particular responses can we implement in sports medicine or sports science? People after doing a vigorous studies, obviously on different population, different durations. And in that way, we can develop a personalized countermeasures not only for the astronauts, also particularly Indian astronauts. We can fill that gap which we are having currently massively, and we can improve both astronaut health as well as those who have orthostatic intolerance or the patients who are having a cardiac autonomic dysfunction. So I think they will be, or those who have an impaired cognitive ability. So those people can be, instead of just simply lying, and everybody wants to lie down instead of doing exercise. If you ask to do a sedentary people to do exercise, instead to get those benefits just by simply sleeping only or lying down only, maybe it can be initiated. So it's a pilot one. So we are trying to extrapolate the study. And so what are the limitations we are having? Just I'll take 1 minute last. So the magnitude of upward fluid shift due to head down tilt, we are still unknown. Is there any effect of prolonged use of microgravity? Immediate effect we can integrate with sport. That is the objective our lab is currently working. But is there any efficacy of incorporating acute or regular pre or post exercise simulated microgravity sessions to enhance fitness level or sports performance? And so we got the institutional ethics committee that got approved, and clinical trial registration second revision has been done. So this is the study where we are trying to integrate it with the sports and athletic population and how we can do that one. So this is going on. So I'd like to thank hope I am on time a bit. So I'd like to thank the organizers to giving us the opportunity to deliver a talk on altered gravity physiology. That is a very emerging area, and I think can be a potential relevant one in the field of sports medicine and science, not only for the clinical population, for the healthy population as well, to make it further or make it more or better. So with this, thank you everyone, and I'd like to thank Deepak sir once again for agreeing to deliver a talk on the anti-gravity, and he only inspired me. So from 2019 or 2020, we're in touch and we're talking this multiple times. We got the concept from sir, and that is how it's going. So thank you, sir. Yes, we can do. Sure.
Yeah, thank you to our esteemed speakers for the valuable presentation. Your expertise and insights have greatly enriched today's session, and we are grateful for the knowledge you have shared with us. And also, I would like to thank the chairperson for guiding this session. Now, I would like to invite our chairperson to kindly present the memento to our esteemed speakers. Professor P.K. Deepak, sir. And Dr. Arnab Das. As a token of thanks to our chairperson, I would like to present a memento to our chairperson.
मोबाइल मैंने दिया था चार्ज ऑन आवर चार्ज Thank you.
Yes.
Nutrition, Health and Performance. This is our next presentation from our honorable chief guest, Professor Peter Bruckner, sports medicine physician, Australia. And I want to request Dr. Ashok Ahuja, former head of department sports medicine, NIS Patiala Sai, and Dr. Upal, consultant sports and exercise medicine physician, President Sri Lanka Sports Medicine Association Sri Lanka, to kindly come to the dais to chair the session.
Which one is it? Yeah.
Thank you. And once again, it's a pleasure to be here. So my topic today is nutrition for health and performance. And you might think that they're two different matters, but I think I hope to explain to you that it's actually a lot of the same thing. So I spoke a little bit yesterday about my sports medicine career. I've been very fortunate to be involved with a lot of different teams and Olympics and World Championships and Premier League soccer and so on. But what I've always been interested in nutrition, and way back in the 1980s, I wrote or co-wrote the first sports nutrition book in Australia called Food for Sport. And in those days and in subsequent days, it was all about carbs, the carbohydrate generation. Everyone was having carbs the night before the marathon, carbs during the marathon, carbs. That's all we heard about. And that was, as we know, carbohydrates can be ingested as sugars and starches, stored in the muscle and the liver as glycogen, and then it's there for use when you exercise. We heard a lot about carbohydrate loading leading up to an event. We heard about pre-exercise carbohydrate availability, feeding during exercise, and feeding during recovery. So first in the 1960s, the result of science from some of our Scandinavian colleagues, they proposed a period of exhaustive exercise to deplete your glycogen stores, and then followed by several days of high carbohydrate intake. And then that sort of got refined a little bit over the years to just simply tapering the amount of exercise you do, followed with increased dietary carbohydrate intake. So that was carbohydrate loading, which was part of, I guess, every endurance athlete's armament in that during that period of time. And there was plenty of evidence to show it was effective, especially for exercise greater than 90 minutes, and showed that high glycemic load fuels were better than low, and the dietary intakes of 8 to 12 grams per kilogram per day was required to maximize glycogen storage. Pre-exercise, you could then top up your muscle glycogen even further and restore your liver glycogen by a small amount of carbohydrate pre-exercise. This would be some of the examples of pre-exercise fuel. And then feeding during exercise, again, it was all about carbohydrates. And you could have fluids in the form of sports drinks, Gatorade, Powerade. You could have semi-solids in gels. And for longer events, sometimes you'd have solids such as bars or bananas or something. Again, you could have 30 to 90 grams per hour, depending on the duration of the event. So that was really sports nutrition for the last 40 years. Carbs, carbs, and carbs. And that's what we wrote about in that book. But things have changed a little bit in recent times. And I want to take you through my own journey of discovery as how I've sort of come to look a little bit differently on nutrition. And I'm going to talk about three what I call light bulb moments. First one was affecting my own health. So I go back to 2012. I was living in the United Kingdom, single-handedly winning trophies for the Liverpool Football Club. The guy holding the cup had nothing to do with it at all. That was my team at Liverpool, the doctors and physiotherapists and fitness staff. We were all there to look after 25 pampered, highly overpaid footballers. It took a lot of us to do that. So at that time, if you'd asked me, how was I? How's your health, doc? I'd have said, fine. I was a healthy 60-year-old. I've been on a low-fat diet, as was recommended, for 30, 40 years. I exercised regularly. My blood sugars were fine. No, I'm good, thanks. Thanks for asking. The reality was I probably wasn't quite as healthy as I thought I was. For a start, I had a family history of type 2 diabetes. My father had developed type 2 diabetes at exactly the age I was at that time, at 60. And I saw what happened to him, and it wasn't pretty. And I really didn't want to go down that same path. So I was very aware of the dangers of type 2 diabetes. I was overweight, borderline obese. Like many middle-aged men, and I consider 60 middle-aged. I used to think it was old, but now I think it's middle-aged. I'd probably put on 0.5 kilogram a year for 30 years, slowly getting thicker around the waist, to the point where my kids are sort of poking me in the guts and saying, come on, Dad, how about it? And I'd shrug my shoulders and say, well, I'm on a good diet, I exercise, not my fault. I also had some metabolic issues. I had a high insulin levels, I had high triglyceride levels, and I'd had a fatty liver. We heard a bit about fatty liver before, non-alcoholic fatty liver disease, for 10 or 12 years. Every time I had a blood test, every couple of years, it would come back, liver function test consistent with fatty liver. Now, I didn't really know what fatty liver was. I'm a sports doctor, aren't I? What would I know about fatty liver? And I figured I was on a low-fat diet and I'd be fine. So like most doctors do when they're confronted with some medical issue, we ignore it. And that's what I did. So in retrospect, I was clearly pre-diabetic. I've got all those classic signs of pre-diabetes. But at the time, I didn't really understand that, and I thought I was fine. So you can see there, I'm not the healthiest looking person around, but a few of my football colleagues are fairly similar. So maybe it's something about working in football, I don't know. So around that time, I have a good friend in South Africa by the name of Professor Tim Noakes, who many of you will have heard of and read his work, The Law of Running, the Bible of Running. And around that time, Tim Noakes, who had always been a huge advocate of carbohydrates, came out and said, I think I've got it wrong. I think I've had it wrong. It's not carbohydrates it's not fat that's the problem. It's carbohydrates that are the problem. And we're all eating too many carbohydrates. And he'd actually reversed his type 2 diabetes by going on a low carbohydrate diet. So he was advocating that we should all follow that path. And to be honest, when I first heard that, I thought, oh, come on, Tim, don't be ridiculous. We couldn't have all had this wrong for the last 40 or 50 years. But because it was Tim Noakes, and he's probably the smartest guy I know, I decided to look into it and see whether there was any truth in his assertion. So I read a book. That's unusual for a doctor, but I actually read a book called Good Calories, Bad Calories by Gary Taubes, who's not a doctor. He's a science journalist at New York Times. And this book just blew me away. It was an amazing book. And it talked, not only did it talk about the relative merits of carbohydrates and fats, but it talked about the politics and the history of how the low-fat diet had won out over the low-sugar diet back in the sort of 60s and 70s, which I'd always assumed was due to science and evidence, but turns out it was due to money and politics. We shouldn't be surprised. So I then, once I'd read that, and I found this book very disturbing. I found the whole concept that we'd had this whole diet thing wrong quite disturbing. I remember sitting on the edge of my bed in Liverpool, my apartment in Liverpool, looking out over the Mersey River. It was a beautiful, beautiful sight, feeling quite agitated and disturbed at the prospect that maybe whole of Western society had had their diet wrong for the previous 30 or 40 years. I then dived into a whole lot of books and articles and read everything I possibly could, including, books and articles by many of these people. From the left is Jeff Volek. Next to me is Nina Teicholz, who wrote a fantastic book on this subject. There's Tim Noakes there, and there's Steve Finney on the other side. And they're the sort of the gods of the low carb movement, if you like. And I read everything I could, and the more I read, the more I think they're right. I think we've actually got this wrong. Well, I'm a scientist, well, sort of scientist, and I thought, well, I need to do some research. But I knew enough to know that research with an n equals 1 is a waste of time, except when the 1 is you. That way it's very important. So I decided it was time for an n equals 1 experiment on myself, looking at what happened if I went on a low carbohydrate diet. So what did I do? I decided I'd try 3 months what they call a low carb, healthy fat diet, and to see what happened. So on day 1, I got all my bloods done again, and I weighed myself, and away I went. So what do I mean by a low carb, healthy fat diet? What did I eat? Well, I stopped eating anything with sugar, bread, cereals, pasta, rice, potatoes, fruit juice, margarine, vegetable oils, pretty much all processed foods. Now you might think, well, that doesn't leave much, does it? So what did I eat instead? Well, I went back to eating probably the way that my grandparents had eaten, with real food, fresh food, plenty of non-starchy vegetables, meat, fish, eggs, oh, all that cholesterol, butter, oh, that fat, saturated fat, my God, cream, oh, terrible. All the things we've been told not to eat for 40 years, I went back to eating. Olive oil, nuts, and the only fruit I ate were berries. So what happened? Well, the first thing that happened was I stopped being hungry. So instead of having my sort of cereal for breakfast at 8 o'clock in the morning and getting to about, 10:30 and thinking, gosh, is it lunchtime yet? I would have eggs and bacon and avocado for breakfast, and I wouldn't eat again all day. So I went from eating 3 meals and 3 snacks a day to eating 2 meals a day, is what I eat today. So then I started to lose some weight. Every week I'd lose a bit more weight. I thought initially it was just fluid, it's just, beginner's luck, but kept on going. But other things happened. I started to sleep better. I wasn't as sleepy during the day. My exercise improved. I thought I could concentrate better. I generally felt a whole lot better. So at the end of that 3 months, I was half the man I used to be. I'd lost 13 kilograms in 13 weeks, eating as much as I wanted to, never being hungry, and the more fat I ate, the more fat I lost. I sort of almost felt guilty, because losing weight's supposed to be really hard. And yet I found this so easy. I ate really well, I had lovely meals, and I kept losing weight. Couldn't believe it. So I just thought I'd share with you a couple of my blood results because they're quite interesting. So if you look here, my fasting blood glucose was 5.5, which is fine. That's a reasonable fasting blood glucose. And similarly with my HbA1c, which is a measure of the sort of the previous 3 months glucose. Again, 5.5, absolutely fine. Not much difference 3 months later. So what effect? What's happened? Well, here's the interesting thing. Here's my insulin, my serum insulin levels. So my serum insulin initially was very high at 11, and it came down to half that, 5.6. And my HOMA-IR, which is a measure of your insulin resistance, was again very high. So those tests showed I was insulin resistant. So even though my blood sugar was fine, The reason it was fine is that my pancreas was pumping out all this extra insulin to keep it low. And eventually what happens is your pancreas gets exhausted and can't do that anymore, and that's when your blood glucose rises and you become diabetic. But this was further evidence that I was pre-diabetic. I was hyperinsulinemic. Now, I'll bet none of the physicians in this room ever test for their serum insulin. And yet, I think it's probably the single most important test you can do. No doctors test for it. We test for serum glucose, but by the time your serum glucose starts to rise, it's too late. You're already diabetic. Serum insulin is interesting. So there's a lot of concern about lipids, about fats, cholesterol, when you're on a high-fat diet. So what happened to my cholesterol? Well, it went up a little bit, but my HDL cholesterol went up a little bit. But my triglycerides, which were quite high at 2.1, remained the same. And I remember being devastated when I got those results. I thought, oh no, that's supposed to come down. That's supposed to be the thing that really comes down with a low carbohydrate diet. And then I read a little bit more and realised that maybe I'd just been mobilising a lot more fats, and that's why my triglyceride was still high. And then when I repeated the test 3 months later, my triglyceride had come down to normal. So all my metabolic abnormalities, so my weight and all my metabolic abnormalities had been resolved by simply 3 months of a low carbohydrate diet. And they've remained normal ever since I've remained on the diet. So similarly with my liver, these are my liver results. So you can see there my ALT, which is probably the best measure of a fatty liver, had been around about 65 for the previous 10 years. And then in 3 months, might have been less than 3 months, I only did the blood test after 3 months, it had come down to 25. My fatty liver that I'd had for 10 years had resolved by eating fat. Weird. Unfortunately, we use the word fat for too many different things. That's a problem. But anyway, I felt better once I discovered that fatty liver has actually affected a third of all Australians. We heard earlier today that it affects 12% of adolescents. Well, a third of Australians. And there's a lovely saying from Professor Roy Taylor, who's done a lot of work on in this field. Before the diagnosis of type 2 diabetes, there is a long silent scream from the liver. And that was me. I had fatty liver disease, and I was on the way to being diabetic, but I didn't understand it at the time. So my little N=1 experiment, 3 months of a low carbohydrate diet, reduced my appetite, lost 13 kilograms of weight, increased my energy, improved my sleep, decreased my triglycerides, normalized my insulin, and resolved my fatty liver. Not a bad idea. Not a bad 3 months, eh? If you'd had some drugs that did that, you'd be pretty happy. You'd probably market them, call them Ozempic or something like that. Anyway, there was one problem though. There was one big drawback. I needed a new wardrobe. I'd gone down in size, 2 sizes, and nothing fitted. But I figured that was a small price to pay to do that. So sugar is an issue. You know, diabetes is a massive problem in our society. And obesity and diabetes, a huge problem. I believe that type 2 diabetes is the single biggest health problem we have. Why is that? Well, you don't die of diabetes, but of all the complications. Diabetes is the most common cause of blindness. It's the most common cause of amputations. It's the most common cause of kidney disease, kidney dialysis, kidney transplants. It's the biggest risk factor for cardiovascular disease, higher than cholesterol or anything like that. You never hear about that. And it's closely associated with dementia and Alzheimer's. Alzheimer's is referred to sometimes as type 3 diabetes, such as the link. So diabetes is a massive problem in our society. This is a quote from some time ago, 8 years ago, from Professor Paul Zimmet giving a lecture in the United States. The diabetes epidemic, obesity and type 2 diabetes, is likely to be the biggest epidemic in human history. I think that will turn out to be true. So where do we go wrong? What happened? I mean, 2 generations ago, we didn't have these issues of obesity and diabetes. What's happened? Well, people say, oh, we're not exercising as much as we used to. Well, that's not actually true. We're actually exercising about the same as we did 50 years ago. In those days, it was more work-related. Now it's more leisure-related. But exercise hasn't changed much. What's changed? Well, let's have a look at this graph here. This is the obesity over time. These are American figures, but I'm sure most countries are fairly similar. And you can see in the 1970s, it was a nice flat line. There was no particular increase. Then around about 1980, everything started to take off. And ever since then, we've got fatter and sicker. What happened? What happened around 1980? Moscow Olympics, can't really blame that. Ronald Reagan got elected, can't really blame him. What happened was, we told everyone to stop eating fat. The wise people decided that fat was the problem and the solution was low-fat eating. So we were told to take the fat out of food, to stop eating fat. And the food industry, very clever, saw there was lots of money to be made, so they decided to take the fat out of a lot of processed foods. The problem was that when you took the fat out of the food, it took all the flavour away. So they had to come up with something, a substitute. What was that substitute? Sugar. So it was actually the low-fat, high-sugar guidelines. And as you can see, they've been a fantastic success. We've got fatter and sicker ever since. The diabetes curve is pretty similar. All right. My light bulb moment number 2 happened in this country. I was with the Australian cricket team, touring here in 2013. Yes, okay, you beat us. All right, we won't talk about that. But I'm going to talk about a particular case. One of our players had a lot of trouble with his knee. He'd actually been out of cricket for a year, and he was really struggling with knee pain. As I said, he missed a year of cricket, and he'd been to every specialist, and he'd had scans and had arthroscopies, and no one could work out what was wrong with his knee. Eventually, he went to a rheumatologist who diagnosed him with seronegative arthritis and started him on some very powerful drugs, initially prednisolone and methotrexate, and then after that, Enbrel, which is a tumour necrosis factor antagonist. Very expensive. So when he was on the prednisolone and methotrexate, he got about 50% reduction in his symptoms. And then with the Enbrel, he was probably 90% reduced in his symptoms. So when I met him, he was injecting himself with Enbrel once a fortnight, and he was able to train and play. He wasn't able to train fully. The coaches thought he was lazy, but his knee would just get sore. He was in the squad, but not actually in the test team at that stage. He told me that about 10 days after his injection, of each injection, his knee would start to ache, and he knew it was time to have another injection. So it lasted about 10, 12 days. So he was actually a little bit overweight, as so many elite athletes are, amazingly. And if we understand their diets, we'll probably know why. But he was a little bit overweight. So he came to me in the middle of that tour and said, I just lost all my weight. And, the guys had talked about it a bit. And he said, I'd like to lose some weight. I was wondering, can I try the low-carb approach that you used? I said, sure. Challenging here in this country, all those nice, high carbohydrate breads and rice and so on. But I said, no, let's do it. So he did. The good thing about athletes is they're very disciplined. And he was very disciplined. And he went low carb almost straight away. We're eating in the same dining room, so I could just have a little look every now and then. And sure enough, he was low carb. Maybe because he knew I was looking. But after 3 weeks later, he came up to me and said, Doc, I forgot to have my injection last week. I said, what do you mean? He said, well, I didn't get any knee pain, and I didn't realise it was 2 weeks, and it's now 3 weeks, and I had no knee pain. What should I do? Should I have my injection? Well, I pretended that's exactly what I expected. Of course, yes, I knew that would happen. And I said, why don't you try and manage without it? See how you go without your very expensive autoimmune drug. Since then, no drugs, no pain. He increased his training. He got back into the test team. He's been in it ever since. And last year, which is 10 years later, He was the ICC Test Cricketer of the Year, saved by his diet. So this was a real eye-opener for me. I pretended I jokingly said I expected that. I had no idea that diet could affect musculoskeletal problems like that. And so I started to get very interested in the whole concept of diet and inflammation. And we now know there is a strong association between inflammation and chronic disease. Now, as you know, there are two types of inflammation. There's the classic, acute inflammation, your red hot, swollen knee, but we're really talking more about chronic low-grade inflammation being a massive factor in the development of chronic disease. There's evidence that type 2 diabetes is an inflammatory disease, atherosclerosis, and many other diseases. Chronic low-grade inflammation plays a major role. All sorts of different diseases. And we know that there are certain foods that are inflammatory and are anti-inflammatory. Inflammatory foods are particularly sugar and vegetable oils, seed oils. Anti-inflammatory is more fatty fish, flax seeds, and so on. Olive oil. So it's actually been shown for 100 years probably that a very low carbohydrate diet or a ketogenic diet, which is sort of the extreme, if you like, of low carb. If you reduce your carbs completely, your body switches its fuel. It switches from petrol to diesel. It switches from carbohydrate to fat. If you're eating any carbohydrate, the body will use the carbohydrate first. But if you starve yourself of carbohydrates, the body switches to fat. It's called a ketogenic diet at its extreme, because you're producing lots of ketones and using that as an energy source. And we've known for 100 years that a ketogenic diet can help the management of childhood epilepsy. But it was discovered in the 1920s. And then when drugs came on the scene, it was forgotten. And now there's been a resurgence in interest in the ketogenic diet in epilepsy, in that all the major children's hospitals around the world have a ketogenic diet ward for people with chronic epilepsy that is resistant to drugs. And there's actually a foundation called the Charlie Foundation, which is based on this young boy here who was the subject of a movie with Meryl Streep. His father was a Hollywood producer, and he was having 60 fits a day at the age of 2. And he'd been around to every specialist and had every drug and every medication, and nothing had worked. And his father heard about this ancient remedy, this ketogenic diet that was used 100 years before. As a last resort, they said, let's try this diet. And that was the end of his fits. Almost overnight, within a week, he had stopped having these 60 fits a day. And so his father had devoted his life to promoting the idea of these ketogenic diets through the Charlie Foundation. Now, the interesting thing is you would have thought 100 years ago that someone might have thought, well, if it works in this particular neurological condition, maybe it'll work in some other conditions. But no, that's not the way medicine works, unfortunately. And no one really thought about that until the last few years. And now, again, there's been this resurgence of interest and research in the last few years about the role of a ketogenic diet in the management of chronic disease. And all these different diseases, there is starting to be some research coming out showing an improvement in these diseases with a ketogenic diet. My last light bulb moment came in the coffee queue. Now, I have to admit, I have an addiction, and it's coffee. And I've just had a very nice coffee, thank you. So I was in the coffee queue at university, and a young lady came up to me and said, Dr. Bruckner? I said, yes. She said, I enjoyed your lecture the other day. I said, oh, it's nice. Not many people say that, but that was nice. And she said, but that's not what I want to talk to you about. And I thought, oh my God, what have I done? You know, what did I say in that lecture? Did I upset someone? Did I say something politically incorrect? She said, my husband and I are massive cricket fans. Because of you, we changed our diet. My husband's been bipolar all his life. And I just want to tell you that he's now off all his medication and you've changed our lives. And I just want to say thank you. And I thought, wow, didn't see that coming. And again, that was another eye-opening moment for me in the role of nutrition in mental health. You know, we all talk about, and the previous speakers have talked about, you know, the incidence of mental health in our community, particularly in the young. And there's some really interesting research going on now. There's been a couple of books come out recently. There's a whole new area of psychiatry called nutritional psychiatry. And there are 8 to 10 large clinical trials going on around the world looking at the impact of a ketogenic diet on various aspects of psychiatry, depression, anxiety, and in particular, it seems to be very effective in this bipolar disorder. There was a recent paper that looked at ketogenic diet in various forms of mental illness. And you can see there the symptoms improved in 100% of cases, a variety of different illnesses, bipolar, major depression, schizophrenia, reduction in medication, and almost half of them were put into remission. Quite dramatic effect. So there's a lot of evidence coming out now about the effect of diet on a whole variety of different chronic diseases. So what are the factors that you know really seem to cause chronic disease? Well, there's 4 main factors that people talk about. I briefly mentioned insulin resistance before in my own case, but it's a huge issue. Inflammation, we've talked about as well. We hear a lot about gut dysbiosis, the gut microbiome and abnormalities there. And the other one is mitochondrial dysfunction. Seems to be an enormous factor in chronic disease. I don't have time to go into all of those now, but insulin resistance has been known for some time. It's a key to all these diseases. And there's evidence for all 4 of those factors being involved in the development of chronic disease. And they're all interrelated. So it's really important to understand the contribution of all those different factors. Now, interestingly, there's one thing that can improve all 4 of those issues, and that's a low-carb ketogenic diet. So all the factors that seem to be causing this chronic disease can be improved by changing your diet. So that's been my low-carb journey, if you like. Started off with my own experience. And I guess when you have an experience like that, you have 1 of 2 choices. You can either just keep it to yourself and, keep it a bit of a secret, or you can start talking about it. And I chose to start talking about it. Well, I didn't have much choice, really, because people would be coming up to me and saying, God, what have you done? You got cancer or something? You lost so much weight. And, I decided to try and spread the word about this particular issue. Started to give talks, started to write. We started a program called Sugar by Half. We've published a book called The Fat Lot of Good, a program called Defeat Diabetes, and written another book called The Diabetes Plan. Sugar by Half we started a few years ago because everyone agrees on sugar. Even the dietitians agree that sugar's not great. And we decided, let's have a target. Let's try and reduce the amount of added sugar that each person eats. In Australia, that's about 20 teaspoons of added sugar a day. 20 a day. The worst culprit, soft drink. How many teaspoons of sugar do you reckon there is in a 600ml bottle of Coke? Well, I'll tell you, 16. 16 teaspoons of sugar in a bottle of Coke. We're very happy. We wouldn't let our kids eat 16 teaspoons of sugar, would we? We're very happy to give them Coca-Cola. So we wanted to reduce the amount of sugar by a half. And the main thing we've done is we've produced a whole lot of lessons, school lessons for school children that teachers can give and get the message out there. It's amazing the influence that kids can have on their families' diets. They come home from school and tell mum and daddy they feed them the wrong things. So Sugar by Half's been quite successful. The elephant in the room, as I've mentioned, has always been type 2 diabetes. And there have been a couple of programs, one in the UK and one in the US, that's been very successful in developing app-based programs to reduce type 2 diabetes. So in Australia, we decided we'd do something similar. So we developed an app, which was initially an app and now an app and a web-based program called Defeat Diabetes, called defeatdiabetes.com.au if you want to have a look at it. And that basically consists of a whole bunch of videos, articles, meal plans, cooking demonstrations, recipes that give you all the information you need to tackle type 2 diabetes with diet and other chronic diseases as well. We have an active Facebook group where people post their stories. We have a regular webinar series. And we've had over 12,000 people do that program. Now, that's not that many, you know, when you consider there's probably 2 million people with type 2 diabetes in Australia. But it's a start. And we've recently formed a partnership with Diabetes Australia, who've always been very reluctant to embrace diet as they're sponsored, you know, like all these organisations by pharmaceutical companies. But they've now come into a partnership with us to promote the idea of a low carbohydrate diet in the management of type 2 diabetes. We commissioned some research as well at La Trobe University in Melbourne, where I work. We have had a PhD study going for the last couple of years, looking at 100 or 99 actually patients referred by their GPs into this Defeat Diabetes program, all of whom have HbA1cs over 6.5 and therefore are regarded as having type 2 diabetes when they start. And these are our 3-month and 6-month results. The average HbA1c goes down by 1%. Now that doesn't sound much, but that's a massive difference in HbA1c, and it's been associated with significant reductions around 30 and 40% in all the complications of diabetes I mentioned earlier. And you can see in the bottom one, whereas initially none of the 99 had HbA1c under 6.5, so they're all type 2 diabetic. Now half of them are under that amount. So half of them would no longer be considered to be defined as having type 2 diabetes. Now, I don't know about you, but when I was in medical school, I was told type 2 diabetes was a chronic progressive disease. There was no cure. You were on medication for life, and you just got to hope you avoid some of the complications. Well, I think we've shown that's not necessarily the case. So another study we're doing at the moment is looking at the effectiveness of an anti-inflammatory diet, which is basically a low-carb diet, into knee osteoarthritis. And we have 144 subjects, half of them on a normal sort of traditional diet, and half of them are on a low carbohydrate anti-inflammatory type diet, which has reduced amount of zero really processed foods and encourages natural foods. And that's been going on for 2 years. We've recruited all 144. We're just waiting for the final results, and that will be published next year. So, you know, there's a lot of work going on in this field, but the main thing is that people do a lot better when they reduce the amount of carbohydrates. Okay, let's get back to the athlete, because that's what we started talking about. What about the athlete? Is that relevant to the athlete? The fact that, you know, carbohydrates may not be as good as we first thought. What's the best fuel, fats or carbs? You know, the advantage of carbs is that it gives you immediate energy, but the problem is that you run out very quickly. You run out of carbs, run out of glycogen, so you have to keep refueling. If you're running a marathon or an Ironman or something like that, that's a massive issue, all the gut problems and so on. The advantage of fat is that even the skinniest one among us, we've got lots of it, and we can use it as a fuel. So is it possible to change your diet as an athlete from a high carb diet to a high fat diet? Well, there's been quite a bit of research on that. Steve Phinney was the first one to really look into it way back in 1983, and he suggested with some submaximal cycling that there was no detrimental effect anyway of changing from carbs as your fuel to fats as your fuel. They put out a book, Jeff Bollock and Steve Phinney, called The Art and Science of Low Carbohydrate Performance. And there have been a number of papers now out there that show that that low carbohydrate, high fat diets can be effective, particularly in endurance and ultra endurance events. It seems to be just as effective. And anecdotally, many of the world's ultra endurance runners, for instance, those crazy people who run 100-mile events and things like that, we need psychiatry more than food. But anyway, they actually do better on a fat as a fuel rather than carbohydrate. It's of course been very threatening to the carbohydrate-obsessed dietitian profession. And this is Louise Burke, who's probably the most famous sports dietitian in the world. She was at the Australian Institute of Sport for many years, and she published back in 2006 that quite definitely fat loading and high fat diets were no good. You can delete fat loading and high fat diets from the list of genuine ergogenic aids for endurance and ultra endurance sports. She was quite adamant about that. Well, interestingly, a few years later, she said, whoops, Did we call the nail in the coffin? Did we call the nail in the coffin? Did she call the nail in the coffin too soon? She suggested, well, maybe we got it wrong. She said the current guidelines for carbohydrate intake, which were mainly published by her, appear to be poorly understood. Sports nutrition experts do not promote a high carbohydrate diet to all athletes. Well, that was news to most of us, because as far as I knew, they had for about the last 40 years. The evolving model is that the athlete should follow an individualised approach, where carbohydrate intake is periodised. So it's not just carbs, carbs, carbs. You periodise your carbohydrate, depending on the amount of training, the amount of exercise you're doing that day. So we hear about this, this story of train low, compete high. So you train in a low carbohydrate state, but you compete or you do your intense training on a higher carbohydrate state. So there's been a real sort of revolution, a lot of controversy. There's sort of two camps, you know, there's Noakes on one side and there's Louise Burke on the other, and, you know, there doesn't seem to be much middle ground. In fact, Louise Burke got up at a lecture and said that Tim Noakes and Peter Brookner should be in jail. And I thought, oh, that's a bit radical. But I thought if I'm going to be in jail with anyone, I'd be happy to be there with Tim Noakes. You know, we can have a good chat. Anyway, she said there's a need for ongoing research. And to her credit, Louise Burke has done some very good research with a bunch of elite walkers there. And she suggested that there probably wasn't, that there was a slightly detrimental effect of a low-carb diet in elite athletes at a particular distance. There are additional advantages, though, of a low-carb ketogenic type diet for athletes. First of all, weight loss. It's a very effective weight loss mechanism, and it doesn't seem to affect your power, your muscle strength. So you're not losing muscle on a low-carb diet. So that improves your power-to-weight ratio, which is obviously a good factor. Metabolic health, I've talked about that. I have concerns about the long-term effect of high carbohydrate intake. We've had a whole generation of athletes, elite athletes, who've had massive amounts of carbohydrates, often in the form of sugar, sports drinks and so on. What's the long-term effect of that? Surely many of them will become insulin resistant. We hear a lot about former athletes having heart problems and so on. Everyone says, oh, it's the strain on their heart. Well, I reckon it's probably what they've been putting in their bellies rather than their heart. Recovery. You seem to recover better on a fat-based diet rather than a carbohydrate-based diet. Probably because of that inflammation. Less inflammation and you recover better. And then there's a reduced need to refuel. I've had patients who've done an Ironman triathlon, 10 hours on water. No breakfast and water. Now, if you're carbohydrate based, you would have to be having some carbohydrates every hour in that time. And that has massive issues with your gut and all sorts of problems. So there's certain advantages, theoretical advantages anyway, to this idea of a low carbohydrate approach. So what do we know? How do I summarize things? We know that when you go on a low carb ketogenic diet, you dramatically increase the amount of fat oxidation. Very effective at doing that. There's no doubt about that. Anecdotally, some athletes, especially endurance and ultra-endurance athletes, perform better on a low-carb diet. High-intensity activity, maybe not so much. So if you're an elite, high-intensity athlete, you know, 1,500-metre runner or a 5,000-metre runner, probably I'd stick to the carbs. The research evidence is certainly not clear. More studies need to be done. So what we don't know is how long does it take to fully adapt? A number of the studies are done after you're adapting for 2 or 3 weeks. But there are other studies that suggest it takes 6 months to fully adapt from a high carbohydrate diet to a low carbohydrate diet. So don't do it for 2 weeks before you're going to run a marathon. Do it in the off season where you've got time, because often initially when you change from a high carbohydrate diet to a low carb diet, you actually don't feel that great for a couple of weeks. You have this condition called keto flu, which we think is probably a depletion of sodium. Because if you're not eating processed food and you're not eating these sugary drinks, you're not getting any salt. So we actually get low on salt. So how long does it take to fully adapt? We don't really know that. And with full adaptation, does endurance performance improve? What about intermittent sports, you know, football, basketball, ice hockey, and so hockey? We don't really know. We don't know about that. We know that strength doesn't seem to be impaired, but we don't know enough about those sort of, certainly anecdotally, many football teams now, I mean, we recently changed coaches, changed managers for the Australian national football team. And the first thing he did was employ a dietitian. Before he employed an assistant coach or anything like that, his first move was a dietitian. So, and that dietitian is encouraging reducing carb intake. So, what I suspect is that there's considerable individual variation. There seem to be responders and non-responders. Some people do very well on a low carbohydrate approach, others don't. There's probably individual variation. It's a matter of suck it and see how you go. I think there's a right diet for everyone. It's just the challenge is finding out what that diet is. And it depends on a whole lot of different factors. I would say that a low carb diet is probably better for ultra endurance events of moderate intensity. And even those, an amateur runner, if you like, running a 3-hour marathon is probably going to benefit from that, but probably not the 2 hours 10 marathon runner who's at Olympic level. Most will need additional carbs for high intensity activity. So what a lot of football teams are doing now is that during the week, they're mainly low carb. They might have extra carbs on their high training day. And then on match day and the night before and the morning of the match, they'll have some extra carbs. Nowhere near the carb loading that they used to, but certainly more carbs than they would. So this train low, compete high concept. So further investigation, we need performance after weight loss in weight categorized sports. So a lot of sports are weight categorized, so potentially low carb can be very advantageous. As I said, what we don't really know is the repeated high intensity sort of ball sports, the development of central fatigue during endurance events, perceptual motor performance during prolonged sports, the ideal dietary fatty acid composition, because there are different fatty acids that affect things differently, and what is the effect of ketone supplements. We need to know more about that. So what do I tell my athletes? Well, I tell my athletes that their basic diet should be a lower carb, healthy fat, real food, avoiding sugar, processed foods, ultra processed foods, and seed oils. That's for their general health. Give yourself plenty of time to adapt to this change in eating pattern. Don't do it the week before the marathon. You may find you need to top up with some carbs before or after during higher intensity activity. And everyone is different. Find what works for you. Thank you.
Thank you, Professor. He is a milestone in the life of sports medicine. No doubt, today's topic of sports and performance not only just covers the sports person, but also the common metabolic diseases that we are fighting. Unfortunately, we are becoming the diabetic country of the world. India is facing a very, very major problem. Thank you so much, Dr. Peter, for giving your timeline also and your medical profile to tell us that we need to take up the insulin resistance and HOMA tests on a regular basis for everybody. I'm sure in this hall also we'll be having quite a number of people who are getting pre-diabetic or so on. We all are from that. And of course, for the sports person, as I also said yesterday, we are still finding the right sources in, we have the vegetarian diet, we have vegetarian sportsmen, at least in our country, we are facing a lot of problems of that. And they have got high carbohydrates also, and the protein problem. Thank you so much, and I'm sure now it is open for any questions on that.
That lot of good? Yep. You get that on Amazon?
Yes.
Sorry. Sure, yeah. There's been a lot of discussion about environment and diet, and certainly the vegan population have tried to demonize the poor cow, who is supposed to be burping methane and causing climate change. The cows have been around for a long time, and we've only had climate change in the last little while. So I don't think it's the cow's fault really for the environment. But look, I think there's a massive problem with agriculture. There's a massive problem with pesticides and herbicides and genetic changing. I think we need to go back to regenerative agriculture, organic agriculture as much as we can. I think there's also a massive problem with the addition to the additives to foods. Particularly ultra processed and processed foods have 10, 20, 30 different additives to make them last longer, to make them look better, colorings, emulsifiers, and so on. That's a huge issue as well. So I think if we go back to eating, the way that our grandparents used to eat, eating real food, and avoid all the processed food and all the adulterated food, then we might be much better off. Coffee, yep. Hmm. Yeah. Yeah, look, there's been quite a lot of study into coffee, and most of the studies seem to indicate a positive effect on health rather than a negative. And similarly with tea, and especially things like green tea, I think I'm a great fan of green tea. I think it's very healthy. So you eat a lot of green tea here, which is good. But coffee, yeah, I said I admitted I'm a coffee addict, and obviously, everything in moderation, and I think small amounts of coffee and tea are quite healthy.
We'll,
Yeah, I think you've only got to look at recent history. I mean, we're just getting more and more unhealthy. We have chronic diseases now that we'd never heard of when I was a medical student. I mean, all these problems with gluten. We didn't have that 30, 40 years ago. All the chronic autoimmune diseases. Something has changed. Something has changed in our environment, and I think food is the number one culprit for me. Dr. Burn.
Is business. Is the so I just want your mind this. What is what you look out when you look for ISSEM? It is body and distance such as this some amount of companies they one piece. The carbohydrate is some amounts and it's divided by millions body is what is it? No, glycogen load is glycogen load is yeah.
Look, as I said at the start, I mean, glycogen, carbohydrate loading, it's been very effective. There's no doubt it does seem to work in endurance events. And I think, if I was an elite marathon runner, I'd probably still be doing some form of carbohydrate loading. But, clearly I'm not an elite marathon runner. And if I was running marathons, I'd be running on fat. Because it's much healthier. As I said, I have real concerns about the long-term future of these athletes who are having lots of carbs. So, I think the elite athlete is a different animal, I mean, but the rest of us, the other 99.99999% of the population, I think we should be following these guidelines.
Because the guideline does publish 120 gram carbs. Second system was 10 to 20 gram. So one more question regarding here, when the question is from some of the people we have sitting from one very lower game. So actually, what they have a higher, total cholesterol level, that is the lean mass.
Yes, lean mass hyperresponders, yeah.
Yeah.
Yeah, no, that's right. Well, this man knows his literature. There's a group of people known as lean mass hyperresponders who, when you put them on a higher fat diet, do have extraordinary high levels of LDL cholesterol, which we've all been very concerned about. And there are some people doing some really interesting research there by a guy by the name of Dave Feldman. And it seems that these sort of people do not seem to be at extra risk of cardiovascular disease, despite their high LDL levels. But there's still more research that has to be done. So there, as I said, there's a small percentage of the population who seem to respond. The majority of people, their cholesterol, their LDL cholesterol doesn't change all that much, surprisingly, by changing from a low fat to a high fat diet. Interestingly, people get very concerned about cholesterol in the diet, and yet we've known for 50 years, even Ansel Keys, who was the big man on the low fat diet, he knew 50 years ago that the cholesterol in our diet has no impact on the cholesterol in our blood. The cholesterol in our blood is the cholesterol we make because we need cholesterol. Our brain needs cholesterol. And I think one of the big issues is that we're all so low now on cholesterol, we've gone too far the other way. It's actually affecting our brains. But that's a bit controversial, so I won't talk too much about that.
I know this is going to be a very important and interesting practice. So it's a lunchtime, and I know everybody will be looking for questions or so. We'll continue over there, but I think just last question.
Very interesting presentation about path. One question protein. Let's start conference going on about the way protein and way isolate because the grass fed for the cows also makes a difference in the protein powders. So can you get your comment on that?
Yeah. Well, yeah, that's a whole other lecture on protein. But a couple of quick comments on protein, okay? Protein is obviously very important, particularly as you get older. The older person needs more protein. So, we always used to say, maybe 0.8 grams of protein per kilogram per day. Double that as an older person, because we need to maintain our muscle mass, and very, very important, as well as doing some resistance exercise. So that's one point. Second point is animal protein versus plant protein. Very controversial again. Everyone gets very emotional about it. Leaving aside whether you believe in vegetarianism or meat, or leaving all that aside. Clearly, animal protein is probably a higher quality protein than plant protein. Doesn't mean you can't, because they're complete proteins, whereas plant proteins are not complete. They don't have all the amino acids you need. But that's not to say you can't get sufficient protein and be perfectly healthy. Thank you, service work, on plant protein. So I'm not against that, but the fact remains that animal protein is more effective. Protein supplements, protein powders, whey protein, it's become a sort of part of what people who exercise believe. They finish their workout at the gym and then they have their protein powder. I'm not convinced that that's any better than having, a good protein meal. But it's certainly not harmful. As to which type of protein, probably whey, as you see, whey protein is probably the best. But yeah, we can talk about that at length.
I know there's a very pertinent question amongst Indian athletes also, whether to have the whey protein or the isolate protein, and the BCCA, the number of supplements is too much exhaustive. It's a multi-million-dollar industry which has come up over there. A lot of myths and facts required, for which I don't think so we have good time. With this, I think we close the session. Thank you so much. It has been very interesting, very interesting. Or also for the general public. Thank you, sir.
Good. Can I just say one thing? To say what a pleasure it's been to be here for these 2 days, and how everyone has been so friendly and warm, and I really appreciate it, and I look forward to coming back in the near future. So thank you very much.
So, on behalf of everyone here, I would like to express our gratitude to our distinguished speaker. Your presentation has provided us with new perspectives and have made this session both engaging and enlightening. Thank you, sir, for your invaluable contributions. And we extend our heartfelt gratitude to our chairperson for steering this session. Now, I request both the chairpersons to kindly present the memento to our esteemed speaker. As a token of thanks to the chairperson, I would like to present the memento to our chairperson. Although we are running late and if the audience permit me, I would like to proceed for the next session. So can we proceed to the next session or should we go for our lunch break and we continue after that? Latika ma'am, you say? We should start. Okay. So we can cut short the lunch break and we can continue the session. Yeah, that's why I asked. Okay. So we have with us Professor Latika Mohan, Professor and Head AIMS Rishikesh, and she will be she will be talking about the fitness for pilgrimage to high altitude shrines, and we invite Professor K.K. Deepak sir to kindly chair the session. Yes, sir, please.
इसको भी लगा दो.
This is fitness for pilgrimage.
Thank you very much for this opportunity. I am going to regard the person that there has been yesterday event that to cap only they learn better. I'm sure the journey is going to be better. Suddenly they have this problem to performance. Yes, so I think we have actually and you know basically
Okay.
my Dr. Lakshma Mohan is well-known person. Over to you.
A very good afternoon to everyone, and I'm sorry for holding you up for lunch, but I thought that the chances of getting a better audience is more now than after lunch. After lunch, तो सब बिल्कुल भाग जाएंगे. So I represent AIMS Rishikesh. As all of you know, I'm working there. And also I would like to introduce my new association that I have formed with Colonel S.B. Singh and a group of other people, the Indian Society of Hypoxia and Mountain Medicine. And this talk is about about high altitude, and we're trying to do work with hypoxia and mountain medicine. So this is, I hope you get inspired by my talk, and subsequently post lunch, Dr. S.B. Singh will be talking and join us association. So this particular talk is not only about talking about the physiology and medicine of fitness for traveling, for pilgrimage to high altitude shrines, but it's also a call to arms. It is also an advocacy for people to get involved in this research and to do something for this situation that I find myself in AIMS Rishikesh. We are living this reality every day. And it is something which involves and affects each and every one of you sitting in this room, because at some stage or the other, you will all be inspired to go on these pilgrimages. So, um, located close to AIIMS Rishikesh are the 4 shrines, the Char Dham Yatra, and basically all these shrines are located in the high altitude, where the main stressors, we all know, it is common knowledge to most physiologists and sports people, is hypoxia, hypobaria, fall in temperature, lack of humidity, and UV rays. I'm not going to go into details about this, but I'm sure you're all already aware of it. Now, the shrines that we have, I just like to tell you a little bit about this map that I've got out here. So we have these 4 shrines at Yamunotri, Gangotri, Kedarnath, and Badrinath. If you see, all of them are located over 2,500 meters above sea level. 2,500 meters is the current international definition for high altitude. And the general journey that is taken for the Char Dham Yatra, it is over 10 days. So mostly they hire either buses or or even individual vehicles, and they travel from Yamunotri. Pointer's not. They travel from up to Yamunotri. From Yamunotri they go to Gangotri. From Gangotri they go to Kedarnath, and from Kedarnath they go to Badrinath. This is the general route which is taken by most people who complete the full Char Dham Yatra. So this is mostly on hilly terrain, and most of the people who are going for it are not acclimatized. They are not really prepared. Many of them come from Tamil Nadu and from Gujarat, living on the seaside. They've never really even seen what a mountain, imagine what a mountain is. They've probably seen it in a Bollywood movie. So they have no perception or concept about what this particular situation is going to be. So I'd like you to remember this sequence of Yamunotri, Gangotri, Kedarnath, and Badrinath, those who are not already aware, because it is also important from the route is also important from the acclimatization and how it's going to pan out point of view. So how various lowlanders sort of perform at these altitudes and how they fare, whether they get any diseases or whatever, any problems, depends on their physical fitness. Now, all of you can see me standing here large as life after this wonderful lecture by Dr. Peter Bruckner. I'm telling you, this previous lecture was so important to me, because I have been trying to face this problem of obesity for a very long time, and many of us do have pre-diabetes and this kind of a problem, and it's a struggle. So, so physical fitness is going to really influence how you fare in these high altitude places. How fast you ascend, the rate of ascent, severity of rate of ascent has become very significant now, because a larger number of people are traveling to these altitude locations by helicopter, thinking that it's going to be easier or better. But it's got its own problems, its own set of issues that come up because of sudden air travel and air entry into altitude. The severity or duration of exposure, if it's short, maybe a couple of hours, maybe it will not have so much of a problem. But some people do get stuck because of bad weather, and the exposure becomes longer than 10, 15 minutes, 2, 3 or 4 hours, or and extends into a couple of days. Certain cultural habits. I think yoga is a good example of a cultural habit. Geographical location and genetic variation. These are generally factors which affect how lowlanders respond. Now I want you to see this chart. I don't know if the figures are visible to everybody. It's basically, why did this problem of the yatris in Char Dham Yatra come to the forefront over the last few years? Basically, after COVID, we started documenting how many people were actually visiting the Char Dhams. And this chart is basically a document which shows the total number which came this year. And this is as of 20th of October 2024. And the number is 42 lakhs 56,727. So can you imagine what that means? What is the magnitude of the problem? How many people have visited these shrines, and what kind of load it is putting on the system, on the ecosystem, on the medical system, on everything.
Now, this is a part of, I was not really allowed to officially share this, but I'm sharing it anyway because I feel this message is very important. 247 dead. Out of those people who went, this is the reported, this is from the state government document. This is what they have reported as people who have died by going to these shrines this year. Last year it was 400 and some 23 or something like that. At the end of the year, that was the total figure that they had. Now, my question is, if a person is going on pilgrimage, tourism, or anything to a particular place for a short period of time, why should even one person die? I mean, there has to be some way that we have a system in place, or we have some screening in place that we prevent this kind of mortality. And what I'm also getting the feedback now, because we're still analyzing this data. From Kedarnath, I have started a DM program for physiology in high altitude. Physiologists and others also can do, but in high altitude. So I have a resident who's posted at a hospital in Kedarnath, which is, we have an MOU with Swami Vivekananda Health Mission Society, and he is working there. 13 deaths which occurred in his hospital in Kedarnath were entirely and totally, all of them due to cardiovascular causes. All due to cardiovascular causes. So we'll go deeper into this. So what are the major vulnerable groups? Sedentary, middle-aged, elderly people with multiple comorbidities. So it's wonderful that this lecture comes straight after Dr. Peter Bruckner's, because that is the message that was coming from there. So a lot of people who are pre-diabetic, who are or maybe diabetic, hypertensive, and maybe some have heart failure, COPD, and so forth. They are the ones who are doing, most of them who are doing this kind of journey. There are also vulnerable groups are pregnant women and children. A lot of children, even yesterday I had gone for this Aarti. So many children were there. And I was really worried because, you know, this kind of magnitude of crowd, the stampedes and all that can happen. But they did, the children, they come. And the other vulnerable population, I call them vulnerable, is because these are people who come for reasons of commerce to support the infrastructure and stay there for a longer period of time. So here there are people who are the labor who are working there, the people who run those small shops, the tea shops, and who maintain those small hotels. Now those people have really no access to any public health education on this particular matter. They don't have access to medical care, and they are really there for one season and they go down. So they're also a vulnerable group that we need to address. Even our government people, there's a whole police force which is working to, 42 lakh people visiting this shrine over 6 months. You need a good police presence to be able to control the crowds. So they're also going in without any training, without any previous understanding, and also are, dependent on the same healthcare system that we have there, which surprisingly, though this has been brought up by the government, we just have Swami Vivekananda Health Mission Society's hospital, which is actually doing any real good work. I mean, the government facility exists. Sometimes there's a doctor there, sometimes not. It's got equipment which is still not been unpackaged. There's limited awareness amongst the pilgrims about the health risks on an altitude travel, and also they are not very happy to stick to any of the health advisories, even if they're given, because many of them, obviously for religious reasons, and that is that thing, especially post-COVID, we found there's a total avalanche of pilgrims that came because it was against any kind of medical advice. They were just wanted to visit, and they don't carry adequate warm clothing. So many people don't have a concept of warm clothing because they've never used it in the south and all. They come with chappal and sari and one shawl they'll wear, and they're -5, -10 degrees temperature, and they go into hypothermia. There is limited and overburdened health facilities. There is problems with infrastructure, electricity, and connectivity. Connectivity is not there at all. So limitations for evacuation. Now this is a big problem because suppose the weather turns bad or there is a landslide, suddenly there is no way that if you have a sick person, you can't evacuate.
There's no way of bringing them out of that situation. So you have to hold it in whatever hospital or medical facilities which are very sketchy there. And generally that is the kind of patient which is heading towards the mortality. Yeah. So I'll go fast. So the guidelines which are available are okay. I think I'm allowed to take 15 to 20 minutes. That was the time allotted to me, so it's prepared for that much. So most of the guidelines and studies available internationally are mountaineers, healthy field volunteers, and simulated ascent, and with very small simple sample sizes. So we don't have any sort of good data on how to handle these kind of patients in this kind of situation. Very few recent studies have been coming from China and from the Alps where they've been working on COPD and so forth. But we have our own typical Indian problem of pilgrimage, which we need to study in more detail. And so far, there are very few people who are really working on this, and actually nobody. There's just nobody working on it. And this is just through case reports. If you like, I can skip them, which is just basically the kind of patients that we are getting. I will ask the chairperson at the time. I can just quickly, huh?
Can you see that?
The conceptual thing is that basically this was a patient of 55-year-old. This is important in a way. He came with chest pain and his problem had started with angina at Kedarnath, but he really manifested his problems at Badrinath, which is the next halt, and it was a case of acute anterior MI. No previous history. Jugal Kishore, a 41-year-old male from Gujarat, had palpitations and nausea. No chest pain, no history of chest pain, vomiting, headache, or this thing. He came at about, this patient came at about 3 o'clock at night. And when he was saying that he was feeling uneasy, and the blood pressure, vital parameters, SpO2 was perfectly normal. And ECG, there was just sinus tachycardia, which is expected at altitude. The ECG was normal at 3 a.m. when they did the ECG was normal, but because he was complaining of uneasiness, they decided to detain him in the hospital, and they put him on oxygen. He felt better in the morning, went off to do his darshan and all that, left the hospital, was absolutely fine. And 10 o'clock, he was brought back with this. And he died. So this is two typical problems that my resident has faced in altitude, which I wanted to show. So what are the acute physiological adjustments? Quickly, I will just go through this. Of course, there's hyperventilation. Hyperventilation causes alkalosis, and because you're breathing more frequently, with each breath, there is loss of insensible water loss and dehydration. There's the stress response with the acute increase in sympathetic discharge. Diuresis, which worsens your dehydration, and the usual responses to cold or peripheral vasoconstriction and shivering. So this is what leads to this particular physiological milieu for everybody, each and everybody who's going into an altitude situation. Dehydration, alkalosis because of the hyperventilation, tachycardia because of sympathetic discharge, increase in cardiac contractility, increase in systolic pressure, coronary vasoconstriction, fluid adjustments because of certain unknown yet hormonal effects, and also an increase in lactate. So acidosis also building up. Now, where this also becomes relevant in this particular setting, Kedarnath involves a trek of 16 kilometers. Yamunotri has a 4-kilometer trek at a very steep climb, and Gangotri has a 2 to 3 kilometer walk. Now, maximum MIs that we are getting is at Yamunotri. I'll explain why Yamunotri. Yamunotri, a person is coming completely unacclimatized. From the first port of call, the first halt is at Yamunotri. And when a person reaches there, middle-aged sedentary person who has not been doing any kind of exercise earlier, he takes on this steep climb to the temple and to the shrine. And that is where most of them are having a problem.
For anybody, the exercise capacity is reduced by 1% with 100 meters rise in altitude. And it's only the religious motivation and faith which carry a lot of people forward. Now, there is a thing that they say that if you are going to possibly die in that location, it is attaining moksha. But then it's not as simple as that. Not simple as that for the family. It is not simple as that for the medical care givers in that location, for the people who have to evacuate, and it is a big problem. So the two major stresses which we are coming into conjunction here are hypoxia and exercise. Now, when a person goes with pre-existing cardiovascular disease to altitude, there's the cardiovascular disease at altitude. Now, I think most of you would have already gathered from what I have built up with. There's hypoxia, there is hypoxemia, there is increased myocardial demand due to cold, exercise, and hypoxia. There is systolic hypertension because of your sympathetic discharge. Yet unknown effects of increased sympathetic discharge on endothelin 1. There is increased expression of endothelin 1B receptors and inflammatory cytokines induced by hypoxia, which we are just coming to know about. So diseased coronary arteries paradoxically may vasoconstrict in this scenario of respiratory alkalosis, stress, and exercise. So the message here is that if you are physically fit and healthy and young, nothing's going to happen to you if you travel to altitude. You probably won't even notice it, maybe get a little breathless. But if you're sedentary, not regularly exercising, have comorbidities, are pre-diabetic but have not been looking at the signs, have not ever got a health checkup done, which is what most of these pilgrims are. These hypoxia and exercise combination is going to unmask your underlying disease and leads to a catastrophic result. And these catastrophic results happening in a location like any of these shrines. The problem is there's no medical care, there's no evacuation, poor evacuation, and the treatment is also sketchily available. Stampedes happen, crowds negotiating out as difficult. So there, basically, it is a very big public health problem. So cardiovascular screening before travel to altitude. This was a beautiful lecture taken yesterday by Dr. Devraj. And we need to implement some of those principles. It's a call for action, as I said, that some people need to work on developing a screening algorithm for cardiovascular risk, which can be put into place. So he had given some ideas for athletes, like you would have a primary, secondary, and tertiary level of screening. Primary including clinical examination and ECG, secondary examining echocardiography and stress testing, and so forth. So, but I feel that any person, if he comes to you as a doctor, that I'm going to any of these places, this is the basic, and the chances are there that they're sedentary and all the rest of the background that I gave. So clinical status, the functional capacity, how much are they able to exercise? The echocardiography, CT angio if it's required, stress testing needs to be done. And they did exercise test at sea level to exercise tolerance and provocable ischemia. So one message here is that angina is more likely to occur at lower workloads at altitude. So this is the point to remember. And one must approach strenuous exercise with caution. Advice for pilgrims is exercise preconditioning with regular incremental exercise before undertaking the pilgrim. It is unsafe for patients with unstable angina to travel to altitude. And persons who are treated, diagnosed with controlled disease, good exercise tolerance, can safely travel to moderate altitude where these shrines are located. So just quickly about hypertension. So the hypertension is really a doubtful problem. There are many people who say that that doesn't affect the blood pressure too much and it stabilizes very fast. But there is an increase in systolic pressure because of increased sympathetic discharge and a fall in diastolic pressure because of hypoxic dilatation. So there may be what the message I want to give is that there may be a change in pressure and there may be self-monitoring and dose adjustment which is required for people who intend to stay for a longer period of time. And person who has uncontrolled hypertension, the risk for cardiac event is much higher. Arrhythmias at altitude, hypoxia, hypothermia, electrolyte imbalance, alkalosis associated with long QT. Sudden cardiac death is an increasing problem in pilgrims and military at altitude. Recent Holter studies have shown that hypoxic exposure is arrhythmogenic and mostly benign, but may become more sinister in the elderly. And if you have any unspecified symptoms of syncope, dizziness, and palpitation, they should not be ignored, and a full workup should be done, because the chances of you having a arrhythmia, which I showed in that case study, are much higher in a hypoxic environment. So I'll skip this. The take-home messages: travel to high altitude poses potential risk to all people diagnosed or yet undiagnosed with cardiovascular disease. Exercise and hypoxia may unmask underlying disease with catastrophic results in areas with poor medical facilities and variable evacuation. We need to sensitize public in general and doctors that pilgrims are prepared properly for this sojourn. Screening protocols need to be devised and standardized. This is what I would like people to work on, and I would also be doing it with my cardiology team. It's a big exercise and requires multiple people to take on. And strategies for mass testing for cardiovascular risk. This is the last point is ever so important, because the problem is that 42 lakh people which came this year, how do we test them? How do we implement this? Do we have camps? One idea I had was that we can have religious camps, through religious organizations and volunteer doctors, where this kind of screening can be done before. But then even if the screening is done, to motivate those people not to go to the pilgrimage, वो एक बहुत बड़ा काम है. They think the job is over, that they have done the registration on the Char Dham Yatra portal and they've got the tickets for travel. But the bigger problem is what lies below the iceberg. So that is the last and most important message. And thank you very much.
Such a weak sample.
Yeah.
Really, it's a great opportunity. We have to write project the government to mobilize people that for a short duration of time, say few months, and huge cohort. To create a special
Already doing very nicely in the dot. Okay, then. Thank you so much. Yeah, we clap for that long. Thank you. For all night.
Thank you, ma'am. And now I would like to invite our chairperson, Professor K.K. Deepak sir, to kindly present memento to our esteemed speaker. On behalf of the organizers, I would like to present memento.
Okay, thank you.
For your time, effort, sir.
Pretty got one. Thank you, sir. No, that is a मैं मोबाइल दे दूँ. फिर मैं देख रहा था कि
So we take a break here for lunch and we will be back maybe around 35-40 minutes. I hope that it's fine. Thank you so much.
I think ब्रेक में ज्यादा लोग होंगे यहाँ पे.
जी मैम, चल लीजिए.
अभी बोल रहे थे.
ये फोल्डर बनाएंगे ना.
है 16 तारीख रात को. सर आपका
Supposed to happen before lunch. That's it immediately after lunch, and after that, we will practice another service. Arrange some.
Conference. Yeah, Lakshmi.
Yes.
I also on the table, and it will mind will take them to this. Which time only?
Ma'am, after here.
Yeah.
Sir. Sir. Thank you. चल रहा है तो वो चल रहा है आवाज नहीं है ना साउंड नहीं है चलो
अच्छा अच्छा खाना नहीं खाया आपने ओके रेडी से सामने दे रहे हैं सर हाँ सामने में जो काउंटर है हाँ रेस्टोरेंट काउंटर में बैठे हुए साइन करके दे देंगे आपका नेक्स्ट है ठीक है अभी अभी करा है हाँ बिल्कुल मैम सब हो जाएगा वो रखा हुआ है द रिसीट इज एक्चुअली इन द रजिस्ट्रेशन काउंटर you just have to share the name and they will sign and they will give it no problem and if receipt is अगर नहीं भी मिल पाया तो we will post it और scan करके दे देंगे that's everything even order certificate so sir is Professor Surendra Pal sir is not here coming huh? Okay fine yes I will begin before Kalyanak sir is not here so I will guess Professor Dr. Joshi sir is being chairman, but we will wait for sir. Yes, we are starting. It was delayed, so sorry because the earlier speaker were not available. So we'll start. So I will request Professor Surendra Pal sir to please come. Sir, your talk is in the pen drive, right? Pen drive is in pen drive. I've already given it. Okay, that's fine. Please, sir. It's not pen drive.
It's important to meet people like you. I think I'm here because of you. Yeah. All right. Good afternoon. Okay, the chairperson has to come on stage, please. A very good afternoon to all of you. And so there's a conference on appearance is an idea. Right, so there's a conference in sports medicine, and when Varun and I connected because I was trying to start a short course in fellowship in sports medicine at Amrita Faridabad, where I am right now. I'm heading the Department of Physiology. So Varun told me about this conference and he said, sir, why don't you attend if you are interested in the topic? I said, definitely I am. I was in the army and had an opportunity to do a fair amount of work at high altitude. And naturally, the soldier we have to consider not only the soldier's health, but also the soldier's level of performance. So for that purpose, we did some studies, and what I'm presenting here is a very small part of what we did. Of course, there's much more to be done. That is the important thing. The important message is there's much to be done, and I might be doing it in a inverted, starting first with a message, but the opportunity in India is tremendous. We have a natural ongoing experiment in hypoxia for the last millennia. There's so many people living, as you shall realize, hypoxia is not attendant only at high altitude. At moderate altitude, people begin to develop early hypoxia. It's just that the compensation is complete, which doesn't happen at high altitude. The compensation is never complete. So we have a huge opportunity. The world is dying for us. How many times have I heard from international colleagues who want to collaborate with me? Of course, we have our government policies, because of which collaborations are not allowed. So I've been unable to collaborate with any international worker. But then we have a whole lot of people in the country who, if they wished, could use this opportunity, could use this ongoing experiment in hypoxia and take whatever learning they wish to take for their respective specialties, including sportsmen. Right. So with that, let's get into it, dive into it. So this, I think Latika ma'am has already set me up out here. She's told us all about this. Only thing I want to bring out is why is 2700 meter or 2500 meter considered the cutoff for hypoxia? The reason it's considered a cutoff for hypoxia is because at this level, number one, the exercise capacity decreases. It decreases actually 10% per 1000 meter or 1% per 100 meter above 1500 meters. But with time, it reverts to normal as at sea level. But above 2700 meters, it will never ever revert to sea level. You could stay there for 5 days, 5 months, 5 years, 50 years, will never revert to sea level values. Right. So that is one catch, one reason why this is defined as high altitude. Exercise capacity decreases, highly variable between individuals. One might show a 1% decrease, another might show a 5% decrease. And at different altitudes, however, definitely a decrease in exercise capacity. Right. Dr. Latika has already told us about this UV radiation, temperature, absolute humidity. So just bringing the focus onto the sportsman, the extremely low temperature at high altitude. So even during the summers, maximum daytime temperature in Leh at 11,000 feet would be about 26, 27 degrees, which is a very comfortable temperature here. And at higher altitudes, when they run across that 18,000 feet pass, the temperatures are down to about 10 or 5 degrees. So the whole game of temperature regulation, which is so important to the athlete, changes out there. And absolute humidity is low, coupled with the diuresis that leads to dehydration. Even after the phase of diuresis is over the first 2 days, the absolute humidity being low, any activity does tend to cause dehydration, right? And the dehydration can have physiological and clinical consequences. In a large study on thrombosis that we've done, we found that most of the people who developed thrombotic events, venous thrombotic events, did so after a fair amount of work had been performed on a heavy work day. Right. Of course, there was the other end extreme of the Gaussian curve who had been resting for a long time. That is a known factor. Okay. So we all know this oxygen delivery chain. I think we skip it. Acclimatization, ma'am has told us about it. Only thing, a few things. Ventilatory acclimatization is complete within the first couple of weeks. Hemoglobin is the next important method of acclimatization to altitude, and that can continue for months altogether. Right. In one study, longitudinal study of about 600 soldiers that I did along with as part of a group, we found that hemoglobin kept on increasing for 1 year. Of course, the altitude also kept on varying, but the hemoglobin kept on increasing for 1 year, and similar data has been presented across the world. Cardiac output increasingly after the first 2 or 3 days decreases. So contrary to what common belief would be, cardiac output to increase ही करेगा, requirement ज़्यादा increase करेगा. No, it doesn't. It decreases, especially because stroke volume reduces, heart rate remains high, goes higher, but stroke volume reduces. So cardiac output is reduced at rest and at maximal activity. So VO2 max is also reduced partly because cardiac output is reduced at maximal activity. It never reaches the same values at sea level. But at submaximal activity, the cardiac output is greater than at sea level for the same workload. Right. So that's an important point to bear in mind. Pulmonary artery pressure increases immediately on exposure to hypoxia due to hypoxic pulmonary vasoconstriction and might be responsible for the reduction in cardiac output by reducing preloading. Right. And of course, muscle fiber area and capillary density, muscle fiber area decreases. As a result, capillary density increases. But this is something that happens over a period of weeks to months. Right. And then there is some interesting work that shows that the Sherpas, who are the best performers at altitude, have more glucose utilization than lipid utilization compared to us. The ratio of glucose to lipid utilization is greater in Sherpas, although lipid utilization, of course, remains a larger component, but it's greater in Sherpas. Is this true for us when we go to altitude? Not known. Right. Keep in mind there are two populations at altitude, the resident like the Sherpa, the native resident, Sherpa, Tibetan descent, Ladakhis, the lowlanders who go and live at altitude for months, years altogether and become somewhat like the native residents, but never exactly because the genetic changes do not happen in them. And then, of course, there's a sojourner, you and me going up, mountaineer, soldier, pilgrim, other professionals, athletes. Of late, a lot of athletic activity at extreme altitude, which is why I thought it would be pertinent to speak of this ultramarathon at altitude. So a number of marathons and ultramarathons are happening. So this particular ultramarathon that I am presenting here is the Khardungla Challenge. 72 kilometer run, starts at 14,000 feet. They run up to 18,000 feet, over 32 kilometers. They are allowed 4 hours for that. And then they run down another 40 kilometers. Maximum they must finish within 11 hours to be called finishers. Right. So we decided to study some of the determinants of performance, like simple determinants, nothing complicated, because research at altitude is hindered by the fact that equipment malfunction is common. Most of the equipment is not manufactured for those cold temperatures or for those altitudes. Temperature sensitive equipment like ABG analyzers and all will fail at these altitudes, or you get them corrected, right? You get them modified for the experiment. So we took simple determinants. We measured hemoglobin, pulse oximetry, spirometry in Leh at 11,500 feet, where the athletes were practicing, where they were training after having landed up there. And we simply noted the incidence of acute high altitude illnesses, acute HIIs, acute high altitude illnesses in participants, because exercise, gentlemen, at altitude has this two-pronged effect. It can accelerate acclimatization if done properly, and it can cause disease if done excessively, right? So we wanted to see if this ultramarathon could also predispose to disease, right? So we looked at the Lake Louise scoring questionnaire, which is a method of diagnosing acute mountain sickness, which is a syndrome of early onset edema of the brain, right? Generally harmless unless it goes on to haze. We looked at the fundus to look for any brain edema, and we looked at chest ultrasound to look for any pulmonary edema. These are common problems that occur at altitude, especially due to exertion, right? So the baseline comparison at Leh between the two groups. So we had 4 groups: acclimatized lowland runners. The first group, ALLR, the native highland runners, right, who'd been born and brought up in Leh, who are natives, Tibetans, or rather Ladakhis by descent, the acclimatized lowlander sedentary, and the native highlanders sedentary. These were soldiers. Some of them, sorry, this keeps on moving, or maybe I had set some timing on it. So the acclimatized lowland runners were mostly Air Force personnel, but also a number of civilians. Out of those 17, it would, I'd say, half and half. Okay, the native highland runners were all military soldiers of the Ladakh Scouts. The acclimatized lowland sedentary were soldiers of the Indian Army, and native highland sedentary were again soldiers of the Ladakh Scouts, right? So the average days at altitude had been 8 for the ALLR group and sedentary group 7. Of course, the other 2 groups had always lived at altitude. The age of the acclimatized lowland runner was rather more than that of the other groups, and they were also taller. Both the lowland groups, that is the runners and the sedentary, were taller than the native highlanders. So height anthropometry varies. Okay. The weight was greater, hemoglobin was lower, right? For you people might be able to explain why ultra athletes have a lower hemoglobin than sedentary people. Okay, I've been looking for literature and I've not been really foot strike anemia, etc., nothing convincing. So maybe there's some more research needed on my part. I need to search the literature better, or maybe your sports medicine people can tell me, or maybe you need to do some more research as to why hemoglobin is less in ultra runners. Okay. The forced vital capacity, interestingly, when normalized to body weight, was again lesser in the ultra runners. One would expect them to have great vital capacity. Not really so, lesser. I think this was because they had been practicing, and maybe some of them did not tell us this. We had told them not to exercise them on the day of testing. Maybe they had exercised and they had some residual bronchoconstriction, but their FVC was clearly lower than that of the other groups. The heart rate, SpO2 were normal, like the other groups. The Lake Lewis score was slightly greater. Lake Lewis score arrival at altitude, not otherwise. Fundus was normal in all. Comet score, which is a measure of chest ultrasound for chest lung water, was pretty fine. Both the lowland groups had some chest water, but nothing significantly. Look at the run timings. Right on top, the native highland runners finished in 7.2 hours plus minus 1.1 hour. Those 6 runners, 72 kilometers in 7.1 hour to 2 hours. The other runners told me, sir, we do not do this sort of running in the plains also. Ultra marathon, 72 kilometers, we can't do it in 7 hours. But this is what the native highlanders did. The acclimatized lowland runners did it in 11.7, almost 12 hours. Right? 14 hours was the cutoff for finishing. So such a huge difference between the two. And if you compare the parameters, weight loss in the acclimatized lowland runners was about 1.2 kilos on an average. I think water loss and maybe some lipids because of the lipid burn up during 72 hours, 11 hours of running, but mostly water loss. I would suspect dehydration. The lowland runners, the native highland runners lost only about 800 grams on an average. The SpO2 was down in the lowland runners. And these recordings, gentlemen, were made about within 4 hours of finishing the race, not on immediately on finishing the race. So this is some residual effect of the race. This is not an immediate effect. The heart rate increase was greater in the native highlanders. The forced vital capacity per kg was even further decreased in the acclimatized lowland runners after the run. Right? We'll forget the rest. Suffice to say that none of them had acute mountain sickness or high altitude pulmonary edema. Right? So you know that pulmonary artery pressure increases during exercise, and that is the cause of pulmonary edema also. So they did not have it handled. If you correlate the timing, we saw some correlations. We found that the timing was the greater the weight of the runner, longer the time taken. Sorry. The greater the hemoglobin of the runner, lesser the time taken. This is very interesting. They have been there only for 8 days, not enough time for hemoglobin change to occur. So this is their residual, their pre-race hemoglobin, the hemoglobin they live with. And the FVC per kg normalized to body weight had the strongest correlation at about 0.66, R of 0.66. Right. So sports medicine specialists, please help me. Why does FVC correlate so strongly with sporting performance? I've been looking for literature, very scant. Okay. Our conclusion was that higher hemoglobin concentration and more importantly, higher forced vital capacity per kg is what predicted better performance in athletes in this high altitude ultramarathon, and that acute high altitude illness did not occur in this race profile. It could occur. I have heard of one or two person getting a high altitude pulmonary edema during this run, lowlanders, not highlanders. However, in this race, in our subjects, it did not occur. Right. So fine, that finishes my presentation. And I am still wondering as to what is exactly the cause, what determines, what makes the low. See, intuitively, it's very simple to say, ऊपर वहाँ का native है तो जीतेगा ही, वो तो तेज भागेगा ही. But that is not the job. That is not science. Okay, that's over a coffee break. We might be chatting and we might say, of course, he's bound to win. Okay, that is not science. What is it that is different in them? And amongst the lowland runners also, is it that the ones who puff everybody's time correlates exactly with the time in the plains? In a subsequent survey I've done, which I haven't presented here, that doesn't appear to be the case. And it's something that's sort of high altitude wisdom that's been known for many years, that the athlete who's superior in the plains is not necessarily superior at altitude. So it's all about what is making the athlete superior in the plains and what's making the athlete superior at altitude. As sports medicine people, you know the physiology of exertion, of running, of exercise. The entire chain, not only from the lungs to the mitochondria, but also mental drive or psychological drive, our economy of running, biomechanics, in other words, anthropometry, etc., etc. All of these things are involved. Gentlemen, from my little work in the field of sports medicine, I've done a couple of other studies also. I have begun to realize that there is little research. Of course, there is a whole lot of research going on across the world, but in India, there's little effort to bring out, to tease out the threads and decide what is it that's a determinant of performance. Put all these factors together, put all this, make a khichdi, and then say, is khichdi mein nimbu kam hai, is khichdi mein kya dalta aur adrak, namak, whatever, etc., etc. But we need to do that. We need to do that if we are to progress the science of sports medicine. Yes, on the user interface, it's essential to help the athlete, which is what's been happening till now. On the user interface, helping the athlete. But if behind the user interface, there is no backside, and we keep on waiting for everybody else across the world to do the work and tell us, and then we say, oh, low carb, high fat, high carb, low fat, etc. diet, this works, that works, depending on whoever somebody says. Right? No, we are indigenous. We are a different population. As I said, the Sherpa utilizes more glucose proportional to lipid. There's plenty of lipids. Fat is not one thing, as Dr. Preeta Bruckner said. Lipid is not one thing, we know. Right? So my message here is there is a need for great research, and one laboratory that's available to you is the Himalayas. That's a huge laboratory. Please come to the laboratory. We have made some inroads. We'll help you enter that laboratory. Come, join us, do some work there. Thank you.
For the very insightful talk and very interesting. I was explaining things, you are an army person. And I think study the industry has in that also probably study.
Yes, one would have to be there. No, but you don't have to run. You can send your students. You can send your students.
They are running the speed with which they are running.
Sure, I'm sure. See that. Yeah, of course. See, it's an ultra, and they've been given 14 hours to complete 72 kilometers. Out of the first 32, they are given 4 hours, I think, which is the uphill part, the difficult part. But then uphill running is all difficult, but then downhill running, one realizes, is equally or more difficult. It's so taxing on the joints. And again, you people will know the physiology of downhill running is rather tough. No, we did not measure blood pressure in these people because, yeah, I'm sure we've measured it. I just haven't presented it here. There was nothing worth commenting upon out there. Nothing major. Nothing.
One or two questions you can take. Any questions?
Pardon? Resilience. Yeah. Very true, very true. I'm sure resilience has a lot to do with it. We know that even in the low altitude, at low altitude also, athletes' resilience or their lack tolerance, right? Give it whatever name, or their focus or mental strength or etc. etc. You people know those terms better. That all of that helps the athlete perform better, right? But does that explain the 7-hour and 11-hour difference? Or does that explain the difference between the fact that 2 ultra marathon runners who regularly run ultra marathon, none of these guys is a newcomer, regularly run ultras in the plains, come here, one manages to finish within the stipulated 10 hours or 14 hours, even running it within 11 hours, and the other guy just doesn't manage to finish it in the planes that run the ultramarathon at the same time. If I may leave you with, since any more questions? It's over. If there's no question, I'll leave you with a suggestion. Why does cardiac output fail to increase at altitude during exercise? Right? That has been the topic of intense debate and research. The Americans have done an Operation Everest 1, 2, 3. Multiple British groups have gone and all. Of course, we guys have, being what we are, Dev Diwali manate hain. Humne wo nahi kiya research. But the point is, why does cardiac output not increase to peak values at altitude? What causes fatigue at altitude? A person who's fatigued after a run still manages isolated limb exercise to and beyond that level. All these questions, leaving you with them. Yes, rather, let's do some research in detail.
This is one thing. All the best wishes for the benefit course. I think the group is.
Yes, thank you, sir.
Thank you, sir, for your invaluable contributions, and I would also send my thanks to the chairperson for his time and effort. And I would like to invite the chairperson to kindly extend the memento to our speaker. As a token of thanks from the organizers, I would like to present the memento to the chairperson. So we are now proceeding towards our next scientific session, and the next scientific session title is Scheduled Enriched Physical Activity with Nutritional Supplements in Young Adulthood Could Reverse the Early Life Stress-Induced Changes in Cognition and Affective Behavior. And I would like to invite Professor Rajay N. Bhashankar, Department of Physiology, AIIMS, Bhopal, to chair this session, along with Dr. Vijay Das, Professor Physiology, MS Ramaiah Medical College, Bangalore. And and we have with us Professor T. Rao Lakshmi, NIMHANS, Bangalore, to present the session. Thank you.
So thank you for this opportunity. Probably I will be able to give some positive factors which is involved in the individual variations in humans what we see. In today's presentation, I'm going to give you just glimpses of research which we have done in our department on the kind of, I would say that scheduled exercise. It is like how long you have to put subject anyone into the exercise and what are different types of nutrition which can be supplied along with the exercise as a modality to as a treatment modality for the early life stress individual who are when they reach the young adulthood. So this is the topic. Probably I may not be able to cover the entire thing, but I will just give you the at least focus on the exercise-induced changes in the stress-induced changes in the brain plasticity. We use animal model to understand the neurophysiological mechanisms. The one of the model which we chose was the early life stress model. So we being in India or in anywhere else, there are a lot of us show the different types of behavior when we reach the young adulthood or the later part of the life. And some are more vulnerable to some of the environmental factors. It could be subtle changes in the environmental modality. Sorry? What happened? What's happening? This, not this.
This one. Yeah, yeah, yeah. So this is the one, mine. This one. Okay, thank you.
Yeah.
Yeah, yeah, yeah. Mm.
So what we did was we subjected these animals in the early life, and more specifically, there's a stress hyper-responsive period, which we can be before we are weaning the mother from the pups, or weaning the pups from the mother. So this is the model we have adapted, and there is a stress hyper-responsive period. Normally, like humans, first 5 years of life is it is the stress hyper-responsive period. Similarly, in the animals, we have it in the around 2 to 3 weeks of period before the weaning. So it's called the stress hyper-responsive period. So normally this period is very important for the synaptic pruning and the maturation. So everything I'm talking about the neurophysiological perspective. And any adverse experience which occurs during this period, in the early life stress period, like it could be in the humans, it is up to 5 years, or in the animal model, which we use the before weaning. So any adverse experience, so that may enhance the risk for several disorders later in life. And we try to understand what are the abnormalities we see in the different ages of our life. One of the parameters which we looked into the cognitions. So there are different cognitive parameters we have assessed. And secondly, we try to look at the neural plasticity changes in the areas which is important for the cognitive functions. So as physiologists, all of us know that. So whenever any stressful experience activates the hypothalamus pituitary adrenal axis. So as a result, we see increased stress hormone in the circulations. So whether this stress hormone is harmful or it is beneficial. In the physiological conditions, we say it's a eustress. So this stress hormone is important because in order to mobilize the energy during the challenging situation. But if this stress hormone is excessively increased, so what is the consequences of this? And whether the first level, we need to look at the behavior. So that is the parameter we all of us look for, that why someone is showing different types of behavior. One of the effective behaviors which we look at in humans and as well as in the animals is the anxiety-like behavior. So same thing we tested in the animal model. We saw that the animals which are exposed to the early life stress, so they show the increased anxiety-like behavior from the adolescence till the old adulthood. The second, like this, there are several cognitive functions we have assessed, like it could be fear cognition. When you expose them to the classical fear conditioning, they show the fear generalization. So they show increased fear memory and at a generalized effect. So they respond to the, not just only for the specific event, they also show the fear response to the non-specific fear. That's called the fear generalization. Then when we expose them into the spatial learning, like, similar to the route map and other things. So we have the model for that. We have a paradigm to assess them. So like radial arm maze, or it could be water maze. So we use the radial arm maze to understand the extensive changes in the spatial cognition. We found that these animals showed the increased spatial memory. They could learn very quickly. They could also form a memory also very quickly. This looks interesting, right? So then when we looked at the sleep parameters, and we found that the animals which are exposed to stress, they show the increased REM sleep in addition to the increased total sleep time. And this was associated with the changes in the connectivity between the limbic areas. Like we focus here, medial prefrontal cortex, hippocampus, and the amygdala. So there was abnormal connectivity is observed in this. So these are all published. So that's why I'm just giving you, these are the initial observations you had done. And of course, and the hypothalamus, they were very hyperactive during both during the learning the fear memory and also during the fear extinction. So which is not a good sign. So if the infralimbic cortex or the middle prefrontal cortex, if they do not functions during the extinction of fear memory, then amygdalas continue to show the increased activity. So these animals in the hypothalamus, they were more active, whereas in the prefrontal cortex, there was a less activity. As a result, they could be one of the reasons they show the increased fear memory and impaired fear cognition. Then when we looked into the structural plasticity, so by doing the assessing the neuronal architecture in the same limbic areas, and we found that there is an hypertrophy. So there was more number of branches in the amygdala and the less number of branches in the hippocampus and the prefrontal cortex. So that is very clearly says that so impaired fear cognition, or it could be the fear generalization, could be mainly due to the abnormal changes in the prefrontal cortex and the hippocampus. So as a result, the amygdala was not able to regulate their or reduce their function. So they were always hypersensitive to the any kind of fearful environment. So now with this previous findings from our lab, and I'm trying to give one project to one of our students, and here we try to show that, okay, if adrenaline stress causes during SSRP is very sensitive and it causes, and okay, of course, physiologically, we also found increased plasma corticosterone and also we found increased dopamine levels. And we also observed that the delay in the developmental milestone, and that could be one of the reasons for the abnormal connectivity in the limbic circuit, and more specifically the hippocampus, amygdala, and the prefrontal cortex. And we also observed there is a reward circuit is altered. So that data, I'm not going to share that data now. So we also found recently that these animals show the increased risky decision-making behavior. So even under abnormal conditions, like hurtful conditions, these animals, early life stress individuals, they take a risk, an impulsive decision for the non-rewarding objects and also to the rewarding objects. So that is one of the recent observations we found. So then, and we also found that they are highly vulnerable to the addiction. So this data had to be, again, I'm not going to present you that data. So with this previous findings from our lab, we propose that whether socially enriched physical activity, we call it as an enriched environment, in the critical developing age, so whether this could reverse the early life stress-induced changes in the behavior and changes in the behavior, whether it is associated with the changes in the neural plasticity also. As we have seen, the neural plasticity and the behavior was directly correlated. And this is a simple paradigm we use. We expose them to the early life stress during the stress hyperresponsive period. Then we subject them into the enriched environment. It is not throughout the day they are in the enriched house. It is only scheduled time, like it is only between 6 hours for only for 10 days. When we extended the enriched environment, which is scheduled in sun, and that is also harmful, or if it is reduced also, we showed earlier that it was not beneficial. So same protocol we adopted for the stress individuals, and we looked into the majorly today I'm going to present the structural plasticity and the relevant behavior which we are seeing. Okay, so the first thing we looked into the physiological parameters like corticosterone. We saw that immediately after the stress, and we did not see any changes in the behavior corticosterone. Anyway, as you can see in the first graph, so there is no change. Immediately after the stress, we assess the corticosterone. There is no difference between that. So then after some time, like there is an young adulthood or the adolescence, we saw there is in the P30, as you can see here, plasma corticosterone is level. So stress induced changes in the corticosterone is not immediate, rather it is a delayed changes. So you may not see any hormonal changes immediately. Then at the end adulthood, again we saw the differences. It is not increased corticosterone, but rather it is a decreased corticosterone. So at the adolescence, we saw increased corticosterone and dopamine, but at the young adulthood in the late, we saw the reduced plasma corticosterone level. Then we looked into okay, there is an increased corticosterone at the adolescence. Then we checked the anxiety-like behavior to understand whether increased corticosterone is related with the behavioral changes. As you can see here, in the latency, if there is a reduced latency to enter into the anxiety-provoking environment, it indicates that there is a increased anxiety-like behavior because they are comfortable staying in the place like a dark environment for the rodents. It means if they spend more time there, it means more anxiety. If they go quickly, then again it is called as increased anxiety. So that was the observation we made. Then we did expose them into the marble burying behavior because they are rodents. We looked into the burying behavior of these animals. We placed several marbles exposed in the big chamber and allowed them to explore. So if they are highly anxious, they try to bury them. So it could be due to the repetitive behavior, like an obsessive behavior, or it could be due to the increased anxiety. So there is again the direct relationship between that. And we found, very interestingly, we saw increased marble burying behavior. So these animals, when they are exposed into the enriched environment, all the burying behavior has calmed down. So it means it could reverse, enriched environment could reverse the stress-induced increase in the marble burying behavior. Similarly, previously as we saw in the light dark chamber also, we saw the reduced anxiety behavior. Then we also expose them into the open field activity. So allow them to explore in the big environment or the open field maze. So there is no maze-like features, but it's an open field. So they can clearly explore the entire area. There is no dominant and recessive animals. If a single animal is exposed, and we saw that there is a changes in the number of line crossing. It means they explored highly, but enriched environment couldn't reverse them. But if you look into the number of times it enters the central platform, normally anxious people want to sit in the periphery, like even the rodents or humans in a similar pattern. So if they do not have an anxiety-like behavior, prefer to sit in the center or into the not in the periphery. So this is what we observed in these animals also. Enriched environment could reverse the anxiety-like phenotypes in the open field paradigm. Again, similarly, in the plasma corticosterone, we could not reverse completely. So the delayed effect of the increased changes in the corticosterone and the young adulthood could not be reversed by the enriched environment. Then we also look, as I told you, the spatial cognition. So that is, I'm just feeling it, okay. So there is, that could not be completely reversed. And we also looked in the cognitions like attention-like behavior. So using a paradigm like a five-choice interaction time task, there is such a perfect model to assess the attention. So increased attention, increased cognition. So we could see that there is not much effect in this stressed individual, but it could be further enriched environment. It was not completely successful in reversing that. Then we went into the structural plasticity, that is standard neurophysiological parameters using the body screening, and we looked into the hippocampus, amygdala, and prefrontal cortex. Completely, all of them could reverse the structural plasticity which has occurred due to stress, could be reversed completely in all three regions. As you can see here, there is an atrophy in the prefrontal cortex. Enriched environment could reverse with the in the structural plasticity in all three regions. Okay, so the highlights of the study is that unless stress during SHRP impacts of your spatial cognition, anxiety-like behavior, higher cognitive functions such as attention, curiosity, and decision-making behavior, and the stress-induced changes in the HP axis activity and limit circuit was successfully reducing the structural plasticity. And I think this is the first study in India we have done, not only in India. So we could show that there is a structural plasticity occurs and it could be reversed by the scheduled exercise activity. We did a lot of work on that. Probably you can visit our department and you can see the real neurophysiology, what we do, and the state-of-the-art facility. We can record the action potentials in the freely moving animals. We can record the EEG-like changes. We can do the optogenetics, everything, whatever is possible is there in my lab. So you are welcome to visit my lab to understand, and you can stay there for some time. And so take-home message is, enriched scheduled physical activity is beneficial in reversing the stress-induced changes in the limbic and the reward circuit. Thank you. I'm sorry. So smile a lot, cost nothing. Sorry.
Thank you for the very time. From the audience.
Yeah, I'm sorry.
Great study. Just wanted to know how much of this animal studies we extrapolate to.
Of course. So now, for example, if I have to say that early life stage, all of us show the different behaviors. It could be several factors which has occurred during the early life. If you are enriched during the early life stage, and enriched during the early life period, probably you have better cognitive ability. You say some are very smart, some are not smart. Okay, if you look at the spatial cognition,
The same pattern, same
exactly. I totally say that there is completely similarity between animals and humans. Yeah, there are a lot of course, I can discuss for many days about that. There are a lot of experimental evidence. That's the reason morning talk when I heard that. So we have the answers for some of the features, and we physiologists can really explain the mechanisms, and we can also show the evidence. Of course, everything is not possible in humans, but our animal studies are the best one to give a roadmap and how plasticity helps in either the resilience or in modifying our behavior functions. We are not rigid. We are not born rigid. We became rigid, right? So animals are the best example to tell us. Yeah.
Question. The critical period you mentioned is up to 5 years for humans.
In humans, comparable to humans, yeah. So, yeah, because HP axis is normally resilient during that because they are well protected by the mother. So if you withdraw that protect your role, so then it becomes more vulnerable to that stress domain.
Yeah. So thank you, ma'am, for your enlightening presentation, and thanks to the chairpersons for their feedback, time, and efforts. Now I would like to invite both the chairpersons to kindly present memento to our presenter. And as a token of thanks from the organizers, I would like to present the memento to our chairperson.
I welcome all of you for the conference, annual conference, which is scheduled in ESIC Chennai. And this is the annual conference of Association of Physiologists and Pharmacologists of India. It is one of the oldest associations in India established, and by our leading scientists like Dr. B.K. Anand, Baldev Singh, and there are many more laurels. And I welcome all of you for that. I'm sure you will definitely enrich the physiology, science in physiology and pharmacology.
Next, we are heading to a symposium, and the title is Sports Exercise and Performance Sciences, the Way Forward. Sorry, it's a panel discussion, and we have, currently we have the presence on the dais of Professor G.L. Khanna, M. Faridabad, Dr. Meena Dhingra. Dr. Meena Dhingra is not here. Next, we have Dr. Shubhra Chatterjee. She won't be able to join. Okay, then we have Dr. Vani Bhushanam, Sai Delhi, and also we have Dr. Sneha Dr. Snehanshu Adhikari, Sai Kolkata. And as a moderator of the panel, panel session, we have Dr. Anuradha Solan. Yeah.
Need to have more
Yeah.
chairs. The presentation making is just now.
I think we need 3 chairs.
Three chairs. I saw.
Okay, so what is it? Pardon?
Very warm welcome to all of you. I'm Swanky from Sai Delhi. So the panel here is from Sports Authority of India, present and the former. Khanna sir, I would like to introduce, he doesn't need any introduction, but all of you know in the physiology circles, he's been with the Sports Authority of India for a long period of time where he has shaped the sports sciences and very actively participated in the working with the athletes. He has at least about 2.5 decades spent in Sports Authority of India at various positions. And now currently he is the Pro Vice Chancellor of Banaras International University, where he is very actively involved with sports sciences. His love for sports science and working with sports has continued. We are very fortunate to have him on our panel. Welcome, sir, to this deliberations. Next, we have Dr. Vani. Dr. Vani Bhushanam is a sports nutritionist. She has a background, very varied background, working in nutrition earlier before she came into Sports Authority of India. She has MSc, she has done her MSc in food and nutrition. She has a PhD in sports nutrition, and she's also completed a 2-year IOC diploma in sports nutrition. So she has wide experience working with athletes of varied levels, starting from our developmental athletes to our NCOE and the tops. So currently she's working with the shooters, the national elite shooters at Dr. Kani's shooting ranges. She is actually also the core faculty for various education programs that the Sports Authority of India does. The diploma course, sports coaching, and we have a PG diploma in sports nutrition. So she's a core faculty for that. She has a lot of journal publications, almost 25 plus peer-reviewed articles, both in Scopus as well as SportMed index journals. And she has also written a chapter in a book. So academic experience as well as working on the ground with the athletes, understanding the application of nutritional principles for performance enhancement is her forte. Welcome, Dr. Vani, to this panel discussion. And next with us is Dr. Srimunchu Adhikari. He's also working as a scientific officer with Sports Authority of India. His, background in education has been MS Medical Physiology. He also has an MTech in Biotechnology. He has done his MPhil and PhD in Medical Physiology. So he worked as an assistant professor in the Department of Physiology, KMC, Manipal, before joining Sports Authority of India in 2014. So for the past 10 years, he's been actively working. Earlier, he was in Patiala, which is our academic center, as well as, a very high performance center for sports persons training, for various international competitions. And also now he is handling as in charge of sports sciences at Kolkata's Sports Authority of India Center. So he has published more than 29 research papers, some peer-reviewed journals, presented a lot of research papers in many of the international and national seminars and conferences. And actually, is involved more in an administrative and operational part of our schemes, the various schemes that we run, how we do the, evaluations and how we are trying to integrate the sports sciences. So we will be getting a lot of inputs from him on this. Welcome, Dr. Seunji, on this. So, big bit, I would first ask Dr. Khanna. Sir, you have had almost 40 plus years experience at specialized. You have been one of the pioneers exist in physiology because very few, places have educational, courses for training our sports science, people. But Anna belongs to a generation of the first generation of sports physiologists, exercise physiologists. And sir, having worked in Sports Authority of India and having seen the sports scenario all around, you have been very actively involved. So what do you see has transpired in this 4 decades that you have been associated?
Thank you, Dr. Anurada. Anurada is a leading sports psychologist in then we could have found those our colleagues, you are our colleague, various system. And it was really thank you, Nana, for this opportunity. We are working together with those sports sciences and trying to evolve the sports sciences from long back. It is Dr. Ahuja was yesterday here, we were mentioning that where we started. We started from very scratch. There was nothing, only the institute was segment of sports together with the coaches and administrative structure for playing ground, everything was there. But scientific structure was limited to only few chapters of teaching in sports medicine. When we joined in the field of John and say the journalist, that was of the 98, passing of specialized in work is only and when there and then the source was, some of the people were asking what the scientists are doing here. Everything is in the field and what scientists will do here. And we were also not oriented toward these forces, right? That what exactly, but the various and the important political needs were determined that we have to really introduce the sports sciences at par with the other international countries. I only have started, and it was a opportunity was that was Asian Games were coming in my thinking. And that when a lot of changes were coming during that time, and we were part of those changes and we started working with that topic. Getting various equipment also and the work and then doing that time. But the know-how which we developed by reading out some literature as one that we are dependent, we were dependent on the for decades. And we started doing that part implement on our field, assessing in the initial phase with their physiological state of the improvements, recovery, rehabilitation, that we have made a good correlate control whether they will be fitted into this. The OP curve is changing now that they lot of stress and how much stress will increase. Whether we will be able to work in that place and but also in other countries. So there was a lot of research also we started doing on that. And the advantage we got it at that same time, the Germans started coming to us. Germans started sharing with us information. And the history came that purchase same started was sent from excellence. It started with the other accounts of the country also was in these from various, different directions also. Not only for the psychology, bio and training, communication and crime. So we developed this for science in Patiala. And from there we started that yes, there was and people started realizing also the importance of foresight. Even from the academic curriculum, the diversified in the things also that it has to be foresight. Nutrition, in psychology, technology, to talk to people. And we started various programs of the academic program and programs. Because the more problem are coaching, if they don't understand science, it is difficult to introduce science for students. So this MS source are developed so almost on courses on courses. And macro boards, we have that all knowledgeable research projections. So this helps us in thinking of periods and also collaborating with them. Working together and making ourselves. Then they started developing this projects and Bangalore and other places center. Spreading in the garden and other things. Various centers so many have burden. And Asian Games, sports authority of India was reward and a big game they have a lot of time for the it was really fun. It was for letting those solid those that one was the beginning, but the sports science are taken 2-3 times into the pushing. Pushing was one at the initial level before Asia, but I could see the next level was then and we were not getting any medal in Olympics. There was concern the government to take complete preparations. They said we should have given some kind of second. Here we can at least some initiate some methodologies. So then it was in conscious of government of India. And they started that we should develop a strategy 8 years before. Within 8 years, we will get a board that will have the year to follow. So that is started. But we didn't get board that it took on to got. Later on, we started involving various clubs here. Most important stage again was the Commonwealth plan. I was part of stating the committee of Commonwealth. So people also yes. So, other things about that. Rajwan and Prime Minister was very much concerned about it. At that time, the another change was in here one of the task force. Patients were communicating by 2017. This change is called stereo of I was part of my and for my emphasis for the exactly. Other universities in the state government or private. Other medical 46, medical 14 were taken. We were actually like manpower for. There we started master yoga. And neither in our work was the there from we started and how we can and I think still we need to do a lot here. You know, we are up at 6, 7 medals. This year we got only 6 medals. We are fighting for 2026. Then the time limits we see here, it's very bad. Change over the field. The other countries, when we compare here, we see that they are they have started working for 2036, 2034, 38, 36,000. And we are not on the for that. And they take Olympic and side for Olympic. Scientific pressure is how they are in the fight. We have to prepare with all the things. And they involve all kinds of technology. Changes which are coming up, we see in the tradition, but we are not able to. And there are processes going wrong. Take it for granted. Where it should go, we have to really complete it. And that process we have to see from now on. That is how we can really working hard to convince it's all us that it's standard. It has come up under that same government as given us in 2017, and I was part of that. It was the same as well as implement the super government of the and it's said. But they have better news how they have the way for my control. So thank you, Dada, for giving.
Thank you so much, sir. It's wonderful how you gave us the development from your time to now. Of course, it's ever evolving. The field has come up in such a big way. There is something or the other. The development is being shown by the way, like very rightly said, the application is seeing fruits now. The way, like, the theoretical background, whatever we had, now how the same thing is being applied and the acceptance of the athletes to use those, knowledge that is given by the scientific, fraternity is really very heartening to see. And now coming to a very, important component of an athlete's preparation, nutrition. So, Dr. Vani, sports nutrition has evolved rapidly over the recent, decades. And there are personalized approaches and supplementations. A lot of, discussion was there, what to use, what not to use, what gives you, the advantage for an athlete. So, in your view, what are the recent advancements that might change the way we support elite athletes?
Yes, we see the Department of Sport Nutrition, particularly in India, is risen its current form in the recent, I would say, last decade, or probably 50 years from now. Not, so it's a very nascent department in India, particularly. So the advances that we get is from the international literature and evidences that are available. But fortunately, unfortunately, not all those literature is available to our Indian athletes. So we have our own personalized strategy that we pick up, experiment, and in fact, we try to put it to practice. And we have come up with our own solutions to some of them, and we still are in the way to pick up solutions to many of the queries. Of which one is nutrigenomics.
Since when you are taking data from our athletes who were having issues, for example, a recurrent injury over the period of years in looking for competitions in the. I'll give a very recent example of the 2020. Sorry, that's very, very good. One of our athletes, he was trying to achieve a medal. He was in existing medals, the medals to Tokyo 2020. He wanted to compete for 2024. Because of his incessant injuries, he could not. There were a lot of tests that were done, including injuries. And one of which we realized that his absorption, omega-3 access is very good. And omega-3, as we understand, is important for recovery and injury rehabilitation. So we had devised ways and strategized personalized his approach to nutrition because he was allergic to many more things. We did not go for omega-3 supplementation because it was a vegetarian athlete and we didn't want to consume fish oils. So we had to go look for only dietary methods, strict plant-based methods that we could do, and successfully we were able to help him rehabilitate and recover from his injury, and he's won the bronze medal in the recent Paris 2024. So individualization does help. That's from my experience. And the other advances that is coming up is the brain-gut axis. The athletes most often suffer from brain disorders. This is across sports, and most of sports where there's a lot of strength, training, and also in intermittent sports, what we have with the data available with us. So we are trying to individualize each of these athletes. Definitely not gone into currently the microbiome studies of and the gut studies, but yes, we are able to improve on their SCFA content so that it is improving the gut microbiome. This way we are able to help our athletes. That's one advance which we have picked up from the general research as well as from the research abroad. The third one is use of software. Across India, we have a similar software where athletes' data is put in so that whenever the athlete travels, the athlete doesn't need to go for a retest every intermittently. The data and the information is scanned across within to the software. This is why advanced that site does in individualizing the protocols. We also use wearable technology. Currently, we are in the process of using CGM to understand the glucose loads of the athletes to see if during and post-training glycemic load, and also how we do. We are still in the process because it is difficult to use across sports, especially with the ISSEMs. We have tried only at the pilot level, and we will try to continue. We will see good results. However, there are some research which have evidence for carrying CGM to give a better understanding of how the athlete uses battery resource. The one that we currently are using with this plan is the policy that we have come up for our upcoming athletes. It is on a stage where we will first, before introducing as a policy, we will do studies and then go ahead with the policy maybe. So we are in the initial stages or in the advanced that we are looking for in sports science in India, where we have done observation studies. We are doing the restricted stage and we will later on go into the interventional stage, which is planned and headed by Varanasi, who is our head, who is currently heading us. And this is collaboration with ISSEM. So we are looking forward for policy that is strictly based on evidence. So this is one of the huge advances that our site is up with. And with COVID 2020, earlier online consultation was not a hope with us in the nutrition department. And with COVID 2020 years, we started with online consultations. And we have, I particularly have online consultation plan staying abroad, like Germany, where they were long-term then it was some of the transit and they were taking it for over 2 years. And the reason why is the question who was the first Indian to participate and secure a place for a competition like that. So these are some things that we are using in different fields where advances of totally technology, but in different approaches are being taken care of and get us long way to. Thank you. wonderful Vani. I personally know Vani has been involved with a lot of, nutrition, counseling and, diet menus and very particular field where, food plays a very important role in everybody's lives, and athletes are, not anything away from us, and they expect the, especially because they are aiming for a better, results, better performance. There's a lot of emphasis on nutrition as a science to help performance. So now, Dr. Samson, you have been also involved with, our Fellow India testing. Fellow India is a scheme that we have in Sports Authority of India, where we encourage mass participation and the talent is picked up to as a feeder to our main teams. So with the, testing that we have been doing, whether it is Fellow India or we are doing for our NCOE athletes, which is, every twice a year we are doing these evaluations. And we also have tops athletes who are actually the international medal prospects. They are, being given a lot of facilities by the government of India. So all these assessments where we have been doing, thousands of evaluations. So do you feel that, a database for our Indian population is on the way? Keep coming, because it's a very essential that we have our own reference value. So I would like to have your views on that.
Thank you, ma'am. Currently, source authority of doing authority of India doing excellent. Basically, this program we the entire building. The policy not only physiology, it's the branches of 4 sciences. We have nutrition, the sports, psychology, the biology, and composed data, we have a very good thing by the so many systems and we have so every work is very crucial, and once government of India has started very recently the Hello India program, Hello India University, and you all know that many times it has been averaged that we have ISSEMCON, we have set up few of the conditions. How all standardized ACP guidelines means the protocol by which we are assessing the athletes is pan-Indian basis being followed. So, tested in the same protocol. This single kind of protocol, basically, the athlete is 100 meter, will be having a separate protocol, the footballer is having a separate protocol, but that we need to follow pan-Indian basis on the department wise. So, we are having a huge Indian database. So, this database along with the research study what our students, what they have published, these data we have and we have now in a plan of a linear database. So which for our own athletes and which counterpart now can be compared with body time. And not that government of India has started many of the programs, especially the Hello India has developed the constraints across the country because voting to environment पहले नहीं था, वो आजकल काफी जाने जाते हैं क्या Hello India universities are happening here and very frequently, and not only that we are having the TT the TT program, TT assessment is involving many of the athletes, so that we are having more and more type of athletes coming from the school level and very early. So those athletes database we are getting, and these database essential to standardize and calibrate our Indian data pool. And this data pool is very important because once we are going to select the body time in the selection process itself, so this database will be helpful that are south in the early years. Because this is a very crucial part, as you know, the talent hospital scouting in the grassroots level
We are ultimately going to develop based on the training, based on the development support, on the psychological counseling, all the environmental factors we are ultimately on the curriculum. These are depending on our country to the international platform. So these need to be selected very precisely and then on the selection process itself, we are need to standardize for the genetic markers also. In future, probably we could serve the genetic markers. Still, we are in the process. Many of the startup research has come and we are getting collaborating with them, still in the early level. And not only that, you all know, so in the early level, we can calibrate the master cycle time which is very difficult, I know, because you need to have a master biopsy. But now, the advance in the technology, the master spectroscopy is and to assess the master cycle time. And if you can type the master cycle in the early and just select the asset, the glass to be itself and just see that I think should be more to that I also want to say two things. Not only we are assessing, we are also training the assets. We are having working hypoxic chambers. So hypoxic chambers we have set. Currently we are having hypoxic chambers with some high performance centers, especially Bangalore and Sakala. So we are giving the higher to train especially the endurance athletes. In my remarkable enhancement of their performance, it is 0.05 percentile improvement of the performance also being very and the international platform is 5,000 times to enhance. So if you can enhance their performance by these very standard methods, which is not which is standard and which is not under doping or banned methods. So if you enhance those kind of protocols and even normally or the high cables, so these will be very beneficial to the athletes. And basically these athletes they are not in the normal attitude because the normal attitude they are happy and so this kind of thinking approach will be enhanced in future. Thank you.
For the questions, because my next part of the question was that I wanted to ask you, like when you're talking about, training component, how much is wearable technology? Because now I see that our labs, physiological lab is high, technology, very advanced technologies are available. So what is your take on wearables as far as physiology is concerned? What is the role in our performance?
Great, ma'am. That's a very rightly pointed. Nowadays, with the advancement of the technology, we are blessed to get very sophisticated tools, which was not imaginable even just few years back. Now, with a simple mean, you can wear a mean to access your sleep pattern, your heart rate, and your recovery pattern, and this is giving very tremendous data. So you assess how much they are recovered, how many they are recovered, what is their quality of sleep. Because if they are not getting recovered, you know that when they are being very low, or very low must be precipitated and they come back to this time, then the next very low will be precipitated. If they are not completely recovered, then the next very low will be accumulated and the access need to be overtaken or this will be prone for the need. So this kind of things can be prevented if you can assess here a sleep pattern. And not only that, we are having the heart rate monitors and from that you can do the heart rate variability analysis and you can do the high frequency low frequency ratio, sympathetic shifting ratio, and especially for the sugars and others is very remarkably with the ratio. Thank you.
Technology has, advanced or bound its place in every field and sports science is no exception. We are also utilizing in our labs and Sports Authority of India have the best of the latest state-of-the-art technology available. And physiology, as I told you, since Channa sir's time only, it was very much technology oriented. Whatever was the latest at that time, our labs in Bangalore and Patiala had those technologies available for the athletes to be accessed. So thank you, Simon, on that. Coming to Vani again. See, as I told you, nutrition plays a very important role. And seeing that the pervasiveness of nutrition for performance enhancement, what are the challenges that you, as a practitioner, what is the challenge that you have or yourself face in the process?
First, I think every practitioner will have their own load of issues to handle it. Particularly dealing with athletes, it's not easy. Particularly also dealing with more of both the able-bodied and para-athletes. It is tougher dealing with para-athletes than with able-bodied athletes. I should say because I handle both para as well as able-bodied athletes. But probably this is a problem challenge because the nutrition problem is there. Nutrition, so we talk about conservation also supplement is there. So this is one of the prime concerns that we really find because unlearning them is not that easy. They come up with their own mindset, they come up with their own peer solutions, peer-based solutions, own solutions. And when the impact of social media, one of the papers is the impact of social media, where we have concluded as authors that in India particularly, the impact of social media is so high for us to help them unlearn and then relearn. So this is the biggest task that as a practitioner in sports nutrition I am currently facing. But I still continue to this. There comes the limits, which is also aligned with the social media. Limits are there with our based particularly on traditions. But fortunately, we are very diverse and therefore it is very complicated, be it regional differences, systems, and availability. So, limits not of first even difficult because and for them to understand scientific language is not because the moment we don't give them a political understanding or local understanding, hard for them to digest it as first against them with which they want to consider. So this is the biggest challenge that it is. Now with advances in minors, in calculations and the quantification of foods, this is one area that could be a challenge for us, particularly as quantification is a different story. So this is one biggest challenge that we will face, but we try to send recently concluded in Paris 2024 based on the challenges that we saw from the able-bodied competition. So we had sent for the entire competition period where they could snap on because the foods where competitions are arranged totally in both national and international stage is difficult because individual variations and pace differences are a huge challenge that has to be overcome. The way to athletes understand that food in actually I'm very emotional attachment to food. So that's a very big challenge definitely. Very few athletes that we see across probably Virat Kohli and Neeraj Chopra saying that I eat because I have to eat for my performance, but that mindset is probably 0.1% of the entire population that we handle amongst those persons. So starting across grassroots level to developmental to elite athletes, this is the biggest challenge in practicing those constitutional abilities. And one more challenge in the direction that I could see for 2023 Olympics is where we could help psychology department because stress handling is a huge challenge among athletes. And most of the athletes they go to a competition site, but they're not happy with the food. And then the stress along with it. So this is an amalgamation. Probably we would have an integrated approach to see how we could handle stress through food. Probably that would be the biggest challenge for us and also direction for us to see for the upcoming.
Mr. Vani, I know, much more science is becoming interdisciplinary. So sports science is not an exception to this. Understand? You have seen most of the development of sports science departments for you. And now that we are planning to bid for 2036 Olympics, we have at least about 10 years work on this particular interdisciplinary development of sports science. So, sir, from here to 10 years now, what do you see could be worked upon so that we are able to deliver the best kind of sports science to our athletes, given the best result?
Really, and the way forward, how do we go about there? These very target us. Anything is scientific culture around us, where it all the sportsmen just get the basically and about the things. You know, any problem is coming, it's too there with them. Think of that part, the long term, we WhatsApp there, immediate what they can take it on. And the problem with me is the kind of graduates we will get the ball. Whether they need one that acquired knowledge of that sports stage, integrated, and then they will be able to take the floors. So they want information, the innovative approach, creativity, and mind. So we are competing with these values, adaptation, other talents. And Olympics is not an organization of the past. We have to also create those people in the we have to really get those pillars also in streamline and groom them upwards. So then, the continuous video sources, then we can make it for that level. We are not able to do that far right. We take up with them. Only the good person. We have to that is the component of itself. Here we have the backup on that side. We are able to just implement certain sometimes I'll just say but the backup work of that research which they have people are putting in, they are big, if we have a big force is there, just like that part. So those kind of things we need to really make everything at least it's that. So areas for the possibility of I all up and then set the right time and then doing this manage how the big failure how is 1%. Really, really globalize it because it's the global aspect has to be. We also have to work with that globally and bring like this that problem. And in that way, even now there may be stage what I was in the we have the sports intelligence department. All intelligence. I was worried, I was frustrated that one time they do. How I can understand that we got it that getting on that. So it is something making a strategy also and planning for more. And that is what I think from intelligence that how they are studying they are playing for the condition. Where their system is something that they will have and we also for package of the plans required it's still playing as the battle. We focus on all the force of the body champion and not the kids. Get excited. We see, If people suffer to follow from them. Which would have been first say the publishing certificate. Then say in the see also the how we sort out that actually. Whatever was good. Take up those issues also now only student with not the CA. Possibly will be good for all kinds of conflict or landing there. Taking those forward. Part also we understand. Filtering them, just get the information from 41, that is no carbohydrates allowed. Yes, they should not take it and then they get into food from the part. We want to live. Reporting.
So much. Now, just briefly, Dr. Vani will take over as moderator and she will request.
Let's go, I guess.
Such a good, I think you people have to excuse me for that. Dr. Anuradha, she has a PhD in psychology. She joined SAR in 93, so one of her very serious in the Department of Psychology, and currently she is in the department. She is involved in academic research, assessment of athletes, and has been able to intervene with their medical training, having had certifications from German psychologists. And she has had interactions with athletes across, cutting across sports and cutting across levels of competition. This is instrumental in guiding athletes to calm down, stress out, and have that kind of a mind to control the competitions and to deal with stressors. So, to start with, there's been a lot of technology utilization in sports sciences that we are all aware of. What kind of technologies used in sports psychology in particular and athletes?
Sports psychology, so to say, has always been associated with soft skills, like you have to deal with athletes at the mental level, of the mind level. You have to be very, understanding their behavior, interpreting it. So, sports can be, we are also using these kind of, observation and many other technology or techniques that are very familiar in psychology. But when it comes to quantifying, we technology. So in our setup, we have, the VNR test system, which is used for measuring their psychomotor coordination, like the reaction time, attention, concentration, and their, anticipation time. All of these are measurable. So we measure them to understand their current levels and how we can improve them. So that is one technology. Like earlier, what we had equipment were all manual. So I could manipulate. I could say that I just these or but now that is not the case. So computer-based, software-based assessment is available for all of the vertical variables in all across sports. We can measure their, parameters and to rate them. We have systems like the biofeedback, which is again, a technology-based assessment as well as the training module that we use. And we also have equipments, software-based again, to train athletes for attention, how to be attentive. The neuro tracker, which helps athletes to track a few of these, targets in a 3D environment that athletes understands which is relevant target. He has to keep focusing on that. So all the rest distractors, he learns how to overcome the distractions by using these equipment. So it is a high use technology world over. Most of the Olympic athletes and Olympic institutes world over are using this technology. It is a patented technology again. The neuro tracker we are using. We are using an eye-hand coordination trainer. Again, has stimulus. The athlete has to be decisive. The decision-making time can also be measured as well as us. So there's a lot of technology, the recent advancements are being used in sports psychology.
Feedback is a multidisciplinary discipline. How would you use it in psychology for athlete performance?
Yes, so biofeedback is one equipment where we are using for the stress management because when one thing that there is also the visualization, the imagery technique that I mostly use with the athletes to prepare for a competition. Because what happens is that program your mind to the challenges that lie in a competitive situation, your preparedness increases. And when you are prepared, you have a certain level of confidence which helps you in controlling the stress or the anxiety that you feel. So, biofeedback, techniques or this, our training sessions are involved in combination with, the visualization techniques to help them overcome the uncertainty that they may have or the kind of, the odds of anxiety can be understood by the athlete himself. जैसे कि एक swimmer के साथ मैं काम कर रही थी, तो he had a kind of arousal levels the moment his name was called. So he would start becoming so overly, anxious that he was not able to focus. मुझे वहाँ जब starting से मैं पढ़ा हूँ, what is that I need to focus? Everything went haywire for him, and every time when he had association, जैसे मेरा नाम बुलाया जाएगा, मैं गड़बड़ होना ही होना. My timing definitely will be the worst that I can think of in the pool. So we worked with him for about, the techniques that we used were positive self-talk. Every time you are there, just tell yourself that whatever best is possible, I will be able to do that. I look forward, bring that kind of an enjoyment and excitement with that particular event. So all this, hold very well with the biofeedback because the moment is like I would give him a visualization and say that, okay, now your event is about to start, you're going to be there. So उसका हम values देखते थे कि एकदम से it would shoot up. So after the session, we would give him a feedback and say that, this is where your mind is unnecessarily getting into a kind of a educated state. How could you control this? Just say that whatever I'm prepared for, I'm trying to do. That's almost about 3 months to train him. And I ultimately, when he went to his senior nationals, he won almost 7 to 8 medals. So that is how biofeedback with psychology has been able to help us, by understanding the psychophysical, it's both physiological, how to control, like man was saying, controlling the control. So how can you control bodies? I'm not under the autonomic nervous system. How to, monitor as well as change that. So that is how biofeedback is being held and being used and has held them. Yeah, so now I come back to my position back. I just would like to, put in my capsule of whatever discussions we had till now. So starting from the development of sports sciences, very rightly said by Dr. Khanna, because I also belong to not so much of this period, but a little ahead of them. But we have worked together and we have seen the way sports science was made acceptable to the athletes and as well as the coaches, because the coaches 30 years ago were the traditionally trained coaches. It was a huge challenge for us, but we did not stop there. And very rightly, like Kanna sir said, it was integration of all the resources, whatever we had. We had, technological capabilities available there. And then how theory could be put into practice from the lab to the field. That was our emphasis in Sports Authority of India. And whatever, like the MOUs that we had with our foreign counterparts, the Germans, the Russians, it really helped us know what exactly sports science consists of. And from there, we evolved our own, ways of working with the Indian athletes. And one very right, gave us an idea about nutrigenetics, how, nutrition plays a very important role in injury prevention as well as, we tailor-made kind of nutrition, counseling to the athlete, what helps him to perform better. And Dr. Smash gave us a very good, input about the data, the kind of data that is available from his seniors to the current level. How we can use the data and how we can, in the coming years, we are aiming to develop our own norms. Indian norms will be should be put in place. So we are, moving forward. Like from here, I don't see any stopping us from helping us perform better or develop a better athlete-oriented technology or athlete-oriented approach that we always have been focusing upon. And the challenges, as Pani very rightly mentioned, social media. Everybody says ads, at the tip of the Google Baba is available for everything. You can get any kind of information, and athletes mostly believe what they hear is the right thing. So they do not want to go to the specialist. So she has been, very instrumental in making a lot of educational programs, handouts, and whenever we go to the mess area, you can see a lot of educational, information put up there, so that the athlete, whenever he goes there for his food timing, he sees, yeah, ठीक है, इसमें क्या nutritional value क्या है इसका. So subtly, but making an athlete understand the challenges. She's had a very big list. She gave us a very big of them, but she has been, trying address these issues very effectively. And as her very rightly said, from here moving forward, if we are talking about 2036, a lot of research base has to be established so that we understand, like, what nutritional components, whether it's the micronutrient, macronutrient, or what kind of a nutritional input is required for an athlete. And physiologically, the wearable technology has already improved so much. We need to be faced with our foreign counterparts, how to make use of those knowledge, but develop our own, ideas and ideologies to work with our athletes, Indian athletes. So, winding up here, I am very fortunate to have such a wonderful stellar colleagues, mine and my CMOs, Banaras. So thank you everyone for being so knowledgeable and giving us so much of inputs and being given that audience understand the importance of science and where they can expect 2036 India to. Thank you so much.
Again, we on the page, we are still there. We can rather than we-
Now, like they have some chip embedded in them, which could help understand if there's any interesting, efficacy, any hunger something there, something else. So have you heard about this this? Because they are going to many into performance studies are going on. They balance the job imbalances, and because of that, the weight and the posture of the athlete is going to improve. I have heard about this, sometimes anytime this kind of information reach to your ears.
The very important part of this course and history is coming in a big way now. A lot of courses also starting with various scientists. PCI also working in sports industry, state also. So it's ongoing work and maybe this kind of development will be definitely helpful to everyone here. So it's a big challenge, contemporary, the biggest problem for our process. Yeah, I think, and we are working on that, but of course, census is that so also try to incorporate that as.
How many methods to find out all the parameters? Salivary diagnostics is also coming in big time.
So that is, if we go in a bigger way, different way, even up to the Maharani level, people have started investigating and even finding out conventionals for environment. And even various digital part also, we have to also read that here. Our research should not limit to only various studies. So, or I think that doesn't follow us. So the board one person. You should also know that it should not be event of scientific. Level. That is where we are doing some research projects are ongoing all across India. But most importantly, the collaborative effort, the site itself will not be able to take up time. But we can see that diverse fields in various universities, people are taking with the interest of the sciences. Your all information will help us in incorporating this into that streamline. So, then one, the other part is from there to the health and fitness aspect.
There's many questions. Okay, the last one. My questions.
What are there?
So can we take questions in the tea time, with the tea time? Yes, you will ask.
One question.
Okay.
Just for this.
Okay, yeah.
As part of the preparedness, this was, you should not restrict it to one single year. So, for example, if you take the games, see, one is the major problem, we all get, most percentage is the initiative. So sometimes it is not that there is massive, we need, in terms of the sound sensing. So all it can be managed, the field not managed, but they have ability to regenerate. If there anything, which can be done this time as part of the preparedness, how many months, the strength of the muscle, by measuring the motor EMG part, so that you give us the strength of the muscle. If with this many physiological parameters, which can be done very easily as part of the preparedness of the first person.
The diagnostic point of view, it's not only the component on we have the set in the states, but also the does and also the biomechanics. The sources, which is in that aspect also, the EMG and other modalities from you. Even EMG is a very common number. And the patient part of this study.
During any movement, a simultaneous taking they can understand the part of that whether the only one activity also involved in part can be seen. There will be a silence and if they can do one of us is feeling very important. Or even the other eye is said and so everything is important. The whole body has to work at the maximum level. Yeah, so the whole body and the effort of the whole system will the balance of the today we are on that.
Simple, but very nicely you have asked. As the training modalities itself, you are having that very clear micro level because it's a part of adaptation process also. And in this adaptation, if there is more micro level, that can be obviously noted by the EEG, potentials you can find. And our biomechanics counterpart, which is the EEG part, and along with that, for sports medicine, and we have asked that what we do in the rehab process. Now, we are having very recently one P1 medicine specialist who was at that website. We have developed certain tools giving some growth factors, especially in plasma growth factor we have used. And we have very successfully seen that access recovery is very faster after the injury. And one more thing also I want to add, nowadays sports footage of India has also developed that is return to play field. Because injury, we can't neglect the injury. Once we are having a very high level of training program, the injury is a very common part of it. So as soon as we can rehab faster and bring those athletes to come back to the play fields, it is our achievement. So because what we have achieved, the more games the player has been restricted from the play fields, the achievement, the adaptations we are going to improve. So as fast as we can yes, that is for that protocol, we have developed one return to play field protocol, and this is why we have attached the sports medicine and also the specialists.
So, thanks to the team for the enlightening discussion. And now we have with us Dr. Meenakshi Hariharan, Downtown Hospital, Guwahati. She is a sports scientist, expert, and medical microbiologist. And we would like to invite her to present memento to the team of the panel discussion. Yeah. Dr. Meenu Dhingra. Professor Khanna, Professor G.A. Khanna.
Thank you.
Dr. Shubhra Chatterjee. No, she's not. Please, sir. Okay. So, Dr. Vanu. Dr. Sihanshu Adhikari. And to Dr. Anuradha Solan. And we would like that Dr. Meenakshi stays with us because she is the next presenter. And I would like to invite Dr. Nidhi. Dr. Nidhi Gupta, MBBS, MS, OBG, consultant, Women's Sports, Bhopal, to kindly join us for the as a chairperson for the next session. And Dr. Meenakshi shall be talking about including fitness culture in young ones for healthy tomorrow. So over to you, Dr. Meenakshi. Slide one. Slide picture. एक काम से नहीं करना। Slide one. Yeah, we have a ठीक। शुभ्रा का दे दिया
Slide one.
वरुण से बात हुई थी शायद। अच्छा।
Good afternoon, everyone.
Okay, then it is not there.
I know it's a very boring topic when you're discussing about the sports science, and we are discussing about the performance enhancement in sports, the recovery, the rehabilitation, and how to increase the performance, how to maintain the diet for the athletes. But something which we are neglecting is the youth population, the age group between 10 to 24, which is the future generation. Something we are neglecting because we don't focus on them, we don't focus on the nutrition, we don't focus on their physical fitness. And this age group comprises of 24% of the total population worldwide. Considering them to be healthy, we neglect their daily activities. But the risk behaviors they pick up in this age group is somewhat responsible for, in part responsible for the non-communicable diseases or the lifestyle diseases which are on a rise. If we see the evolution of human, we are not supposed to stay inactive. We are supposed to do more work. We are supposed to do more work physically to stay healthy. But with the revolution in science, with digitalization, what we are doing is that instead of using those to enhance to do our work more efficiently, we are replacing the science with our physical activity. We are neglecting the main reason of evolution, and the standard practices with the evolution has become a health hazard for the human. So, can subjective health perception and lifestyle practices of the younger age group can affect the future health? What do you think? It can be interactive session actually. So, do you think that the subjective health perception, because they are considered to be healthy individuals, and the lifestyle practices they are having now, can lead to the health hazards in their future? We know that there are three types of health measures. One is a subjective, which a person feels that whether they are feeling good, they are feeling healthy or not, which is very subjective from person to person, which is different from the objective perception. Objective is what we health professionals see in their blood parameters. We find their problems in health checkup, and that also reflects the functional fitness of an individual. As I have already mentioned, that this age group comprises of 24% of the world population, and this age group has triple burden of health problem. Number one is the infectious disease, which is now coming down because of the immunization programs we have, because of the various medicines we have. And still the injury and violence is more in this group. But something to worry about are the non-communicable diseases, which if we can take action now, this has triple benefit because it will affect their growth and development in this age group. They will help them to have a better life
to work efficiently in their adulthood, and this is also going to help in the next generation. We all know that there are 5 causes of death worldwide: cardiovascular diseases, respiratory diseases, cancers, diabetes, and stroke. So why it is so? Because it don't start at the age of 30 or 40. This is something which starts at the younger age group, and it manifests as diseases in their 30s and 40s, in 50s and 60s. Earlier, this non-communicable diseases were supposed to be at the later part of the age, but now we get a lot of cases in the late 20s, 30s with altered lipid profile, with coronary artery diseases, who are undergoing angioplasty. We are having sudden cardiac arrest, who are having hypertension, stroke, altered sugar levels. It's mostly because attributed to the lack of regular physical activity, which has become pandemic now. And next is the use of excessive social media, then the unhealthy diet patterns, then the substance abuses, then poor sleep quality, then influence of the family and friends. चलो कुछ नहीं होता है, बच्चे हैं हेल्दी है तो खा लो, बच्चे हैं हेल्दी एक्सरसाइज नहीं करेगा तब भी चलेगा, लेकिन नहीं चलता, ऐसा नहीं होता है. So this is something which we as adults, we encourage them to pick up these habits. बच्चों का बर्थडे है तो मैकडॉनल्ड से पार्टी करा देते हैं, बच्चे हैं खा लेंगे कुछ नहीं होता है, वो तो लिपिड प्रोफाइल उनका नॉर्मली रहेगा, उनका शुगर नहीं होगा, अभी डायबिटीज होने का कोई चांस नहीं है. एक्चुअली दिस इज completely wrong. We are the one who are responsible to encourage this kind of habits, and these standard habits have become an health hazard for the future generation. And the most common disorder in India now is overweight or obesity. 1 out of every 5 children is overweight or having the obesity problem, which is hampering his physical development, psychological development, hormonal issues, and everything which is reflecting in their functional inefficiency in the later part of their life. So is modern lifestyle killing us? Yes. Due to the lifestyle we are having, this is increasing the non-communicable or the lifestyle diseases. So these are the lifestyle diseases which I have already mentioned. I'll not go into details. There are, of course, some of the uncontrollable risk factors like age, gender, race, hereditary, which we cannot change, but the controllable risk factors are the modifiable factors, which are on us how we deal with these risk factors, controllable risk factors, which will, even if we are genetically predisposed, we have a strong family history of diabetes, if we have a strong family history of coronary artery disease, we can somehow control these risk factors with the change in the lifestyle. Like we all know that in country like us, we have dual state of malnutrition, like undernutrition and obesity in children. Then management of weight, body weight, most of them are overweight because they are more into carbohydrate diet. Then lack of physical activity, we don't encourage them to have physical activity. मुझे आप घर में ही खेल लो जो खेलना है, अभी पार्क नहीं है, सब जगह पे बिल्डिंग्स बन रहा है, there is construction everywhere, no place, there are no parks, no place to play. तो आप घर में बैठो खेलो, आप वीडियो गेम खेलो या फिर जो भी खेलो, हम काम में जा रहे हैं. Because this is the psychology of Indian parents. Then lack of sun exposure, then smoking, substance abuse. This is the age group and they pick up those substance abuse. Then the alcohol consumption at inadequacy because of the digitalization, because they are more into screen time, the sleep, they have inadequate sleep. So adolescent and younger in adulthood is a period of transition. This is the key period of human development. They undergo rapid psychological, biological changes. There are significant transition in responsibilities and lifestyle. They start having self-perception. They explore their identity, and in this period, they increase participation in the risk behaviors like smoking, alcohol and other substance abuse because they don't have the adequate knowledge of these risk behaviors. So this age group is like a melting pot. They have rapid growth and development, maturation. They undergo physical development. Neural plasticity is more in this group. They have psychological and cognitive development. So they are like the melting pots. So whatever environment we engineer for them, we being adults, whatever environment we give them, they blend to that environment. If we seniors, if the adult portray them the behavior of doing parties every day, lack of physical activity, this is something which they pick up and they follow it throughout their life. So this is somehow they are like the melting pots. We are the one who can develop a safe environment for them to prevent this kind of non-communicable diseases. So the unique challenges faced by young adults are there. The maturation is multifaceted. The rate of maturation is not same for everyone. If we put them in the pressure that the other child is doing this, you also do this. This is not right. So there should not be a bias between them, and we shouldn't force them to do anything. It should be something we shouldn't. There is a difference between what we are forcing them to do and what they can do naturally. If we can make them to create an environment which they like, so they can pick up that behavior very well. But if we force them to do, they will not do. We cannot mix their malleability with the passivity. So we have to do everything in moderation so that they can pick up those behaviors, we can inculcate those habits so that they carry out throughout their life. So the challenges faced in physical literacy is that in few children we push them for the sports, but somehow due to some academic performance pressure or due to some injuries after a certain period of time, they'll end up with they stop playing sports. And in some children, we allow them to pick up those sedentary habits because we don't have time to focus on them. So here the extreme ends are all not good for this. We have to maintain the moderation. So the physical consequences can be in this period, physical inactivity and the social sedentary behaviors. This can have both short-term consequences and long-term consequences. Short-term consequences, what happens if the child is having obesity, he will have less self-esteem. He may suffer from depression, stress, anxiety, everything. Then bullying in his friend, in between his friends, and long-term consequences are like the non-communicable diseases related to obesity, which I have already mentioned. So poor physical fitness can lead to increased mental health challenges and impaired cognitive skill needs for learning. So what is the potential solution? Reshaping a favorable system. So the key components to create an active society, environment, people system are the first and the foremost is the family. Next is the school and the educational system. What we can promote them, we can promote. It has been advised to introduce physical activity for 60 minutes every day in school. So this has been recommended by WHO and it has been recommended by other international standards also that there should be physical activity of minimum 60 minutes daily in schools. And we as parents, we should encourage them to play outdoors. The next is the digital and the social environment where they can be encouraged to have physical activity. And the third is the urban environment. As I have already said, there are a lot of planning where there's lack of space for parks and pocket parks. They can be constructed. So the planning has to be appropriate from the policymakers. And there can be walking tracks, there can be cycling tracks in every area so that they can pick up those habits of cycling, walking, running, and the parks that can be installed with fitness equipment so that they can enjoy and play there. So these are the three key components of the adolescent physical activity system. So inculcating fitness culture in young adults is one of the most important thing to prevent those non-communicable diseases. So what we mean by the fitness culture? Fitness culture is a socio-cultural phenomena surrounding exercise and physical activity. Usually this is related to gym culture or the fitness fashion, which we pick up as a fashion to go to the gym. We love to go to the gym just because हमें अच्छा दिखना है या फिर सब जा रहे हैं इसलिए हम भी जाएंगे जिम. ये हम लोग का एक psychology रहता है. It has been seen in international surveys that 20% of the total adult population attend gym, fitness centers and health clubs. 61% of them have regular exercises. They are doing currently regular exercises. Now, those that are not going to the gym type are 69% will consider to go in the future. But the current need is to change to see the significance of physical fitness more holistically, to encourage the younger age group to pick up this habit at a very young age so that they can have a healthy lifestyle in the later part of the period. So the points are education. We can educate in the school. We can do educate. We can encourage them to play. Then the next is the parental co-participation, parental model. If the parents are picking up these habits, if the environment in their families, like that the parents are eating healthy, they are going to the gym regularly, or they are into the fitness, so there is more chance that their children will take up those habits. And third is the social support and encouragement. So these are the development of healthy behaviors which we can be done. It can be divided into two parts. One is to educate and encourage them for physical activity, and secondly is the development of healthy behaviors like avoiding consumption of alcohol, tobacco, substance abuse, and avoiding eating junk food, sugary beverage. Then we should ensure adequate sleep, 7 to 9 hours per day, and we should also train them to practice meditation. It has been seen that from the age group of 5 to 6, meditations such as transcendental meditations can be introduced to them. It is not a concentration technique. It's just some mantras which are given to them. They can just keep on practicing. Even when they are playing, we can remind them you just keep on saying this. This is kind of a mindfulness. This is a separate topic which I may speak later on, maybe some other time, other day. But then this type of practices can be done for them to practice mindfulness, which we can introduce them at an early age. Then the most important thing is the cardiorespiratory fitness and the strength training. Cardiorespiratory fitness is a physical marker for physical and mental health and academic achievement. So this will help them to have a good cardiometabolic health, preventing premature cardiovascular diseases and academic, and helps them to develop endurance. But the most important is the resistance training and strength training. There is a myth that strength training can lead to injuries, retarded growth, stunted growth, like that. But studies are coming up that this is actually going to help in the growth and development, physically, mentally, and psychologically in the children's. So this is a diagram showing the benefits of resistance training. I am not going to details because we don't have time. I'll just go through it. It improves the overall fitness. It builds muscle strength. It increases the lean body mass. It improves the blood sugar level. It increases the bone density. It enhances the muscle development. Improves the functional quality of the life. Improves hormonal health, and it reduces the risk if someone is also involved in sports. Yeah, I'll just play one video because, yeah, these are some of the functional movements actually which we advise the younger ones to do. So these are some of the studies showing the importance of resistance training, and I'll just show one video which we do in Guwahati. We have encouraged the parents to give their children for the strength training. We are doing them from the age of 6 to 7 years, and we are doing weight training, and we have seen actually the rapid growth in that. And they are these are not athletes. They are not sports athletes, but they are lifestyle athletes, young athletes who are into sport, strength training. And train them. So with this, I would like to conclude my lecture. So it is high time we work for the younger generation because we all know that lifestyle disease is on rise and we are heading towards a bad end actually, and which is taking our evolution to dead end. So we have to work on this. That's the need of the hour.
Highly specialized for long-term development targets will be which age is appropriate for highly specialized.
See, you can start the weight training from the age group of 7 to 8 years. Right?
What stage, not extended, highly specialized, game which years, which highly specialized 7 to 8 years. For weight training or any
Olympic lifting also. Olympic lifting and the movement part. It's the Olympic so this kind of
person technique about younger adult, younger care, which techniques are appropriate for younger.
gradually and
And this cycles, they are the melting, they are at the melting point. If they begin better, they will proceed better. I think,
Yeah, so thank you, Dr. Meenakshi. And I would like to again add one thing I would like to add here. It's like we have heard and people saying and parents saying that don't send children to the for that strength training because that will affect their growth, like and all. Yeah, it's a myth.
actually, the first thing you have to consider is whoever is training them, they should have a certification. They should be experienced enough to teach the younger ones. They should be trained for that. And secondly, their program is very different. They shouldn't go for overloading and overtraining. They shouldn't be given more loads. They should work on increased repetition of workouts with lesser loads so that they develop the techniques, and we should focus on the technique and the rest
Right
recovery.
form.
Yeah, right form and
It has nothing to do with the linear growth of the children.
injury. That only can prevent
The growth.
there is injury in the epiphyseal plate. But if we have the workouts are programmed in such a way that they don't go for overloading, it is not advisable. We don't advise children to do bulking. We are concentrating on developing the strength in them,
Not the volume.
not the volume. Not the volume is also not possible because the testosterone level is not enough to have the muscle bulk. But the thing is, we should concentrate on developing the strength, which can be developed by younger age group, similar to the adult. But because we have to concentrate on the younger, we have to make the program in such a way so that we don't overload them, we don't overtrain them, and they should get efficient rest. We should concentrate on the nutrition.
Nutrition,
Everything as a whole can give a good rapid growth and development, and they can do the motor skills more efficiently. They can have the cognitive behavior. They can develop the cognitive behavior. See, everything is functional. We have to deal on the functional lifestyle. So if the child is an obese one, he will also have restricted functional mobility. So everything has to take, we have to take into account every aspect, be with the younger age group.
Yeah, thank you so much, Dr. Meenakshi, and thank you for the enlightening discussion we all have had here. And I would like the chairperson to kindly present the memento to our speaker. Yeah, as a token of thanks, I would like to present the memento to the chairperson. So ECG in health fitness. This is the topic of our symposium, and we have as a presenter Dr. Senthil Kumar Subramaniam from AIIMS Madurai, and we have next presenter for the symposium as Dr. Saraina Kupuswamy from JIFMER Pondicherry, and Dr. Basanta Manjari Nayak from JIFMER Pondicherry. And I also would like to invite Dr. Arnab Das to kindly come to the dais, chair this session.
Okay.
Thank you. Thank you. So our team is going to speak about EEG and the role of exercise in that. My role is to introduce that. So how I have planned my topic is, I will be going on with how EEG is measured and what are the various ways of looking at an EEG. Then I will say how the exercise affects the EEG, common things. Then it will be taken up by Dr. Saranya, how the EEG is measured in obesity. And later, Dr. Basanta will be talking about how the EEG measurement and effect of exercise in schizophrenia patients. To understand those two upcoming topics, so better to have a basics in EEG. I have prepared it so that even the students can understand. So let us go with that. So I have begun with what is EEG. It is electrical recording of brain activity. So it can be starting from single cell to group of cell, but EEG is surface recording of group of cells. So it is non-invasive. Invasive is also there, but predominantly we are going with non-invasive EEG. So what is the drawback of this? It is a group of neurons are giving signals to that. So spatial resolution is less, meaning spatial resolution is poor of 1 centimeter. Poor meaning it can locate where the signal is coming within 1 centimeter. That is, they are calling as poor. MRI and CT MRI can locate even more locally. Further, for deeper structures, EEG cannot be used. EEG is mainly for cortical structures. Now, few techniques have been developed to identify even the electrical signals from deeper structures. But real-time recording, EEG is the best. So while doing a procedure, if you want to see any changes in the brain, EEG is better rather than MRI and CT, which doesn't have time correlation for that. So spatial resolution is less, but temporal resolution is very high. That's why we are using it for exercise during and after immediately. While during a particular activity, EEG will be a better tool. Moving on to the next. If I have to improve the spatial resolution, what are the things that can I do for? I can increase, okay, the electrode placement, place it correctly in the anatomical position, that is for 10-20 system or 10-10 system. That way we can localize, first point. Second, I can increase the number of electrodes. Second, third, I can go with softwares for localization. That is for Loretta and MNE, I can localize it. Then selection of montages, depending upon that, we can try to localize. So these are the various methods by which we can use EEG for spatial resolution also. As soon as we heard ECG, everybody will start talking about gamma, beta, theta and everything. But when you get the recording, it will be like this. From here, how they are moving to gamma, beta, theta, delta and everything. We want to know about that. So this is a time series signal, meaning in x-axis there is time and y-axis there is amplitude. So red is the EEG which you are getting. Let us take a single EEG. Okay, time is in x-axis and y-axis is amplitude. So what FFT transformation does, each wave can be subdivided into a particularly phased sine wave that can be represented as multiples of sine waves. So if you come back to this blue side, you can see that complex waveforms which are represented in time can be converted into frequency domain. So representing a time domain data into a frequency domain data is called FFT, fast Fourier transformation, and there is a various algorithm for that. Let us not go deep into that. So let us limit this. So we are getting EEG like a time domain, then we are shifting into frequency domain. Nothing but gamma, beta, theta and delta, the range of frequency. So we are converting a time data into frequency data. That's what is done in EEG analysis. But we will not hear about only that. We will be giving power to that. What is the meaning of power? So again, when you look at the power spectral density diagram, x-axis is frequency. So in that, what is the highest frequency in EEG? What we call that? Gamma. Okay. Then will comes your beta, alpha, theta and delta. So highest frequency will be the gamma, the pink one in the last. So if you see that graph which is going down, that determines how much of frequency it has. And otherwise, the amplitude of gamma frequencies is there. That is called as power of that frequency. So x-axis frequency and the power is in y-axis. So this is how it is calculated. Power spectral density is calculated. So this is again trying to explain. X-axis is time and amplitude. This is sine wave. When you are converting into power spectral density, you can see that frequency in x-axis and power in y-axis, the peak is coming in low frequency. Similarly, the green diagram, which has high frequency, when you convert it into power spectral density, the peak is coming in higher one. This is how PSD is plotted. So how the amplitude comes? Now the power comes. It has both same frequency, but the amplitude is different. So in PSD, for less amplitude, the height will be less. For higher amplitude, the height will be more. So this is what the theory behind power spectral density. Those who are well versed in digital signal analysis, there are so many steps in this. I'm trying to break down so that people like me can understand. Okay. Now coming, this is the diagram which you'll be commonly seeing in EEG. What they have actually done is 10-20 system they have taken. At each electrode, what frequency is recorded. Let us take the top left corner. It is delta frequency alone. Okay. And what is the color representing? Color is representing the power now. Okay. So light color is less power, dark color is higher power. Looking at the diagram, nose is in the top, just a little small triangle. So you can say that posteriorly, that is to right posterior. So occipito-parietal region, dark delta is there, meaning high power of delta is in right parieto-occipital region. This is how you look at the topographical EEG spectral analysis. Okay. There are other things, but I don't want to go into this. Now, many people will be talking about coherence analysis. So I just want to give an example for that. What you are able to look in the first diagram, people are dancing. Each one is doing their own steps. If our brain activities are like that, then they are not in coherence. But in the second diagram, they are coordinating with each other. Similarly, if in one area alpha is dominant and the second area there is again alpha, and they are phase matched, then we will call it as coherence. They can be phase matched or there will be a phase shift also, but there should be a time continuation. There are many arguments in that, but this is the simple theory. So alpha coherence, meaning there are two alpha in two different regions. So what is so great about it? Meaning they are communicating with each other. So they are in communication with each other. That will be the basic take home message. So I can see that low coherence indicate independence, high coherence, they are communicating with each other. So like this, we can fix it out. Which electrode is in communication with the other electrode? Based on that, we can say which area is communicating with the other area during a particular activity. Cross frequency coupling, this is just one step ahead. I have told alpha coherence, alpha is found in one part, alpha is found in the other part. Okay. Now, if delta is in one part and you are correlating with the alpha in the other part, then it will be called as cross frequency coupling. So this will be normally happening when you are going for motor control and movement. Alpha will be correlating with the beta bands. Alpha will be generating in the lower level and beta at the cortical level where the motor activity develops. So I'm trying to break down into simpler steps. There are so many things behind it, but this way you can start reading an EEG analysis paper. If you took out an effect of exercise on EEG and start seeing the diagrams and get baffled by it, we don't want to do that. So let us break into these steps so that we can easily understand that. With this, I am moving on. Whenever we are looking at an EEG study, what are the basic things to look for? We will say gamma is increased or alpha is decreased or something like that. So we have to say ECG waveforms affected. I'm talking only about spectral analysis of EEG. There are various methods to analyze EEG. I'm looking only at spectral analysis. Next is what is the brain region affected? If it is frontal, parietal or occipital, that also we have to tell. Why this is important? Because effect of exercise, alpha can increase in one region or decrease in the other region. There will be global analysis of alpha also. So you have to be very, very clear what is mentioned in the paper. Third, how long the last affected? Is it transient or long effect? That is also very, very important. Transient increase in theta is very good for the health, but long-term increase in theta is bad for the health, which is found in schizophrenia and autisms. So you have to be very careful while telling increase or decrease. Taken during rest or during activity. Again, this is important. Why? Effect of exercise they would have measured while during the exercise or after finishing the exercise. Third, they would have recorded EEG activity while during a cognitive performance task also. So we have to be very careful while looking at this. When you are doing an exercise intervention, you have to be very careful what is the type of exercise. Depending upon that, EEG will change. Intensity of the exercise, EEG will change. Depending upon how long the exercise is given, EEG will change. So you have to be very, very, very careful in interpreting the papers. So we have done in, I am very much interested in exercise physiology. So we went with our lab data. We are working with the school students. Immediately after the exercise, what was the effect? We were able to see there was increase in alpha and beta waves, but there was no change in theta and delta. Most papers have reported that also, but we found this. And we are also compared athletes with non-athletes. We were able to find that theta power was reducing in non-athletes at resting period. So this was the observations we observed. Okay. This is one review paper from 2019, which I found it to be very, very useful. They have given studied some 2,365 subjects, more than 50 papers they have reviewed. My studies were before that, so I was collecting it. So if you can just scan the QR code, you will be able to get the review paper. Okay, that is done by Systematic Review article. It is published in Frontiers in Human Neuroscience. I will finish in the next 2 minutes. They have been using this EEG for fatigue analysis in sports person. An increase in delta wave can be considered as the subject is going for fatigue. That is the idea of this diagram. Then for each exercise, the changes in waveforms are different. That's why I told be careful what type of exercise intervention is given. There is the take-home message. Again, a few talks before they were talking about concussion injuries. They are talking about chip kept in the brain. You can take EEG waveforms to find out concussion injuries and rehabilitation for that also using the EEG waves. So this is the future in that. Effect of exercise on cognition also has been done using P3 analysis. So there are various mechanisms described for that. This is my last slide. Enhanced cerebral blood flow and oxygenation, neurotransmitter release, particularly the dopamine and serotonin, and stress reduction and cortisol modulation, and improved neuroplasticity are the mechanisms given for effect of exercise on EEG. Thank you. Let me call upon my next speaker, Dr. Saranya, to speak on the next topic. Thank you.
So, good evening, everyone. So we move on to the next topic on EEG and obesity. So here we will see the electroencephalography in exploring the neural signatures in obesity and then fitness further. So this is in continuation to Dr. Senthil's talk, in which he has given an introduction about EEG and how to look at EEG findings. So we go and we have seen this in obesity, how the EEG changes have been brought out. Obesity, we know that it's a major public health problem. And in fact, in the last 3 decades, obesity has quadrupled. And by 2035, we expect the number to be around 2 billion worldwide. What about the statistics in India? In the last 10 years, it has nearly doubled. And the most alarming fact is around 30% of the urban children are obese. In fact, the Asian cutoff has been reduced in comparison to WHO criteria. Now, is obesity a brain disease? We have talked enough about obesity being a cardiometabolic risk factors, and the cardiovascular risk has been extensively studied. Now, what about the brain and obesity relationship? Now, the recent research has commenced where they are saying about the neurological findings and the changes in obesity. And some of the recent findings from MRI studies, they have found about the reduced gray matter changes and reduced white matter volume, and in fact, reduced cortical thickness. Also, there has been reduced cerebral perfusion, and the cognitive associated regions also, there has been aberrant activities suggestive of reduced cognition and obesity. As EEG has been enough talked, so EEG always remains a dependable tool for studying these neural changes, and these EEG waves have been spoken now. In short, to tell the gamma waves of the EEG band, it tells about the cortical information processing, and it reflects the excitatory state of the brain. The next comes the beta. I'm speaking in terms of the decrease in frequency and increase in the amplitude of each of the EEG bands. The beta, it is mostly seen in the awakened state, and it is involved in logical thinking and conscious processing. The alpha, which is normal, it is also seen in normal awake conditions, but slightly eyes closed state, it is best brought about. The theta, it can be seen in the stage of drowsiness or early stage of sleep, and delta, it is seen in deep sleep. So this is what we expect the EEG in the normal phenomenon. Now, in obesity and EEG, when we looked at the literature, we didn't find much studies on resting state EEG in obese adults. There was only one study, it was done in childhood obesity, and they have found about increased delta and lower alpha EEG waves. So, considering this, we took up the study of studying the resting state EEG in young adult population, comparing between overweight and obese with the normal BMI adult. So we recruited around 88 participants and divided them in 2 groups. The anthropometric measurements and body composition analysis was done.
Further, EEG recordings was done for the analysis of past spectral density of all the EEG bands. Heart rate variability analysis and inflammatory markers were assessed, and then further correlations were derived. So what were our findings? The groups were of comparable age and gender. The anthropometric parameters, as expected, there was a drastic difference between the two groups, and the body fat percentage was higher in the obese group. But significantly, we found that there was a central pattern of fat distribution. In fact, the neck circumference was also higher in the high BMI group. Coming to the EEG findings, now in this picture, as Dr. Sendil had spoke about the spatial resolution. So what you get to know, the color coding here, the darker color, it depicts the less past spectral density. As the lighter blue goes, it is a slight increase, and towards the red, it is the highest past spectral density. So in our finding, we found that in the higher BMI, the delta EEG band was slightly higher in the high BMI. And also in the alpha band, there was a drastic reduction in the high BMI band in comparison to the normal BMI group. In the other bands, though there was an increase of theta and a decrease of gamma, but it was not significant. So this was the finding. So the delta band was found to be high in F3, FZ and F8 electrodes. So we followed the 10-20 pattern of EEG recording. So in these three electrodes, that is mostly on the frontal and central delta past spectral densities was high for the delta. And for the alpha band, it was mostly in the parietal and occipital region that we found the decrease in the alpha. The relative past spectral density also revealed a higher delta and lower alpha. Now, the relative past spectral density is nothing but each of the EEG band is put as a percentage of the total past spectral density. So in that way, again, the percentage of delta was higher and the percentage of alpha band was lower. This finding was incoherent with the study that was done in children. So this reduced alpha, basically it suggests there could be a decreased arousal and vigilance in this obese group. And this higher past spectral density of the delta, it is more seen, such a finding is more seen in adults with depressive disorders. So this finding in this obese group, though they were otherwise apparently healthy, it basically suggested towards a decreased neural processing. Now, what could be the probable link? So the other factors that we could assess here was the lipid profile was deranged. There was a slightly increase in the insulin resistance. The IL-6 was elevated. The leptin levels were slightly high, and the LFHF ratio, which was the marker of sympathovagal imbalance, there was an increase in the sympathetic activity. We also assessed other adipokines, but we didn't get much change in that. Only leptin we found to be significant. So considering this, so the deranged lipid profile, the inflammatory state, and the increase in sympathetic activity could have been a factor in causing this neural changes in the form of increase in delta. So we got some amount of significant associations with the EEG findings also, which could further corroborate with our findings. So the EEG changes that we found in this obesity was probably due to the neuronal inflammation at the level of microglia that happens, and that could be potentiated by the inflammatory cytokines. Probably one of them could be the IL-6, which has been phosphorylated in obesity. Furthermore, the increase in sympathetic activity, insulin resistance, and the adipokine levels could also perpetuate this EEG changes. One finding that was drastic was the level of physical activity. In the high BMI group, the level of physical activity was less in comparison to the normal BMI group. Now, why this becomes significant is the physical activity is always one of a modifiable lifestyle factor, which is most accessible and easily adaptable factor. Therefore, we suggest that physical activity, if at all it is inculcated in day-to-day life, probably even the neural changes can be reverted back, because we know that exercise improves brain health. It acts on all domains of cognition, whether it is concentration, improvement of working memory, spatial memory, or even the cognitive flexibility. And there could be increase in cerebral blood flow, increase in the brain volume, increased neural connectivities, and even structural remodeling can be brought about by exercise on long-term basis. And the previous studies, one study as quoted by Dr. Sendil, though it was about a short-term change where he found an increase in beta waves. Even the regularly athletes were involved in regular intense exercises. Even in them, there was found to be a decrease in the delta power and increase in alpha power. So even long-term exercise can bring about EEG changes, which means it can actually bring about structural changes or even improve the functional connectivity at the neuronal levels. And in obesity, exercise is known to improve cognition. So probably the link could be at the neuronal level. So this study underscores the importance of physical activity or even routine physical activity in the day-to-day life, which can improve upon the neural health. So the implications of our study, the resting state EEG in obesity, it revealed higher slow wave activity, that is delta wave, and a reduced alpha wave activity. And this could be because of the underlying neuronal inflammation. And this EEG change, it signifies about the impending cognitive decline that can happen in this young adult population. And physical activity could be a modifiable factor if at all inculcators can bring about the or even revert this change. These are some of the references, and thank you.
Thank you, Dr. Sharana. It's nice to present the obesity and EEG, and before that also Dr. Shentu nicely how the EEG needs to be done protocol based. So what a clear highlight is this.
So now I invite upon Dr. Basant Manju.
So next time refers to Dr. Basant Manju, it's going to be my country.
Next time. नेक्स्ट है
पहला बंद कर दीजिए
इसको बंद कर दें क्या पहना क्या
नहीं ये नहीं बंद कीजिए
ये ऊपर वाली Yeah.
Good evening, all. First of all, I will thank the organizers to giving me the opportunity to speak on this platform. So my talk is in continuation to other two talks that EEG as a neurobiological correlate in exercise and cognition. So having said about all the EEG waveforms, those are called brain waves which are generated. They are of different frequency, but actually they don't occur in isolation. Rather, they occur in combination. So we know the method how we do a power spectral density assay and then measure the different the power of different spectrums like different frequencies. So these brain waves can get altered in different conditions. So let it be any brain damage, let it be traumatic or ischemic or any neurodegenerative disease or without any damage also if there is functional loss or any psychological disorder like depression, anxiety and schizophrenia. So our study is on schizophrenia we have studied and I have given here some therapy which has, I have studied the cognitive
as well as the EEG spectrum in schizophrenia. So schizophrenia is a disorder affecting primarily the thought and volition and characterized by a spectrum array of symptoms of both positive and negative. The positive symptoms include hallucinations, delusion, conceptual disorganization, and incoherent thought and speech, while the negative symptoms are blunted emotion, social emotional withdrawal, in that there is also cognitive dysfunctions, like there is lack of concentration, lack of abstract thinking. So cognitive dysfunction is almost usually a common feature of schizophrenia, where people usually have been studied that almost all the domains gets affected, mostly the executive functions like attention, working memory, episodic memory, processing speed, as well as the execution of any motor function also. So there are many mechanisms are being proposed, and there are studies which are in supportive for this, that there is reduced brain volume, mostly affecting those areas which are meant for cognitive functions, mostly the frontal lobe, and then temporal lobe, as well as the hippocampus, parahippocampus, dentate gyrus, amygdala. These are the cognitive neurocircuitry. So these are mostly affected, and it has been seen that the dorsolateral prefrontal cortex, which is very, very important for higher degree of cognition, mostly the cognitive processing, the cognitive flexibility and cognitive inhibition. Like when a goal is being given, a task is being given, there is always two alternatives: to go for something or not to go. So no go type of activities. So in those conditions, dorsolateral prefrontal cortex gets activated, and it is being observed in schizophrenia that there is a poor neuronal network in these areas. And along with that, SPECT and fMRI reveals there is reduced blood flow, as well as lower oxygen extraction by these brain areas which are being involved in cognition, as well as reduced glucose utilization also. There is inappropriate neurochemical signaling involving the excitatory inhibitory neurotransmitters like glutamate, dopamine, and acetylcholine. These are excitatory ones, and GABA is inhibitory one. If we see why in our brain we have a excitatory inhibitory balance always, because the excitatory ones are needed for performing an action, a task. While the inhibitory action is needed, there are inhibitory interneurons, though those are mostly GABAergic neurons. They are needed to make it more precise. The task has to be more precise so that it probably there is no distraction, doesn't undershoot or overshoot. So to perform a precise cognitive function, inhibitory circuitry is needed. So if you see in schizophrenia, these inhibitory circuit, the blue ones are excitatory and red is inhibitory. So the excitatory input is there to the inhibitory interneuron, which in turn inhibits the excitatory neurons. So that is being lost here in schizophrenia. So that's why there is cognitive processing gets affected. In our study, what we did did 3 set of cognitive tasks where we measured these scores, and these tasks are this BCST, that is words card sorting test, which is there, in computer. You have different cards to be sorted with respect to the color of the card, respect to the number, or else like it is 5 number or 3 objects, or with respect to the type pattern, whether it is diamond, whether it is depending on the pattern. So there are 5 categories in card sorting. So whether the person is able to perform the categories properly or not, and as well as cursive block tapping test we did. This is here. There will be multiple blue color blocks where randomly one block will change the color and blink as white. The schizophrenic patient has to be asked for clicking that, the one which is changing color. And there is math pro test, which is very simple mathematical additions or subtractions. It has to be done in a series. It appears with a lesser difficulty to more difficulty level. So how many steps they are able to do, the score is decided like that. So these cognitive test battery was done pre and post in intervention exercise. So here for cognitive exercise, cognitive scores, we measured by using the Pebble software. It is a version 2, which is a open access software available. You have to download the software and install in your system. It is very easy. There are instructions also how to perform it. So these are the tests done. So first card sorting test is evaluates the problem solving, decision making and working memory, while Corsi block is evaluates the visuospatial memory, because we have to see which among these blue blocks which one is changing color. So it is with respect to the space, it might change in any quadrant. And then so it is visuospatial memory assessment, while math pro test is memory processing and reaction time it assesses. So in our result, we saw this set of exercise. What we gave is initially we gave a warming up, 10 minutes of warming up exercise, which is aerobic kind of exercise with music they did. And then after that, 5 minutes of rest followed by the cognitive rehabilitation therapy, which includes some pen and paper cognitive tasks, like the trail making test we do usually, like A followed by, in a paper, A4 size paper, it will be randomly written A, B, C, D, randomly. And then 1, 2, 3, 4 also. So they are asked to connect A with 1, and then 1 with B, then followed by number 2. So this is the kind of, they need to have more attentive. So so those are the things we did, and repeatedly we made them do it for 20 minutes. So this way that becomes a mental exercise for them. So that is what we observed, that the Montreal cognitive assessment score we measured, which came to be 18.67 plus or minus 4.6. Usually more than 26 is assumed to be normal. So baseline cognition for the schizophrenia patients was reduced. But on intervention, when BCST was done, BCST in card sorting, we found that they could complete more of the categories based on the number or picture or color. So they could complete more categories after the warming up exercise followed by the cognitive rehabilitation therapy. So we found that reaction time for the correct responses, every time they click the correct responses, that reduced. That means their processing speed is better. They could be, their attention is better. They could perform it very quickly, in compared to their pre-intervention value. And so this suggests there is improved sustained attention, cognitive processing, decision making also, which color, which pattern it is, and also it is improving cognitive flexibility. So this suggests that there might be some increase neuronal connectivity, because we are seeing it after a single session of the exercise. So this could be, there is functional improvement of the neuronal connectivity. Corsi block scores, there we found that improved total score as well as improved number of performances, like how many blocks they could identify. Among, there will be 15 to 12 to 15 blocks will come in random, but how many they could attend correctly. And then math pro test, there is increased correct responses in terms of percentage, reduce incorrect responses, as well as reduced reaction time for the correct responses. So these two suggest that improve visuospatial memory and improve sustained attention and cognitive inhibition as well as decision making. So this proves that there is improvement of the executive task of the executive function of the brain. So similarly, EEG spectrum, when we analyze, there are literatures which has studied the baseline EEG in the schizophrenia patients. So it is found that, as EEG, Dr. Senthil told, it is a assessment, it is a tool to assess the brain activity, whether it is in what state of arousal. So that is what it reflects the neuronal synchronization. So the baseline EEG of schizophrenia patients, they saw the increased activity of slow frequency ranges like delta and theta, while decreased activity of the alpha, beta as well as gamma, which are involved in mostly beta and gamma are involved in higher order cognition. So these are decreased. So this is a known, thing. So there are proposed mechanisms why this would have been there. The increased theta oscillations, the slow oscillations and delta suggest there is reduced brain activity, and which is associated with those negative symptoms like, social withdrawal, and then lack of, incoherence in speech and thought. But reduced gamma oscillation, which is mostly gets generated during higher order of cognitive tasks, like during attention, working memory, or cognitive control, that is being significantly reduced in schizophrenic patients compared to their healthy individuals. So this could be due to loss of synchrony in the brain and loss of the functional activity of the neuronal cells. So there are literature who have done 3 hours of brisk walk per week, which they have seen that there is halting and reversal of the brain atrophy. Moderate intensity of exercise at least 3 times in a week, with each session lasting 30 minutes, is recommended for schizophrenia. Exercise improves these cognitive functions. There are many mechanisms how it improves the cognitive functions. So in our finding, the EEG spectrums, this is a comparison between before and after the intervention which was given. So we found that beta is increased. So you can see here in this, the beta, more red is, increase power. Why? So beta is increase in the frontoparietal of the left side, while also in the right side of the hemisphere in the parieto-occipital region, while gamma is increased only in the right hemisphere. Actually, schizophrenia literally means split brain, means the 2 sides of the brain, 2 hemispheres are not in coherence with each other. So it is being observed during cognitive tasks that only more of neuronal recruitment happens, like changes happens in the right side of the brain, not in the left side. So probably they are deficient in the left hemisphere. So that is how our finding suggest here that there is increased gamma 1. Gamma 1 range, we divided gamma to be 1 and 2 because gamma is more than 30 Hz above beta, 30 to 100. But actually in Indian setup, when we are recording these waveforms, we apply a notch filter, which is 50 Hz, which is our electrical supply, this thing. So that can create a noise. So remove that effect. We selected that to make it into 2 different bands, gamma 1 and gamma 2. Gamma 1 is 30 to 45 Hz. And 45 to 55 Hz we eliminated from our recording. Okay, we applied a filter so that we did not acquire those frequencies. And then above 55 to 70 Hz we selected as gamma 2. So in gamma 1 there is right side hemisphere, there is increased gamma spectral density after those intervention. Similarly, gamma 2 also, right hemisphere showed a significant increase, and that too in the frontoparietal and occipital lobes. So this again suggests that these spectral density of EEG is a marker for improving cognition in the schizophrenia patients. So this is the result summary, what I showed in the picture, that increase absolute power of beta and absolute power of gamma 1, gamma 2 in different regions. But there was no change of delta and theta and alpha, what other studies have observed, but there are very less studies, have been done on EEG spectrum. So from this, what could have been the mechanism? There are studies who have done on only aerobic exercise. There is some improvement of the brain function, but they have not recorded the EEG spectrums. So, but provided the exercise is non-strenuous. Strenuous exercise is a stress to the brain, and it might reduce the the cognition as well as the EEG spectral density responsible for cognitive activities like those higher frequencies. So if there is voluntary physical exercise, it adds on to that. Like many people we have seen, we do regular exercise, we go for a walk, but we are unconscious. We just talk chat among ourselves and walk. We are not conscious of our body parts, that how they are working out. So the conscious exercise again improves better. That is, it has better effect. So the proposed mechanism always is increased neuroplasticity, and this neuroplasticity is by neurogenesis. So let it be exercise in any form, aerobic, in breathing exercises or neurocognitive exercises, mental exercises, they increase neuroplasticity by neurogenesis, synaptogenesis, by modifying the dendrites and by inducing angiogenesis, as well as re-establishing that excitatory inhibitory neurotransmitter balance, re-establishing the lost neuronal connectivity which was seen in schizophrenia. And these are mediated through brain-derived neurotropic factors, neurotropins, synaptophycins in the mostly dorsolateral prefrontal cortex, and synophyllin like mediators which increases neuroplasticity, thereby increasing the neurocognitive actions of the brain. So this is how exercise primes this increase hippocampal, parahippocampal and cortical neuroplasticity by some neurochemical changes. So these are the different mediators what I told. So neuroplasticity is the key of learning and memory. We feel that our brain is always static. It is not like that. It has the scope to improve, and physical activity in any form could be beneficial for this. So mental ability is not a fixed value. Exercise of any type will be beneficial not only for healthy individuals, also in the compromised brain, and EEG can be a marker for assessing the brain activities. So with this, these are few of my references. With this, I close the session. Thank you all.
I request the chairperson to kindly give your concluding remarks. Any?
One question, if anyone has that question, it can proceed to the next.
Okay. So thanks to the thanks to the team of Symposium for the nice presentation, and also I would like to thank the chairperson for his time and effort, and I would like to invite the speakers now to I request Dr. Arnab Das to kindly present memento to Dr. Senthil Kumar Subramaniam,
I can see the TV.
Dr. Saranya Kupuswamy,
That's obesity.
and to Dr. Basanta Manjari Nayak. On the part of organizers, I would like to present the memento to our chairperson. We would now like to proceed to our next scientific session, Computational Biomechanics and Motion Capture, the Way Forward. I would like to invite the presenter, Dr. Kaushik Mukherjee, Department of Mechanical Engineering, IIT Delhi. And to chair this session, I would like to invite Professor Rachna Parashar. She's here. Okay, she's not here. So Dr. Varun Malhotra, Dr. Avinash Thakre, Yeah, so, sir, kindly come to the dais and chair the session.
Dr. Kiran Kulkarni.
Yeah. So I would like to invite Dr. Kiran Kulkarni to kindly come to the dais and chair the session. Yeah. Yeah. Actually, I have been introduced to so many new names. Yeah, a speaker. A speaker. I think the speaker is not there. Huh? Yeah, Dr. Kaushik Mukherjee. So I think the speaker is not here, so we can continue with the next session. We have genetics and epigenetics of sports performance and injuries. Yeah. So we have Vijmendra Kumar Grover, RKMVERL from Havra. And have pronounced your name?
RKM very.
RKM very.
Okay, I'll speak Mandarin.
Okay.
Thank you.
Yeah.
A very good evening to all, and I just would like to ask apology because there was another speaker who was to speak about the epigenetics of sports performance, but he could not come because of some medical emergency. I will be speaking about genetics of sports performance and injury susceptibility. So, because epigenetics is a really large field, and he has the expertise of speaking about that, and he has the previous experience also. So I would not touch upon that. I will be limiting my talk only to the genetics of sport performance and injury susceptibility. So my name is Dr. Vijmendra Kumar Grover. I am working as an assistant professor at Ramakrishna Mission, Vivekananda Educational Research Institute, Belur Met. So as I already told, I will be speaking about genetics of sport performance. So, okay, thank you. So before moving further, I just would like to give a brief about my background. I am a boxing coach and assistant professor. So I am working in the field as well as I am working in the laboratories for some genetic analysis. So the purpose of just delivering this talk is also that I would like to connect with the people who are working in the same field so that we can do some good work. So it is about bridging the gap between the science and the practice. Thank you. So when we talk about the genetics of athletic performance, the study conducted in the 4,488 twin adults, twin female adults, it was found that the variance of the genetics that explains the athletic status, the variance explained for being an athlete is almost around 66%, and remaining variance is explained by the environmental factors which account for the training, nutrition, support, and other things, coaching, and all those. So yes, this was a publication which came in and which bring the limelight of this mutants. You know that this was a child who just born, and immediately after 7 days, it was observed that he had a higher muscle mass than the normal baby, and after 7 months, he had the muscle mass of an individual who is almost around 3-year-old. And after 7 years, he was able to perform so many exercises. This was not about immediately after he was observed, even after some years also. So it was observed that this phenotype did not go away with the age, and he was able to perform the task just like a superhuman. So actually the reason behind this was a mutation in myostatin. When we talk about this mutation, there are different types of variations in genetic genes. So mutations are those variations which account for less than 1% in whole population. Those variations which account for variation in a particular gene in less than 1% population, those are called as the mutation. If they are more than or equal to 1%, they are considered as the polymorphisms. So when you talk about this genetics of sport performance, the first paper came in 1998 in the Nature Publications. That was the gene for a human gene for athletic performance. That actually was communicated by a group of researchers from the UK. They highlighted the ACE gene. What they observed that there was higher frequency of I allele in the mountaineers who were able to go to the higher peaks. So they concluded that this gene may be like provide you an additional advantage in the field of sports also, or the performance also. So later on, the studies were conducted, and so many studies conducted, and most of those studies were of the case control, were of the nature of the case control type of studies. And to summarize those studies, these review articles, a series of review articles was started by the American College of Sports Medicine, the official journal of American College of Sports Medicine, and they published 7 review articles from starting from the 2001 to 2006 and 7. This provide that the purpose of these articles was to map those genes on the chromosome map, that which of these genes are associated with the performance or fitness related parameters or the traits. So, but this was just discontinued after 2007 because those genetic markers were started increasing. The number of genetic markers started increasing, and they could not be like brought in a particular article. So it was becoming difficult for them. So they started another this series of articles in the 2010, and they delimited their scope, and they included they made this the process of reviewing more quality driven, and they just kept they just delimited their search to the performance related, health related, or this exercise and physical activity related phenotypes. Exercise physical activity related phenotypes like exercise behavior, fitness related means like hemodynamic variables or health related fitness, or the performance related means those like cardiorespiratory endurance, power, and all these things. So these 2 series of journals which were started by the ISSEM, this provide a good review of all those initial studies, and after this we can see now we have over the time the number of studies which were conducted to identify the genes associated with the performance phenotypes in the sports have increased, and 253 genetic variants have been found to be associated with the athlete status. Out of these, 115 the markers are associated with the endurance related phenotypes, and 96 markers are associated with the power related phenotypes, whereas 42 markers are associated with the strength related phenotypes. So when we talk about the endurance related phenotypes, those markers are especially those markers which are involved in the blood circulation homeostasis, which are involved in the fuel metabolism, like fat metabolism, or the mitochondrial biogenesis, or and so on. So power related genetic markers were associated with the performance in the speed, reaction ability, or the vertical power production, or rapid force production, and so on. So, and strength related markers focused on the phenotypes which are like maximum strength, endurance, and so on. So you can see, out of all these markers, ACE, ID gene polymorphism, and ACTN3R577X polymorphism were the most prominent genetic markers which have been replicated most of the times across the world. So when you talk about the genetics of sport performance, the heritability of this strength-related phenotypes or power-related phenotypes vary from 49 to 86%. The lower range is for the heritability of lower range is explained by these isometric strength, whereas when you talk about the 86% variance is by the type 2 fiber proportion or the power performance variables. So till now, other than the ACTN3, 45 power related and 42 strength related markers have been found to be associated. So when we talk about ACTN3 gene polymorph R577X gene polymorphism, it is a gene polymorphism which is SNP. SNP, you must have heard about this. SNP, it is the most common name. So SNP, this stands for single nucleotide polymorphism. That means there is some type of variation in a particular base pair at a particular position in the gene. So this actually the conversion of C to T or cytosine to tyrosine thymine will lead to the coding of arginine to the stop codon. And it will lead to the immature production of this or partial production of ACTN3 gene, ACTN3 protein. So ACTN3 protein or alpha-actinin protein actually is found in the fast glycolytic fibers of the human muscles, and it is important for and it is responsible for the speed and power related activities. So those individuals who possess the R allele or RR genotype have been found to be associated or have been found to be like this particular genotype or allele has been found to be beneficial for power and speed related performance, whereas XX genotype or X allele has been found to be associated with the endurance performance. So when we talk about the genetics of endurance performance, the seminal work was done by the Claude Bouchard. They conducted a standard endurance exercise protocol, and the purpose of this standard endurance exercise protocol was to identify the individual difference, the response of the training, and how does that response is accommodated by the individual differences because of the genetics, because of the environment, both. So they conducted this study in the black and white population both, and they tried to monitor the genetic as well as non-genetic marker by conducting interviews or providing questionnaires, whereas the genetic markers they just they just took some samples from those people. So yes, okay, there is injury are the part and parcel of these sports also, and there are two main reasons for injuries, which we categorize these factors of injury into external as well as internal factor. So whenever any individual gets injured, it is because of the interaction of both these. So internal factors, one of those factors is the genetics. So there are some of the markers which have been found to be associated with the genetics of injury also, or the predisposition of injury, or we can say risk of injury. So there are risk versus risk as well as protective alleles which are associated with the injury prevalence in athletic population. So many studies have been conducted, and studies have been conducted in Indian population also. We have in our lab we have conducted the study on the endurance athletes, power speed athletes, and boxers. And the another colleague of mine also conducted the study for identifying the genetic marker with the injury susceptibility for the VEGF protein as well as the VEGF as well as this collagen synthesis protein. So yes, so I would like to come to the I would like to finish my talk in just 2 minutes. So when we see the strength of evidences, if you want to see that yes, genetic markers are there, can we use these markers for the practice, for the talent identification, for the individualization of training program, then we see that the systematic reviews and meta-analysis provide the strongest evidences for the practitioners. So when we see this study was conducted in 2013, and it says that the power athlete had odds of 1.21 for possessing RR genotype. And when we talk about this RR versus X, so if an individual who is power athlete and he has he will have the odds 50% more than a normal individual for possessing this particular genotype if he is power or speed athlete. But again, coming back to the point, so if it is providing these much odds, can we use this for our talent identification and all these things? But the catch is here that whichever studies has been conducted, they have the small sample size. And when we talk about these kind of studies, these are the case control studies or cross-sectional studies. So we require large number of sample sizes if we want to generalize these findings for talent identification or individualization of training programs. So these one marker, if you talk about this only one marker like ACTN3 has provided the consistent result across different populations. So that can only provide us less than 1% of the probability of becoming successful in particular event. So if we want to understand the effect of genetics, we need to understand that genes are not itself. There is interaction of gene with the gene with the environment, and environment also has multiplied to cause its effect on the genetics of an individual. So we need to integrate the epigenetic and genetic to understand the effect, understand the role, understand the performance of an individual. How does genetic is affected by the epigenetic influences? That we need to understand. That can be possible with the help of the collaboration and the collaborations and the research only. So right now, if somebody asks me that can we do genetic testing with the help of these markers, then I will say no, we should avoid these things because currently we don't have the evidences. These studies, when conducted and provide results in hundreds of thousands of people, then we can say yes, these markers can be used for genetic testing for sport performance. Otherwise, they will be misleading. So thank you very much for providing me the opportunity. Thank you.
Quite an eye-opening talk.
Thank you, sir.
Because as you say, a lot of research need to be done on genetic testing. I think still we are in the move to all these things.
We are in infancy.
Any questions from the audience? Thank you, sir. Thank you very much.
Can I access the younger care in analysis? What's lambda? I apply.
Actually, genetic testing is not. Yes, sir.
Can I apply?
No, sir, we cannot apply. That's what I conveyed through this presentation. That right now, whatever the evidences we have, they are not suitable, and if we will be using those evidences for genetic testing, they will be misleading. So we should not apply these things. My area of this curiosity also was from that particular some of the incidences that I heard about, that some companies are doing this testing, genetic testing in some renowned academies. So I thought, is it possible on the basis of single gene that, or not only single gene, variation in a single gene, a particular point, so that can explain that you can become like Superman. And they are saying that this particular gene is polymorphism. This is common population. If that is mutation, we can say yes, that can provide us a competitive advantage. But this is a common polymorphism that cannot provide us success.
This comes into more than even especially gene doping, all these things. You can create superhumans out of this. So it is still under research and ICMR. All these, there are a lot of legal hurdles to come up with gene testing. You know what I mean? So thank you, sir. Thank you very much. It was a nice.
Yeah. So thank you, Dr. Vijmendra, for your informative presentation. And also, I would like to thank our chairperson, Dr. Kiran Kufar Kulkarni, for his feedback and inputs. And I would like now to invite our chairperson to kindly present the memento to our speaker.
Sir.
As a token of thanks, I would like to present the memento to our chairperson. So we are about to start the valedictory function within a few minutes. So kindly stay with us.
लास्ट टेस्ट देगा तो लोग कैसे करेंगे बता रहे हैं बताते डिस्चार्ज
Again, the price up again. Categories.
So,
Pass through categories, batch by batch.
Yeah, ladies and gentlemen, as we come to the conclusion of this scientific session, I stand before you with immense gratitude and appreciation. It has been a privilege to be a part of such an inspiring and engaging scientific session organized under Second International Conference of Indian Society of Sports and Exercise Medicine. First and foremost, I would like to express our heartfelt thanks to our chief guest, Professor Peter Bruckner, Sports and Exercise Physician, Australia, for gracing us with his presence in the conference and enlightening us with his knowledge. We also extend our sincere thanks to the other dignitaries, Professor S.N. Sankhwar, Director, Institute of Medical Sciences, BHU, Professor Ashok Kumar, Dean, Modern Medicine, IMSBHU, Dean Research, Professor Gopal Nath, Professor A.K. Tiwari, Head, Department of Physiology, IMSBHU, and all other faculty members, Brigadier Dr. Vibhu Kalyan Nayak, Director, National Center for Sports Science and Research, SAI, Dr. Siddharth, General Secretary of the Society, President-elect Professor Dobson Dominic, Vice President-elect Dr. Kiran Kumar Kulkarni, Treasury Dr. Gagan Banodhe, and Media Support Dr. Ashe, and senior members of the Society. A special word of thanks to the organizing committee and the volunteers whose hard work behind the scenes has ensured that everything runs smoothly. We also express our deep appreciation to our sponsors and partners for their generous support. Without their contribution, this event would not have been possible. To all our delegates, participants, and attendees, thank you for your time, energies, and efforts. Last but certainly not least, I want to extend my sincere gratitude to each and every one of you for your valuable time, your support, and for your belief in the purpose of this event. Now the much awaited event, and it's a time for declaring the result of the poster and the oral competition winners. So firstly, I shall announce the names of the winners of poster competition in different categories. In category of sports and exercise medicine, the winner is Dr. Vignesh Kumar R. He's from Chetinath Hospital and Research Institute. Dr. Vignesh Kumar. So he is not there. In the second category, that is medical, clinical physiology and biochemistry, the winner is Dr. Garima Sharma from AIIMS, New Delhi. I would like to invite Dr. Varun Sharma to please come on the dais and present the memento, the prize to the winner.
सामने वाले को बुला के निकाल
In the third category, we have that is physical medicine and rehabilitation, neuromuscular medicine, orthopedics and pain medicine. We have Dr. Suman Kumar as winner from AIIMS Bhubaneswar. Dr. Suman Kumar is not here. In the next category, that is the medical and health sciences, we have Nikita Thakur from Department of Cardiology, IMS BHU as winner. Dr. Nikita Thakur? Nikita Mathur? Okay, please come on the dais. And I would like to invite Dr. Gagan to kindly present the prize to the winner. In the next category, that is the physical education, sports, exercise, and performance sciences and coaching sciences, we have Abhijit Basia from Central University of Rajasthan as winner. And I would like to invite Dr. Siddharth to kindly come on the dais and present the prize to the winner. For the next category, biotechnology, bioengineering, and life sciences, we have Anuj Mishra from AIIMS Bhubaneswar as the winner. Dr. Anuj Mishra. So he is also not there. We now shift to the winners results of the oral presentation competition. And we have 6 different categories. To start with, first category is sports and exercise medicine. Winner is Dr. Edwin Joseph from Chettinad Hospital and Research Institute. Dr. Edwin. In the next category, we have medical and clinical physiology and biochemistry. Dr. Vaibhav Maurya. He is on his way to the. Okay, so yeah, we move to the next category: physical medicine and rehabilitation, neuromuscular medicine, orthopedics and pain medicine. Dr. S. Adarsh Singh from RIMS Imphal. I would like to invite Dr. Kiran Kumar Kulkarni to kindly come on the dais and present the prize to the winner. In the next category, medical and health sciences, we have Sanjay Maji as a winner from Ramakrishna Mission Vivekanand Educational and Research Institute. And I would like to invite, so is he here, Dr. Sanjay? He is not, he's coming. Okay, so we can move to the next winner and we can call him later. So in the next category, we have physical therapy and allied sciences and Jayan Kundu from Ramakrishna Mission Vivekananda Educational and Research Institute as a winner. So Jayan Kundu, Dr. Jayan Kundu, he's also outside, so we can call them later. The last category is physical education, sports, exercise, and performance sciences and coaching sciences. And the winner is Mr. Shashwat Priyam Khare from Department of Physical Education, Banaras Hindu University, Varanasi. And I would like to invite Professor Dobson Dominic, the president-elect, to kindly. Huh?
Sanjay Maji.
Sanjay Maji. Okay. So his category was medical and health sciences. Dr. Sanjay Maji from Ramakrishna Mission, Vivekananda Education and Research Institute. And I would like to invite, yeah. So Dr. Dobson is already here. Jayant, because here it is written Jayan. Okay. Jayan is here. So kindly come on the dais and I would like to invite Dr. Vikas Kalasha to please present the prize to the winner. Hey, Mr. Shashwat Priyam Khare is here. So he take who is that? नहीं है नहीं लेकिन कम से कम उसको प्राइस देने तो आना चाहिए. So yeah, we are done with the results and congratulations to all the winners for the oral and poster presentation. And for the concluding remark, I would like to call Dr. Varun Sharma to kindly come on the dais and conclude the ceremony.
Thank you very much, Mr. Parul Sharma. She has been conducting the session for 2 days continuously. And regarding the different prizes, I have no idea who is the winner and who, because I have not gone to this thing. But the thing is, it was conducted by different faculty members, mixture of faculty members, I think. And there was also some tie, there are defense tie. So we have to, in case of that, because we have decided to give only one district for now. In the future, if the scientific committee allows it, then we can consider. So tie things are also there. There's 2 persons are having the same this thing. So depending upon the different topic, what they are chosen and the scientific committee has decided. Like for example, the senior residency, senior resident of AIMS, RIMS was having the highest one. But unfortunately, this competition was only for students. So we have to exclude the senior resident. Senior resident is considered to be a faculty. So in this way, we have to do lots of things. So sorry for that. But this is not the end. Lots of competition will come on, and this is just a motivation. That's all. Okay. So thank you very much to everyone, all the participants, and all the faculty members who have come from different fields, different specialty, different colleges all over the India. And we have from abroad also. So that is a huge success. This is just a second international conference, and the society is very young. Still, we have a huge number of the thing which because earlier when we planned to start a conference, we thought that 50, 100 people may turn out like that. So this big scale we have not. But it's good that our team supported under Professor Josna Kairasia. She has been behind, the woman behind. So she is the one who is organizing everything, background. Because see, we usually neglect the team behind the team. But the team behind the team is the most important. And along with the Dr. Vikas Kairasia, the team of the clinical biochemistry, the team of the clinical pathology, and along with our own department, Dr. Under the leaders, Dr. Parul, Professor Parul Sharma, Dr. Ashish Kumar Gupta, Dr. Atul Roy, Dr. also, Dr. Atul Roy was running here and there. He was out of transportation. He is with faculty from the outside, and part of our family, very important member of part of our family, that is Department of Physical Education under Dr. Pradeep Chan. Sir is involved with us. The benefit of the BHU is our family is large, and Dr. Pradeep has been helping me. How much was the popularity, the way biomechanical workshop was done. It was all organized, and the inauguration also. Along with the Professor Parul Sharma, he has taken the lead to organize the inauguration this thing. So I'm very lucky to have support of such dedicated team with the leadership of Dr. Pradeep, his PhD, all his PhD scholar, and all his friends, Dr. Other teammates. Anshul Mina is there. He is a young PhD scholar, and also PhD scholar from department, PhD scholar from Department of Biochemistry. So everything was smoothly done. So thank you very much for everyone. And I will conclude this session saying that we will have a general body meeting. A general body meeting is for all the members of the society. For any kind of the improvement, for any kind of the suggestion which you want to put it in front of us, feedback session, so that see, it is a continuous process. We are learning, everyone's learning. So depending upon your feedback, we may plan for our future activities. So everyone is invited, all may stay here. You can comment on what can be done, what not done. Yesterday, our executive body meeting was held, and we have few important points which I want to say. The first one is most important is the team leader, the team of the future, the team who will lead this society was voted yesterday, it was decided yesterday. And Professor Dr. Dominic from Department of Sports Medicine and Sports Science, Savita Medical College, has been, chosen to be the president-elect. So if Professor Dr. Dominic is the president, thank you, sir, and congratulations. The next is the post of the vice president. For the vice president, unanimously, Dr. Kiran Kumar Kulkarni, a very senior we are in All India Ball Federation, Sarva Sudan, and we are very lucky to have such a senior appointment with us who can guide each and every aspect. Thank you very much. Then for the post of the General Secretary, I was chosen for the post of General Secretary, so I will be working for the post of General Secretary for another 2 years. So I hope that I will improve many things in the future. This thing, whatever I have, what I have thought of, but I may not be able to, materialize things. I will try to improve for everyone in the next conference or in the next activity of the society. Thank you very much, everyone. And for the post of the treasurer, Dr. Gagan Kumar Banode from AIMS Patna was chosen. And I hope that the financial management will improve under him. ISSEM will grow very much economically under him. And we will have a huge grand conference in the future also with all the delegates, much more than this conference we have. And then we have the media and protocol head. It's not here? Yeah. Okay. No, yes. Dr. Joint Secretary. And then for the post of the Joint Secretary, we have Dr. Siddharth Ondial. Siddharth Ondial is a sports specialist. And she has worked with lots of different teams. And she's an assistant professor in Sports Beauty Center. SIC, there is, UMC and Safdarjung Hospital Delhi. So she will be working as a joint secretary for another 2 years. So under her, let's hope that the society will grow. Then for media and protocol head is very important because each and every activity of society has to be reflected on media, print media, as well as electronic media. For the Dr. Aditya Sood is a sports management. He is working as a consultant in the Sethmore, I think, clinic in Delhi. So he has been chosen as a media and protocol. So this is one. And for the executive body, Dr. Siddharth Unithan. Dr. Siddharth Unithan is the sports and exercise specialist from Kerala. So he will be, in the senior executive member. Under him, the ISSEM has grown from 0 to this level because he was, until now, he was the general secretary of the society, and the way the society was being from the scratch, because we have started only, from few to see. We are able to conduct this much, status of the conference because that is serious. Thank you very much. And the house is open to everyone. And if there is any kind of suggestion, feedback, anything, so the house is open. Mike. Mike, they don't make. Okay, what to give? Oh.
Shashwat Priyam Khare is here with us. The category of physical education, sports, and exercise and performance. For winner of the oral presentation, I would request Dr. Varun to kindly present the prize.